للمجموعة البحثية السعودية في أمراض الدم. يهدف المؤتمر لبحث المستجدات في طب أمراض الدم بفروعه المختلفة. إننا نشهد لله الحمد تطورات هائلة وقفزات نوعية في مملكتنا الحبيبة بقيادة خادم الحرمين الشريفين وولي عهده الأمين في كل المجالات وبالأخص في المجال الطبي من خدمات صحية وتعليمية وأبحاث واكتشافات. ولعل طب أمراض الدم هو أحد أهم التخصصات التي تقود هذا التطور الملحوظ الذي يواكب أهداف الرؤية الطموحة رؤية 2030. في هذا المؤتمر جمع لكم اللجنة العلمية يومين من المحاضرات والجلسات العلمية بقيادة متحدثين عالميين بارعين في مجالاتهم سيأخذونا في رحلة لأعماق التخصص في جدة. أدعوكم للاستمتاع والاستفادة والمشاركة بفاعلية في هذا المؤتمر. Dear guests, chairpersons, distinguished speakers, welcome to the combined SSBMT and SSH annual meeting 2025. Thank you. And now, opening remarks from Prof. Ahmed Ali, the President of SSBMT.
Bismillah, good morning everybody, and again it's a pleasure to be here among colleagues, and thank you Dr. Ahmed again for leading this event and for the SSH for organizing this event. This is the third combined meeting between the two societies, the SSH and the SSBMT, and we're proud to have this collaboration and this association and reducing 4 meetings into one. This is, shall continue for next years to come, and we also wanted to focus and have your input in how to implement the Saudi Group for Hematology Research and how to combine the efforts to excel in clinical research. There will be a meeting coming up here in Jeddah as well, organized by King Fahd Medical Research Center soon, and this will be further discussed. I would also like to invite you to the annual SSBMT, which will be held on May 9 and 10. The annual SSBMT meeting held in collaboration with the EBMT and the ASTCT, showing features and highlights from those meetings. It will be held in Khobar in collaboration with our colleagues from King Fahd Specialist Medical Center Hospital in Dammam. Without further ado, I would like to again invite our chairs to the next first session, and wish you enjoyable and fruitful discussion and programs. Thank you.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Thank you, South Side of Hematology, South Side of Bone Marrow Transplant. It's my honor to be with my colleague, senior colleague, Prof. Fatin. Actually, Prof. Fatin, she is the one who introduced me to the Faculty of Medicine, Department of Hematology. So I have to acknowledge her. It's MPN day, or first session, and we have a panel of speakers from different areas. The first speaker is Dr. Ahmed Al. Dr. Ahmed is from state of Kuwait. He is a hemato-oncologist consultant in Kuwait Cancer Center, and he is really leading the care of hematological malignancy in the country. He is was trained in MD Anderson, where he obtained his clinical leukemia fellowship at MD Anderson. He is the deputy director of the Adult Hematology Fellowship Program at Kuwait Institute of Medical Specialization. He is the president of Kuwait Hematology Association. Dr. Ahmed, we need to collaborate with Dr. Ahmed because last year they had their conference in Kuwait. I planned to attend, but I couldn't, but inshallah I will attend. He is also the Vice President of the Leukemia Lymphoma Society in Kuwait. Dr. Ahmed will address selecting the best first-line therapy in CML. So you don't need to check with ChatGPT. Just listen to the presentation of Dr. Ahmed. Thank you.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله أما بعد I would like to thank the organizing committee Dr. Ahmed Barifah Dr. Ahmed Al-Askar, the group from Jeddah here, for inviting us to speak about the chronic myeloid leukemia, which has I think had tremendous impact in the last 10 years, I would say, or 20 years, and thanks to the chairperson, Dr. Ahmed Beiruti, for his nice words. So I would like to talk about the history first, if you allow me to just have a second on if anyone knows this gentleman.
Moshada Bile?
No, he's Bile of CML, I would say. So this is Melvin man who's a CML patient in 1995, was diagnosed failed interferon, and he had no donor. He was trying to raise funds for donor programs. He heard about the STI clinical trial at MD Anderson, so he traveled to Houston to give the first imatinib, which is called at that time STI, and then he is just now raising some campaigns for CML patients in the Leukemia Lymphoma Society. Therefore, CML is a successful story in the era of hematological malignancy and oncology in general, to a degree that this is from the Swedish registry, and this has been, I would say, a bit old, like in 2008, it was reported. And the relative survival of CML patients who are in chronic phase, who are started on tyrosine kinase inhibitor, has reached to the normal, relatively normal survival of the general population, providing that the patients achieving optimal goals. Now we have a new classification from the WHO as well as the ELN, the International Consensus Guidelines. So the WHO made it very clear, very easy that the CML has two phases. We don't have anymore the accelerated phase. So based on the blast count, you have an advanced stage CML, or you have a chronic phase CML. And they said the accelerated phase definition has been less important in the era of tyrosine kinase inhibitor. However, if we look at the International Consensus Guidelines in 2022, they still have the two classification of accelerated phase, blast phase and chronic phase. But here they try to minimize the definition of the accelerated phase with the bone marrow blast between 10 to 19% and basophil of more than 20%, and in addition to the additional clonal abnormalities. What the NCCN guidelines, they were not happy about the two classifications, so they said here the NCCN would not recommend either the ICC or the WHO classification. And then they will stick to the old criteria that was studied in the most of the clinical trials in the CML era or TKI era. So we have the NCCN guidelines advice for the accelerated phase and blast crisis, and we still use this criteria in our center. And maybe we can hear at the panel discussion about what are the other centers are doing. So I'll start with a quick case, 22-year-old male patient who presented with recurrent ecchymotic patches, abdominal discomfort, and significant weight loss of 36 kg. He was pale with massive splenomegaly and WBC count of 478. You can see the aspirate was consistent with CML in chronic phase, and the biopsy was showing no fibrosis. And the fish here, I put it by the AI, and then the AI put a fish for the fish cytogenetics, and it was positive for PCR-ABL, and the RT-PCR was, the qualitative was P210. So when we come to the risk stratification of CML patients, these are based on the different, I think, eras. So the SoCal was built at the time where the chemotherapy-based regimen was used. Hasford was in the interferon, and the UTOS, which is by the European Leukemia Net, was in the imatinib-treated patients. And if we calculate the risk for this patient, it was intermediate. However, we're now using the ELTS score as per the recommendation of the ELN guidelines, because it has put a less weight on the age, and then we can stratify patients better. So here you can see clearly that when you calculate the ELTS, you can see that the curves are separated nicely. So for this patient who was intermediate by SoCal and Hasford, he is now at a higher risk. Therefore, the ELN recommend the use of the ELTS risk score. The finding of cytogenetic abnormalities at the time of CML diagnosis still confer an inferior outcome in patients, and may expect that this patient might have an advanced stage CML. Not only this, the molecular profiling of CML patients, they might have other mutation in the myeloid panel. And we started initially, when we started the myeloid panel, we did find some patients with ASXL1 mutation, and in this report it was up to 24%, and it did have an impact on the survival. So we have different now tyrosine kinase inhibitor. We have the ATP competitors, the ones that we know, the imatinib, nilotinib, dasatinib, ponatinib, and bosutinib. And we have the new kid in the plot there, which is the asciminib, which is in the red circle, which is acting in a non-competitive way at the myristoyl pocket. Now, choosing the optimal TKI is very important, because we know the nilotinib at the last follow-up at 10 years, we have a 25% risk of cardiovascular event, and can go up to 33% if you're using the 400 milligram twice daily. Not only that, the dasatinib pleural effusion has been reported and has been increasing over time, so you don't need to see it at diagnosis or in the initial phase. So you may see it at 2, 3, 4, 5 years down the line. And choosing the optimal TKI, it has to be weighted based on the age of the patient's comorbidities. What are the goal of this patient? Is it a quality of life? Is it an overall survival? Or is it a treatment-free remission where you need to stop therapy at certain time points, especially in patients who are younger, female? So when we talk about the survival and event-free survival, they're all the same. All the TKI can give you the same overall survival. And when we look at the deeper remission, which I mean here, MR 4.5, you can see that the second generation TKI can do a better job based on the last follow-up of 4 different studies. Now, in the first line TKI, we have 4 drugs that have been approved, and we have 1 that have an accelerated approval, which we will talk about. So the imatinib use at a 400 milligram, the dasatinib use at 100 milligram, but maybe you can use it at 50 milligram, and we have been adopting the 50 milligram in our center with a lesser side effect profile. The asciminib, as I said, it has now an accelerated approval, and it has been also implemented at the NCCN guidelines, the most recent one, as a category 1 classification of using first myristoyl pocket, which is an allosteric TKI, the asciminib in the chronic phase CML. Now we moved from the 4 drugs that we had to the asciminib. Now we have the generics. I think the cost is very important here, because access to TKI is a major issue, especially in our center for the expats patients, and I believe the same here in Saudi Arabia. So having the generic imatinib, generic now dasatinib is being a good option for the patients. So what are the milestones that when you start the patient on TKI, then you have to achieve a 10% at 3 months, have to achieve at least 1% at 6 months, and 0.1% at 12 months. So we usually follow the milestone based on the NCCN, based on the ELN guidelines. And sometimes we have patients like this patient who is 34, CML was discovered incidentally. However, the patient had diabetes, he has dyslipidemia, he has depression. He is on 4 antidepressant or antipsychotic medication in addition to the diabetic medication. So we have to check the drug-drug interaction. So we had to do the homework and checking one by one which is the medication that has the lowest drug-drug interaction. So by ELTS, he is a low risk. Our goal here, I know he is young, but I think the overall survival, given that the limited opportunity to use the TKI is an issue here. So we started him on imatinib, which was having the lowest drug-drug interaction. He achieved an optimal milestone at 3 and 6 and 12 months, as you can see. So here I would just refer you to the different TKI and drug-drug interactions, so just keep it in mind. And I would like to draw your attention and just discuss in details about the role of asciminib in newly diagnosed CML patient. This paper that was published in September last year. So the investigator has led a phase 3 multi-center international double-blinded study, including 400 patients. They were included into 200 in the what they call it the asciminib, and 200 in the investigator-selected TKI. And the investigator will be choosing either it is an imatinib because of the comorbidities, or it is the second-generation TKI. And the second-generation TKI are here the dasatinib at 100 milligram, the nilotinib 300 milligram, and bosutinib at 400 milligram. And they looked at the major molecular response at 48 weeks. So if we can look at the patient's disposition here, they randomized 200 in either arm. So you can see that there is what they call it asciminib imatinib stratum. So those patients, 100 patients out of the 200 asciminib patients, will be compared to the 100 patients with the investigator-selected imatinib treated patients. And there is another asciminib, which is the second-generation stratum, that will be compared to the second-generation TKI in the other investigator-selected trial. So what we see here, if we just look at the imatinib treated patients and the asciminib in general, we can see that the rate of discontinuation due to failure of the imatinib was almost double than the asciminib. And most of the discontinuation was due to either disease progression or unsatisfactory response or adverse events. While when we look at the second generation TKI, we still see a higher incidence of discontinuation, almost 24% versus 17 or 16%. So the baseline demographics between the two groups were comparable, but when you can see here that the older patients, cardiovascular risk score, and we mean here by the Framingham intermediate or high risk, was higher in the imatinib treated patients, and this reflects what we usually do in the clinical practice. So the discontinuation rate was at the range of 18% at the asciminib and 38% in the all investigator-selected TKI, and was more prominent at the imatinib stratum, 48%, 46%, and 30% in the dasatinib-treated patients. So clearly you can see that the rate of discontinuation was higher at the investigator-selected TKI. Now looking at the different parameters here, the early molecular response, which is meant by less than 10%, was higher at the asciminib, again BCR-ABL at 1%, and MR4 and MR4.5. But here we need to look in details because this analysis was done in all selected TKI. So when we look at the imatinib stratum, so the 100 patients who were treated with imatinib, we can see clearly that there is a clear difference between the early molecular response. So when you're trying to select a TKI for a patient with, let's say, higher cardiovascular toxicity or pulmonary toxicity, and you decided to put imatinib, remember that the asciminib here might do better than the imatinib. But if you look at the second generation TKI, and this is the idea here, so you can't see a clear differences between the two comparators. And this analysis was not a primary objective of the study. So again, the deep molecular remission at the 96 weeks, you can see it's very clear at the imatinib treated patients, but it wasn't the case at the second generation TKI. And these are the cumulative incidence of DMR at 48 and 96 weeks. And again, this is when we treat with imatinib, you can see that the curves are separated nicely, but not the case at the second generation TKI. So for the sake of time, I would just put the molecular responses. You can see here it was statistically significant in the imatinib treated patients, but it wasn't significant at the second generation TKI. So further analysis was done on the subgroup patients. You can see in the all investigator selected TKI, you can see that there is a benefit of the asciminib. And this is more clear in the imatinib treated patients, but wasn't the case in the second generation TKI, especially if you look at the low risk ELTS patient. Now, we knew with the TKI that ATP competitor, we can see some mutations down the line. And also with the asciminib, there is other mutations also that is happening at the myristoyl pocket or near to the myristoyl pocket. And these has been the mutations that have been reported. And you can see what are the second line that the patient might receive. So none of them had an ATP, I would say, mutation pendant. So they were able to be treated with the second generation TKI or even the first generation TKI. So safety, you can see with the asciminib, the rate of discontinuation, as we said earlier, it was lower. The grade 3 toxicity was lower. And it was clear that the discontinuation here rate was almost 2.5 times than asciminib. And the dose adjustment as well as interruption was more with the second generation TKI. So the toxicity that we encounter with the asciminib are mainly hematologic, so mainly thrombocytopenia, neutropenia, anemia, GI toxicity, constitutional toxicity, as well as lab toxicity. So here, some of the highlights of the adverse events leading to the discontinuation. You can see that the cytopenia was an issue. Lipase increase was also noted in the asciminib. But also you can see with the other TKI that has discontinued the treatment. Now, some of the adverse events of interest to us, which are the cardiotoxicity. You can see with the imatinib, you have zero toxicity, but with the asciminib, there is a rate of toxicity, but not to the level, I would say, maybe of the second generation TKI. So to conclude, I think in this trial, which are comparing the asciminib to the investigator-selected TKI, asciminib showed a clear superiority in the efficacy with a favorable safety profile in patients newly diagnosed CML. And the direct comparison, as I said, with the second generation was not a primary objective. And with that, I would like to conclude and happy to have any question at the discussion part.
Thank you very much, Dr. Ahmed. The microphone now with my colleague, Prof. Fatin.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه أجمعين. Good morning, everyone. It's my pleasure and honor to introduce Dr. Murtada Al-Khaburi. to the podium in this nice morning. He is a senior consultant in Sultan Qaboos Hospital, an associate professor at Sultan Qaboos University. He's a well-known figure in hematology oncology, regionally and internationally. And he has many and multiple publications in the field of hemato-oncology, over 150 publications in prestigious journals. He's going to enlighten us today about the update in primary myelofibrosis, and at the same time he's going to enrich us about the uses of AI and machine learning in risk stratification, prognosis and treatment selection of primary myelofibrosis. Dr. Murtada.
Thank you, Prof. Fatin, for the introduction, and Dr. Bassem for the introduction, and the organizing committee and the scientific committee for the invitation. Now, I have 20 minutes. So initially when I prepared it, I thought 4 hours, so this is why I put AI. But maybe I will not cover AI much in the presentation, and I'll focus on the other aspects. So in the next 20 minutes, well, I'll try to address updates on prognostic indices of myelofibrosis, and then the role of JAK2 inhibitors as upfront therapy. And then, because most of us would have used ruxolitinib, when ruxolitinib fails, beyond ruxolitinib. And then I'll summarize with an overall treatment algorithm for myelofibrosis. And we will start by a case discussion. So this is a 55-year-old man with chronic anemia for 10 years. And that's important. So he probably had this for some long time, 10 years. He presented to us with aches and pains in both legs. He has family history of a brother with myelofibrosis. Actually, I'm seeing his brother, and that patient was treated somewhere else. And then after a few years of treating his brother tells me why my brother has similar problem in somewhere else. So we brought him to our clinic. When we saw him, he had LDH of 350, hemoglobin of 9.6, and platelets of 250. The spleen size was 19 centimeters. So highly suspicious for myelofibrosis because of that family history as well. We did the bone marrow, which showed variable cellularity in areas reaching 90%, increased megas with tight clustering, and he had some areas of immature myeloid precursors, which is a bad thing in most of the myeloid disorders. And then he had reticulin fibrosis grade 4 with osteosclerosis. And when we look at his genetics, his cytogenetics at that time with the first bone marrow was normal. He had JAK2 positive disease. His brother had CAL positive disease. So, I mean, we can discuss it there. Erythropoietin at that time we did not have, and his blood film showed classical leukoerythroblastic picture with many teardrop cells. So kind of highly suggestive again of, almost diagnostic now of myelofibrosis. So now when you look at whether he would fill the criteria, and you look at the most updated WHO criteria, WHO puts it differently with major and minor criteria. But I tend to do it differently as we think about it. So I start actually with the clinical evidence. And WHO mandates that one of these should be fulfilled in the patient. So either he had a large spleen, anemia, high white count, leukoerythroblastosis, or high LDH. So the patient, to just get into the suspicion for myelofibrosis, he had to get one of these, which were called minor criteria in the WHO. And then the bone marrow shows increased megas. That has to show. And then there should be a feature of ATBA, which is important here. And when it comes to fibrotic myelofibrosis, they should have at least grade 2 myelofibrosis and beyond, which our patient had. And then there should be evidence of clonality. I mean, classically, it is either JAK2, CAL, MPL, but you could also use the epigenetic mutations that were found in myeloid disorders like IDH1 and AXL1, because that would also fulfill the criteria. If you cannot show clonality, then you need to rule out all the other secondary causes to be able to get into that criteria, like evidence of clonality. And in our patient, he had JAK2 positive. And in every WHO myeloid disorder, it should not fulfill any other disease as per WHO. Now, when you look at the bone marrow, the one on the right side, this is not his bone marrow, but it shows tight megakaryocytes clustering. It also shows variable cellularity and maybe osteosclerosis. The collagen fibrosis is not evident there. But when you try to compare the myelofibrosis, the fibrotic myelofibrosis, to the new entity, the prefibrotic primary myelofibrosis, the difference between these two is essentially the degree of fibrosis. So to get into the fibrotic myelofibrosis, the patient needs to have grade 2 or beyond. Now, the difficulty here is to try to tease out ET from pre-fibrotic MF. Now, so there is a pointer. I was told I could only see it. No other one could see it. Yeah. So to decrease between these two, this is important prognostically, although they probably would require the same treatment initially, but prognostically it is important to tease these out. And the difference here is the clustering. So in ET, the clustering is loose. The megas are not touching each other. While in prefibrotic MF, the megas are touching each other, tight clustering. So that's one important distinction between ET and prefibrotic MF. The other important distinction is the atypia. So in ET, it is more of mature-looking megakaryocytes, while in prefibrotic MF, the megas has atypia, hyperchromatic, small, fragmented nuclei. So there should be features of atypia. These at least two important features that would tell you whether this is most likely ET and prefibrotic MF. In our patient, he had the one on the right side. So now we've diagnosed the patient, and now we look at the prognostic indices. Now, the first prognostic index for this patient was the IPSS. So IPSS incorporates important clinical variables into the diagnosis, but you can only do it at diagnosis. You cannot repeat it. So in our patient, when he presented to us 10 years ago, technically we cannot apply IPSS in his case to try to diagnose him, or to try to predict or prognosticate him. The next one is the dynamic IPSS. So dynamic IPSS, when it was developed, they incorporated time-dependent variables. That means you can apply it at any time because it's dynamic, and the way they derive it was because of the time-dependent variable. So that includes the same variables, almost the same variables as in the IPSS, but the way it was derived is differently. Now there is something called dynamic IPSS plus, which incorporates the platelets and the transfusion need. The nice thing about it, you can do it at any time when the patient comes, but it does not have molecular testing, and we know molecular testing will be also important. Now, if you include molecular testing, you use the MIPS. So there have been several versions of the MIPS, MIPS 72 plus. Here, beside the clinical, they added mutations. They added imported cytogenetics into the, and these are important, right? So it is important to apply this for a major decision like allotransplant, because it does give you more information about the prognosis of these patients, and to undergo a transplant. And we will talk that transplant has a bad TRM, high treatment related mortality in these patients. Then they developed GIPSS, which mostly include cytogenetics. And I think it is important not to miss the clinical parts. Clinical behavior is important in most of the prognostic indices. Most of the other ones, or all of the previous ones we talked about, are in primary myelofibrosis. If a patient progresses from PV or ET, then we apply MySEC PM as a prognostic indices. Now, let's look at the impact of the driver mutation. So driver mutations are important prognostically. The commonest is JAK2, which is in almost 64 of patients, and the median survival there is about 9 years or so, similar to the MPL, although MPL is much lower. The best is to have a CAL2 myelofibrosis, where the median overall survival is about 17 years. The worst is to have triple negative. This is the good thing. It's only a small proportion, but their median overall survival is very short, 3.2. So driver mutations are important prognostically, but most of our centers would do these driver mutations. The non-driver mutations are also important prognostically. So if you look at the impact of IDH1, EZH2, AXL1, and other modifiers of the epigenetics, it is important prognostically. Now, the way it was developed, you have to have at least 2 mutations to enter the bad prognosis MF. So, but if we can, we should also do this in these patients. Now, going back to our patients, so our patients had a DIPS score of intermediate 2 and DIPS plus of also intermediate 2 at that time. So what we did in his case, because he had symptoms, we wanted to start him on JAK inhibitor. So in the next few slides, I'll talk about the role of JAK inhibitors in myelofibrosis. And I'll try to convince you with the following, that ruxolitinib is really good in controlling symptoms and controlling spleen size. But when it comes to overall survival, I'll tell you my bias, and then we can discuss your bias in the discussion if you want. But this is important because if you think it does not improve overall survival, the way you will adopt it to treat symptoms or spleen if someone is troubled with the spleen. But if you think there is an impact on overall survival, then even patients without symptoms, you will target your treatment goal is improving overall survival. So even without symptoms, you will start ruxolitinib. The trials that establish ruxolitinib is COMFORT 1 and COMFORT 2. And if you look at the outcomes, spleen reduction, 40%, almost 40 to 50% in COMFORT 1. And when you look at, sorry, the other thing, this is COMFORT 1, 24 weeks. But COMFORT 2 at 48 weeks, that 42% became 28%. So that tells you with time, ruxolitinib loses its benefit, even when it comes to the spleen size. And then when you look at the symptoms improvement, 45, 46%. So overall, very good responses to control symptoms and control spleen size. When you look at the toxicity, specifically hematological toxicity, almost 50% or 45, 50% had grade 3 anemia, which is not a small. So many patients will have anemia on ruxolitinib. 13% had thrombocytopenia. So hematological toxicity generally, even higher grade hematological toxicities are common with ruxolitinib. Now going to the story of overall survival, do we really believe that there is an overall survival? So when you look at the updated study, the top curve is the curve that got ruxolitinib, and the other two curves are the group that got best available therapy. Now, whenever you have a crossover, like in this study and the IRIS study of the imatinib, you have an issue, essentially compromising finding an overall survival benefit. So some people would say, well, because there was a crossover, there is no survival, this is why we did not have a survival benefit. But the counter argument is that, I mean, you don't care when do you start, as far as you don't compromise on the survival, whether you started up front or at salvage. As far as you don't compromise survival, you could do that. So that's the counter argument. The other piece of evidence that should improve overall survival is the real world evidence, but the real world evidence had been questioned, the validity of it, which we can discuss later. So in this patient, we started on ruxolitinib. He went into anemia and required transfusion. So we started him on darbepoetin, and then he had his anemia improved to hemoglobin of 10, and then he was transfusion independent for a long time. Platelets were trending down, and the spleen size significantly reduced. Like this, what we saw in clinical trial. The repeat bone marrow showed that he is progressing in terms of fibrosis and in terms of also cytogenetics. He developed 20q deletion, which his brother had at diagnosis. His brother had 20q deletion at diagnosis. So there's something, a common driver between these two brothers. One went into JAK2 pathway and one went into the SCAL pathway. Now, beside darbepoetin, probably the newer entity, although not approved, is luspatercept. So luspatercept has been approved in subset of MDS in thalassemia, transfusion-dependent thalassemia. Here, this is a single arm study in patients who developed anemia because of ruxolitinib, or because because of the disease, no ruxolitinib. And if you look at the responses in terms of transfusion free, only 10% in patients who did not get ruxolitinib, and 27% in patients who had ruxolitinib. So that tells you that there is a difference between mechanism of anemia in patients with ruxolitinib and in myelofibrosis. But overall, there is a little bit of a signal that it may improve anemia in patients with myelofibrosis. The trial that was done comparing to placebo is not yet out. So what happened to that patient? His hemoglobin stabilized, but his platelets trending down. His symptoms were coming back. Was showing blasts in the peripheral blood, and his LDH was going into over 1,000. So clearly progressing. So the next question is, what is beyond ruxolitinib? So beyond ruxolitinib, there are 3 drugs: fedratinib, momelotinib, and pacritinib. We will start with the fedratinib. So fedratinib inhibits JAK1, JAK2 pathway, and it also inhibits FLT3. But it works well. And the trial that showed the utility of fedratinib showed similar results to what we saw with ruxolitinib. Very good responses, 40%, 36%, either in terms of controlling spleen or controlling symptoms. So more or less, it works similarly in patients who similarly to ruxolitinib. This is in patients who were naive to ruxolitinib, but even patients who had ruxolitinib before and progressed, like almost in this study, 66% had ruxolitinib resistance. And the outcomes were also similar in terms of spleen size and controlling symptoms. So fedratinib more or less works like ruxolitinib when it comes to controlled symptoms and spleen size. Momelotinib is the second drug. So momelotinib, besides inhibiting JAK2, it inhibits another pathway called ACVR1. And ACVR1 is important in hepcidin metabolism, and hence it may improve anemia. When you look at the spleen size and symptoms, you see marginal benefit from momelotinib, 26% in patients who were JAK inhibitor naive, and only 7% in patients who had previous JAK inhibitors. So when it comes to spleen size and symptoms, momelotinib is not that great, for sure less than fedratinib. There is a study actually comparing momelotinib to danazol. It was presented, it's a randomized clinical trial presented as abstract in ASCO, and what it shows that when it comes to controlling symptoms, 24% for momelotinib, 9.2% for danazol. When it comes to controlling the spleen size, 23% for momelotinib, 3.1% for danazol. But when it comes to transfusion independence, 31%. So we know that signal is important because it does improve the anemia. And the interesting thing, danazol had a 20% probability of transfusion independence. So don't forget these old drugs, right? They may work in this disease. The last drug I'll talk about is the pacritinib. So pacritinib were compared again in patients who had ruxo before and ruxo naive. Overall, similar to momelotinib. When it comes to spleen size reduction, symptoms reduction, it is marginal. 19% in patients who were JAK naive, and 18% in patients who had previous JAK inhibitors. So relatively small. But when it comes to the anemia, we see a good response. 25% had improvement of hemoglobin in patients who were anemic before. So in summary, patients, once you diagnose patients with myelofibrosis, you prognosticate them. If they are very high risk or high risk, and they are transplant eligible, you take them to transplant. You will need to properly predict what is their treatment-related mortality, because allotransplant in myelofibrosis is difficult. If they are not transplant eligible, see whether you could put them in clinical trial. If there are no clinical trials, you see their symptoms. If they have anemia, you could try the old drugs like danazol. If they fail this, then you could try into the JAK inhibitors. And of all the JAK inhibitors, the 2 that you would recommend are momelotinib and pacritinib, because if they are very low risk, you decide whether you believe in overall survival or not, i.e. if they're symptomatic or not symptomatic. If they are no symptomatic, my bias is there's no overall survival of ROXO or JAK inhibitors generally, so they will not be started on any JAK inhibitors. If they are symptomatic, you go back to the symptoms there, what their symptoms and how you target them. So if they have anemia, you go to momelotinib or pacritinib. If they have symptoms and spleen, you go to hydroxyurea maybe, and then ruxolitinib if they can afford it. If they have only anemia, momelotinib. If they have thrombocytopenia, pacritinib, because pacritinib is approved in patients with platelet count less than 30. If they're low risk, again, asymptomatic observation. If they are symptomatic, you would go back to the anemia. After ruxolitinib failure, if their major driver for failure is anemia, then momelotinib. If their major driver for thrombocytopenia, then pacritinib. But if they're still symptomatic with spleen and symptoms and they're failing ruxolitinib, maybe you could go to fedratinib. And with our patients, we went, because of thrombocytopenia less than 50, we went with pacritinib. And with this, thank you for listening.
Thank you, Dr. Murtada. Excellent presentation. So we will leave the question to the end. We will move now to the next speaker, Dr. Musa Al-Zahrani. Dr. Musa is an associate professor and consultant hematologist at King Saud University in Riyadh, and he is board certified in hematology. He is director of lymphoma board at King Saud University and King Saud Medical University, and now King Saud Medical City. I didn't know. Okay. وميديكال سيتي في برضه كينج سعود ميديكال سيتي الشماسي سابقا. Too many King Saud والنعم. He has special interest, Dr. Musa, in lymphoma and other hematological malignancies. He had multiple publications in esteemed journals like the New England and Annals of Oncology and other mostly in lymphoproliferative disorder. Dr. Musa will address two topics difficult, MPN, that's one thing, and the other one is pregnancy. When you combine these two together, we will see what we will hear. Welcome, Dr. Musa.
Thank you very much for the kind introduction and the invitation. I'm very happy to be here, and this is a very important topic, as you mentioned, because of several reasons. Not only we're dealing with two lives, the baby and the mother, but also there's several risks associated with MPN during pregnancy, whether it is related to maternal health or fetal health. So we'll be talking about initially some background and then discussing the risks associated with MPN and pregnancy. And then the management will basically discuss management before pregnancy, during pregnancy, and then postpartum. So as we said earlier, that these cases are important because of dealing with two lives, but also the cases are expected to be seen more in the clinic. And this is because of many reasons. One is because of the aging obstetric population. So we're seeing older women that get pregnant, and then with older age, we get more pregnancy complications. Also, we improved the diagnostics for MPN as compared to, let's say, 10 years ago. Now we have more sensitive tests to diagnose patients early, whether it's ET or PV or other diagnostics. So we are seeing more cases with MPN nowadays in younger patients in the childbearing age. Also, it was noted recently in several studies that JAK2 can be seen several decades before the initial diagnosis of PV or other MPNs. Unfortunately, we still have lack of randomized trial in this topic. So most of the evidence comes from either retrospective studies or local practice or anecdotal or experience or single center experience, basically. And some of the risk stratification in pregnancy is adopted from antiphospholipid antibody syndrome or other thrombotic syndromes. So we're still lacking a lot of evidence in this topic, but despite that, we'll try our best to. It's not moving. to summarize this topic. So basically, in terms of the concerns, the maternal risk that can be associated during pregnancy with MPN is increased risk of thrombosis. As we know, pregnancy is a risk factor and a prothrombotic state, and thrombosis is a leading cause of death in pregnancy. And this is further increased during diagnosis of MPN for several reasons, including thrombocytosis that can be seen with many of these conditions. There is also increased risk of bleeding during pregnancy related to either treatment or also thrombocytopenia or platelet dysfunction that can be seen, like acquired von Willebrand disease, and also placental dysfunction, and including different phases of this condition, like preeclampsia or hypertensive pregnancy disorders, and also the concern of disease progression of MPN during pregnancy. And the other thing is the fetal complications. So preterm delivery can happen, intrauterine growth restriction, or concerns with teratogenicity with the treatment that we give. Placental insufficiency can be defined with ways, but abnormal or reassuring fetal surveillance could be considered as placental insufficiency, or abnormal Doppler flow velocity that is suggestive of fetal hypoxemia or oligohydramnios, or the birth weight of less than 10 percentile of the gestational age. So we'll start with them when we think about management is the good preparation before pregnancy, so preconceptional issues. One of the question is, does MPN affect fertility? So patients who are diagnosed with MPN, do they have less fertility compared to the general population? This largely remains unknown, again, because of the limited evidence that we have. But from one of the largest retrospective study that included over 1,000 patients, it seems that they have reduced fertility as compared to the general population. So the childbirth rate was reduced by 22% as compared to the general population. And it was primarily driven by the PV patients, polycythemia patients, and myelofibrosis patients. So these two disorders have a decreased risk of fertility as compared to the general population. Patients with ET, essential thrombocythemia, they have similar rates compared to the general population. Again, this is based on limited evidence. The other concern is the treatment that we give for patients with MPN, like hydroxyurea, for example. This could affect sperm motility in men, and it may even affect eggs, although, again, the evidence is limited. So if pregnancy happens, now we're talking about complications during pregnancy. So the live birth rates compared to the general population is also reduced by about 10% compared to the general population. And this is even lower in PV and myelofibrosis as compared to AT. There is a meta-analysis of about 1,200 patients with MPN during pregnancy reported by Mays et al. In the past few years, and it was noted that preeclampsia is the most common adverse complication that can happen. The incidence is about 3%. There is another Swedish age-matched population study of about 342 patients with MPN, and this showed that there was increased rate of preterm birth, 14% as compared to 4% in the control group, and also increased risk of low birth weight, 10% versus 4%, and it was noted that stillbirths are around 1% higher than the general population. Because of these reasons, it is very reasonable that all patients with MPN who are pregnant should be referred to high-risk obstetric clinics. And although this is debated which patient is considered to be high risk, but I think all patients can be considered high risk and be referred to these clinics with increased fetal monitoring, especially after 20 weeks of pregnancy. Now, the other complication that I talked about earlier is the risk of thrombosis and or hemorrhage. So in the meta-analysis mentioned before, the risk of VTE during pregnancy and postpartum is about 2.5 0.5% to 4.4%. So it's a little bit higher in the postpartum. So it's around 3% during pregnancy. And the other study that was mentioned earlier, the pooled incidences was about 1.5%, which is much higher than the general population of 0.1%. The risk of bleeding is also significantly higher during pregnancy, 14% as compared to 9% in the age-matched controls. So both thrombosis and bleeding are of concern. Now, before pregnancy happens, it's very important to plan for it early, including basically whether the patient is willing to be pregnant or not. So the first question is, if the patient is not planning to become pregnant, it is important to avoid estrogen-containing OCP because this increases the risk of thrombosis in these patients. So you may consider alternative ways of contraception, like progesterone-only pill or IUD that is hormonal-free. If pregnancy is planned, then it is important to discuss with patients that the early completion of family size is important because as the patient gets older, the complication gets higher with time. If the pregnancy happens with the IVF, then we can consider VTE prophylaxis during that period until 12 weeks of pregnancy. Now, in terms of risk stratification, we can treat patients according to their risk, whether low or high risk. Basically, aspirin will be used for AT and PV for all patients. If they're on cytoreductive agents like hydroxyurea, this should be stopped 3 months before pregnancy and then switched to interferon alpha. Anticoagulant also should be switched to low molecular weight heparin if the patient is already on anticoagulant. So that is for preconception. Now, during pregnancy, also there are different questions that arises. So what is the role of antithrombotics, so whether it is antiplatelet or basically anticoagulant? So aspirin has been shown in many retrospective studies to be safe, and it is also associated with the lower risk of complications associated with decreased fetal loss in patients with MPN, although it does have a small increased risk of bleeding in pregnancy. But it can be deferred sometimes if you're worried about bleeding. So, for example, patients with acquired von Willebrand disease. So you need to screen for this. And if they have that, you could delay the initiation of aspirin till the 3rd trimester. It is common that patients with MPN during pregnancy, that their von Willebrand actually improves during pregnancy and their platelet count goes down. So then the von Willebrand levels actually improve later on. So you could reinitiate aspirin in the 3rd trimester later on. The dose is the typical dose, 80 to 100 milligram, the lower dose. However, some reports suggest to increase the dose to 150 milligram if there are other risk factors. So risk factors for preeclampsia. If you have 2 intermediate risk factors or 1 major risk factor for preeclampsia, then you could increase the dose to 150, starting from week 13 till 37, so to allow 1 to 2 weeks before delivery to decrease the risk of bleeding. In terms of risk factors, these are the risk factors for preeclampsia. So we have moderate and high risk. So for the moderate, including first pregnancy, maternal age more than 40, pregnancy interval more than 10 years, preconception BMI more than 35, history of previous PE in patient's mother, or multiple pregnancy. So if you have 2 of these, then you can consider high dose aspirin. Or if you have one of the high risk features, including chronic diseases like diabetes, hypertension, chronic kidney disease, or previous hypertension during pregnancy, or history of antiphospholipid antibody syndrome. So if you have one of the high risk or 2 of the moderate, then you can consider higher dose aspirin. In terms of prophylactic anticoagulant, the risk of bleeding because of the prophylactic doses is estimated to be low at 0.5%. So if you want to prevent thrombosis, you need to weigh risk and benefit of this. And if the risk of thrombosis is much higher than this number, then you can consider. However, if it is similar to this number or less, then there is no point of giving anticoagulant. So the use of prophylactic low mercury white heparin has to be at least 2 to 3 times higher than the 0.5%. So if the risk of thrombosis is estimated to be more than 3%, then for sure you would go ahead with anticoagulant. If it is less than 1%, then you would not, there is no benefit outweighing the risk. So basically, it is not recommended to use anticoagulant in this case. However, if the risk is between 1 to 3%, this is a gray zone, and you have to individualize your decision. Unfortunately, as mentioned previously in the previous slides, the risk of thrombosis in MPN is about 3%, which falls in this gray zone area. This is why it remains controversial whether to give a VTE prophylaxis during pregnancy or not, but it is advised to individualize the decision for each patient. And if there are additional risk factors, so for example, IVF pregnancy or other thrombophilia, then you should give the thromboprophylaxis during pregnancy. Otherwise, it is not routinely given. If you give for IVF, the highest risk of thrombosis happens in the first trimester. This is why it is important to thromboprophylax these patients in the first 12 weeks of pregnancy. But in the second or third trimester, it's less important to prophylax them. For postpartum, it is agreed on that every patient should receive thromboprophylaxis for 6 weeks. So, of course, one of the most important topics to discuss is the cytoreductive treatment during pregnancy. Now, if the patient was already on cytoreductive agent before pregnancy, then of course the indication is clear and you have to continue during pregnancy, but switching from the drugs, whether TKI or hydroxyurea to interferon alpha. But if the patient was not on cytoreductive before pregnancy, then there are additional risk factors that we have to consider during pregnancy. And these are some of them, including a previous history of miscarriages, less than 10 weeks, whether morphologically normal fetus or not, and also the birth of a morphologically normal fetus less than 34 weeks of gestation due to eclampsia, severe preeclampsia, or placental insufficiency. So these are additional risk factors to consider cytoreductive agent. Also, you could consider this for patients with increased risk of bleeding, or patients with acquired von Willebrand, for example, or platelet more than 1 million. You could consider this to try to decrease the risk of bleeding or complication during pregnancy. The cytoreductive drug that is almost always used is interferon alpha. And it is important, of course, to increase fetal monitoring according to the guidelines, whether local or international. An example of this is Saving Lives 3. This is a UK national guidelines that can be followed during pregnancy in these patients. So interferon alpha improves birth rate. It's difficult to tolerate, as we know. It causes flu-like symptoms, headache, and other side effects that can be poorly tolerated. However, the pegylated form is better tolerated and it has longer half-life, and this is probably the preferred agent to use. This is based on, of course, retrospective evidence, and it is not approved by FDA during pregnancy, and it still continues to hold a Class C rating during pregnancy. However, it is commonly used in practice, and this is the drug of choice during pregnancy. If this is discussed with patients and felt that it's still risky to proceed with this, then one option is maybe to hold the drug until reaching the second or third trimester. That is an option. The other options are actually not well studied, so it remains not clearly safe during pregnancy, especially with previous reports of teratogenic effect in animal studies. This includes ruxolitinib or anagrelide, so it's not safe to use them. There is no human safety data exist, unfortunately. The new agent, which is the ropig interferon alpha 2b, the use has been used in some case reports, so still the evidence is very limited with it. In terms of therapeutic phlebotomy for a PV and the targeted blood counts, during pregnancy, we all know that the hemoglobin decrease, partly because of the increase in the plasma volume. So it is important to reconsider the target or threshold for hematocrit in pregnancy. Whether you use the same hematocrit outside pregnancy or not, it's still unclear. But some people recommend to use the normal hematocrit value that is adjusted for pregnancy, adjusted for gestational age. So that is the recommendation. Otherwise, you could use the same threshold outside pregnancy. There is no head-to-head comparison, so it remains unclear. It is important to remember, especially for PV, to try to avoid iron supplementation, since this is a common practice during pregnancy. Now moving to the last section, which is postpartum care. One important consideration is breastfeeding. So both low molecular weight heparin and aspirin are considered safe with breastfeeding. The pegylated interferon alpha, it does go into the breast milk with a very little amount. However, it is poorly absorbed orally by the baby. So it remains safe with lactation. Hydroxyurea is present in breast milk, and it is considered to be unsafe and should be avoided. There is little data exists for other agents like ruxolitinib, anagrelide, or other agents, so it is discouraged to use these. So if you need to use them in the postpartum, if you need to use a cytoreductive agent, then pegylated interferon alpha remains to be the drug of choice. So just to summarize, again, we have to early on think about this and have very good planning before pregnancy, with involvement of a multidisciplinary team like high-risk obstetrics, colleagues from OB/GYN, and also to counsel the patients about the risk, to prepare them with optimizing their counts before pregnancy, whether platelet, hematocrit, etc. And then also to switch them to drugs that are safe during pregnancy at least 3 months ahead of time. For all patients, consider low-dose aspirin, and also increase fetal testing with Doppler 20 weeks of gestation, and serial growth scans starting at 32 weeks of gestation. For the high-risk pregnancy, as defined earlier, then we use cytoreductive agents with interferon. And then for the postpartum, for everybody should be on prophylaxis for 6 weeks with low molecular weight heparin. And one consideration for the IVF is the thromboprophylaxis up until 12 weeks of pregnancy, where the highest risk of thrombosis happens. So take-home message, pregnancy is increasingly encountered in our patients with MPN for the reasons we discussed earlier. There are many risks, whether to the mother or the baby, and it is considered to be high-risk pregnancy. And management should start early on before pregnancy with good planning. And also, we think about care in the prenatal, antenatal, and then postnatal considerations. Pegylated interferons remains to be a safe, effective drug, but we need more safety data with larger sample size studies. And we have to individualize the care with involvement of multidisciplinary care in these patients to achieve the best outcome. And with this, I conclude, and thank you very much.
Thank you very much, Dr. Musa. I would like to ask these speakers to come to the podium, and we'll run the questions. Just for interest of the group, Further, Doctor. We did I did retrospective analysis of 44 patients of MPN at King Faisal Jeddah Center, and 50% of our Saudi population have APS. So just be careful that the thrombotic risk addressed by Dr. Musa is higher in our population to other concomitant. And many of these patients, they have silent thrombosis. So now we have the patient, we screen them, echo, and ultrasound and Doppler. And you will be surprised by silent thrombosis. Okay, the floor is open.
Well, very nice presentations. Thank you, everybody. I have a question to Dr. Murtada and maybe comments with NCML as well. So, Murtada, how would you monitor response in patients with myelofibrosis who had splenectomy? So now you put these patients on ruxolitinib, you didn't have the spleen to assess the response, they're already treated and symptoms, you know, under control. So that's question. I mean, any effect, I mean, would you consider it? When would you stop it? How would you monitor the response? That's one thing. And for the CML, maybe you could comment, Dr. Ahmed, this is a comment. We did a study of maybe 50 plus patients assessing the TFR, and we had like 70%, well, 90% of the patients were on imatinib. 70% went into TFR, long-term TFR. So is imatinib remain a good, I mean, is that what you use in your practice? Personally, I still use imatinib as a first line.
So for the MPN patients, generally now splenectomy is hardly practiced with the JAK inhibitors. So this is rare. In the last 10 years, maybe twice. And unfortunately, these are elderly patients, and the patient that had splenectomy ultimately, like shortly after some time. So we try now to spare patients splenectomy, maybe splenic irradiation rather than a surgery. We go the same effect. However, with the introduction of the JAK inhibitors, things have significantly changed in terms of splenectomy. Now, the decision to start patients on the JAK inhibitors would be either because of the symptomatic splenomegaly or other symptoms, other constitutional symptoms. So if it is the symptomatic splenomegaly, I mean, splenectomy should take care of this. And then you would remain with the other symptoms that you could monitor by symptoms. The question is more complicated if you really believe, again, that overall, because this is a major decision into when and how much you would give patients ruxolitinib or other JAK inhibitors. So if you still believe that there is some benefit in terms of survival for the JAK inhibitors, then even if you do splenectomy, you would continue the ruxolitinib. In terms of analysis, so one of the analyses that were done with the ruxolitinib, just one maybe showed survival benefit. The one I showed was 0.06, so it was outside the statistical significance. The real world data shows actually survival benefit, but that real world data is highly criticized because at the end, they did not address well the indication by bias or indication bias, what they call it. In the real world evidence, they did what they call propensity score matching, where one of the ways to try to overcome that compounding bias, but still people criticize that this is not generally real world evidence in MPNs, and I'm sure in other areas to give a better than what is reported in clinical trials.
So for the, thanks, Dr. Ahmed. I think for the first question, sometimes we use the MPN 10 score. So while the patient is waiting for to be seen, we just give them the small questionnaire to fill. And then we can monitor this MPN 10 score to see whether they are responding, having a very good quality of life or not. And for the comment, we're still using the imatinib. If you look at our patients, maybe 30, 40, or maybe 50% of our patients are still using imatinib in the first line, having the vast experience with it. Number two, we have the TFR data. But I'm sure even in our center, when we did the analysis on 70 plus patients, the TFR rate was 76%. But that might be related to the long duration of TKI that they had. They had a median duration of TKI of 8.6 years. So might be this affect the number that is we're seeing 76%. We don't have data with the asciminib when it comes to asciminib since for the TFR, so we're still not using the asciminib in the first line. But I did show the data because it's randomized. The rate of discontinuation and the efficacy was superior with the asciminib. And we have now dasatinib is a generic, imatinib is a generic. The cost is a major issue as well, so we consider still the generics with imatinib and dasatinib, and especially with dasatinib at a lower dose of 50 milligram. Available, yes, based on the request, yeah.
Dr. Murtada, I have a young girl. She's 19 years old and diagnosed to has essential thrombocytosis, JAK2. And it happened that she's one of her twins. And you may know that patient is Riley, and when they look back, it's maybe as early as week 30 in intrauterine. So what happened actually for this patient, because the other twin said, no, let me JAK2, and when I check, actually it turned it to be negative. I think this piece of information is not only applied neoplasm, because in that study, actually, they looked to the JAK2, DNMT3, and as well as AXL. So it seemed to be that all of us, we may get that driver mutation early in our life, even maybe before we born. And there is other contributor which may just either you will have the manifestation of malignancy and cancer or not. And the other point, which is really very important, you may remember also mutation, which has been studied to be that we are mutation, but there is other types of contributor to either that you will see the manifestation of disease or not. I have another question to Dr. Zahrani. Actually, I want to congratulate you on the recommendation which you show us. But now dealing with two people actually, and it seems to be that those ladies, they are desperate to have a baby, and most of them, they experience recurrent abortion. So in which basis you put those recommendations? If this lady experienced complication like a bleeding or she lost her baby, am I be able to stand in the court and they said, okay, Dr. Zahrani, he just recommended?
Get your lawyer, yeah, Dr. Musa. I know a good lawyer. Go ahead.
Could you please repeat the question, because I didn't get the...
No, your recommendation, is it solid that at the court you will be able to say, yes, this recommendation is all the standard and don't worry, or you will have a shaky hand or shaky legs also?
Of course, as I mentioned, because we don't have really proper like randomized trials or prospective trials, so most of the evidence is actually kind of weak evidence. And many of these drugs also like not approved during pregnancy. They have. I was saying that most of our evidence does not come from strong based studies. Like there is no randomized trial or prospective trials, and usually it's like a small case series or experiences of some physicians. And some of the drugs are not approved even, although we use them in practice. They hold class C classification like interferon. So basically, this needs to be discussed, all of these risk-benefit with the patients, and just document whatever you discuss with the patient in the chart, and that way you can be protected. Because it's really hard to just say, you know, this is the best evidence or whatever, because there's no such a thing.
Yeah. For the point of the young patient, so I have many young patients, and in pediatric, don't say reactive thrombocytosis. Do NGS, not JAK2. I have many patients young with MPL. Go ahead.
So before I answer, I'll ask you a question. Is the other twin identical twin, and did you test? No, like genetically identical. Okay. So, I think in our area, we see younger patients and we see familial. That patient that we did splenectomy, actually, who died years after, his son was referred to me with unexplained thrombosis, and then he turned to be JAK2 positive MPN like his father. So this is the second. I have other families, but this is definitely common. Now going back to this pre-JAK clone. So one possibility that you have a pre-JAK clone, and what you do, that pre-JAK clone may predispose to either forming into JAK2 or going into CAL. So that's one explanation, and the evidence for this is that those patients who progress into acute leukemia, and when you test their acute leukemia, that leukemic clone does not, some of the patients do not carry JAK2. So that tells you that pre-JAK2 clone also now gave JAK2 and then gave the leukemia. The second explanation is that you have both positive. So in our case, the brother was Carl, and that patient was JAK2 positive. It is most likely that both are positive for JAK2 and CAL. And it is the sensitivity of our methods that we were able to detect by a standard PCR, the JAK2 and the CAL. But then if you do the NGS, you probably will be able to detect both clones. Unfortunately, that patient died and we did not freeze his, so we cannot prove that concept with this family. But these are the two explanations why you see this, either a pre-JAK clone, which what you kind of suggested initially, or that you have the two.
Okay.
There is also one other possibility, which is germline JAK2. This is a very rarely reported, but there was one family reported in New England Journal of Medicine about maybe 10 years ago or so. Because I had one patient who was in his 70s with JAK2 PV, and his daughter who was in 20s was diagnosed with the JAK2 ET. And I was worried about germline position, but we actually did germline studies for these two patients, and it was acquired. So maybe, as the doctor said, maybe these are acquired early on in life, and there were studies showing that this is an acquired, not germline mutation, it's a somatic mutation, but acquired during fetal age, early on during fetal age.
Okay.
Is
Last question, Dr. Ahmed, then we will come.
This is to Dr. Musa. You mentioned about pregnancy and MPN, but my questions, like last week, we had one patient, young lady, pregnant with thrombocytosis. She has no MPN, but she has the hereditary thrombocytosis with P106L. And I know you had one paper published recently. And also, so what you do for these patients, how would you give prophylaxis or not during pregnancy? And we had some patients who had both mutation, the MPN, one of the MPN mutations, and coexistent P106L mutation. So also, if you have any recommendation for these patients.
Yeah, so the familial thrombocytosis is very common in our population, the MPL Pro106 LU. This should be one of the first one of the first differential diagnoses in our population. It's actually more common than AT, surprisingly. So these patients, we don't have enough evidence. The only study that we have is the one that you mentioned, limited number of patients. We don't have data on, let's say, for example, pregnancy patients. We know that they're associated with less risk of thrombosis. This is from the study, the retrospective study. But still, we don't know a lot of these, what is the best management, etc. So in my practice, I give everyone aspirin, although without any supportive evidence. I do give them aspirin. I don't give them hydroxyurea. So if they become pregnant, I wouldn't consider like cytoreductive agent for sure. I would screen them for von Willebrand if their platelet is more than 1 million. If so, then I would probably try to avoid aspirin if the von Willebrand is less than 30. Otherwise, I would continue aspirin during pregnancy. Again, this is based on just anecdotal evidence. There's no.
Okay, then by now we can call it the end of the first session. would like to call we would like to thank Dr. Khalid, Dr. Murtada, and Dr. Ahmed for the very fruitful first session. We will start immediately the second session. Unfortunately, we cannot exercise or enjoy the coffee break because we're running short of time. I would like to call the speakers in the second session. You're free to get your coffee from the coffee break area and attend the second session. Thank you so much.
يمكن لأنها كانت reported as a variant of unclear significance.
Just send me a paper. I'll check in our population.
هلا والله حياك الله اخبارك طيب خير شكل المايكس ما تشتغل
Assalamu alaikum. Good morning again. It's my pleasure to chair the next session. It's okay. Take your time. أنا شايف الناس بتطلع ولا حتدخل ولا كيف؟ So there is still enough people in the. It's okay. So it's my pleasure to chair the next session, and my co-chair, Dr. Omar Abdul Jalil. It's the best session in the whole day. So if you miss this, you miss the whole symposium. It's about multiple myeloma. So we have 2 talks and then 2 satellite symposia by J&J. I'll introduce the first speaker. Probably they are working on slides. Are you ready? 2 minutes. Okay. That will be deducted from your time. All right. So the first speaker is, it gives me really an honor and a heartily pleasure to introduce this coming speaker, Dr. Ghazi Al-Utaibi, who is an assistant professor at King Saud University in Riyadh, and he's the director of the Oncology Center. So he will be the speaker of the first talk, and he will moderate the next 2 sessions that are sponsored by J&J. So the first talk is going to be about Bispecifics, immunotherapy, MRD negativity in multiple myeloma, steps for cure. So we are going to hear Cure for Myeloma from Dr. Ghazi Al-Utaibi. Are you ready? Go ahead.
Assalamu alaikum. Thank you very much for joining this morning. Thank you for inviting me. And it's always a pleasure to talk when Dr. Ahmed is moderating. My task today is to talk about, bispecifics and MRD in myeloma. And I think this is actually quite a huge topic to cover in 20 minutes. So I'll try to focus on the first part. So these are my conflict of interests, which are not relevant to this talk. And basically we'll talk about bispecifics in relapse refractory setting. We'll talk about, how do you manage their side effects and see if there's any evidence for, combination, bispecifics. We've seen throughout, the last 10 years that the myeloma landscape has changed significantly. We know that every myeloma comes from a small, benign MGUS clone. That clone can actually evolve with time to become a smoldering that evolves to a myeloma. And, with every relapse, you get a shorter, PFS, shorter survival. And those patients, unfortunately, we try to invest in their first, PFS, but ultimately, everybody, if they survive, they will actually relapse and relapse. So, bispecific comes, beyond a second to a third line, in this time. And the treatment goal has to be really explained to the patients. Most of those patients are, difficult to cure if possible. And our goal is to prolong survival and, really keep them on therapy that does not worsen their quality of life. And I think this is very important with bispecifics, given the, side effects and complications that could arise from these therapeutics. We were actually quite lucky over the last 10 years to see a significant expansion in the myeloma armamentum. So you can see that, daratumumab came literally 10 years ago today. After that, we had so many targeted therapy in myeloma and two CAR-Ts. One of them will be actually infused to a patient in Saudi, hopefully in 2025. So the bispecifics as a medication used in myeloma comes in so many flavors. Usually in a standard myeloma, when they come to the clinic, we always think about, inducing them into remission. And then some of those patients will be, transplant eligible. So we'll take them to transplant and then we'll put them on maintenance. And there's actually, on every segment of their therapy, we can literally talk for hours and hours to talk about, what's the best induction, what's the best, do we transplant or not transplant, do we maintain or not maintain, what maintenance options are possible, and then every relapse has its own talk. But, it's very important to know that, along the journey of those patients, it's very nice to know that choosing the most effective therapy that, deepens the response and put those patients into a very deep response is the only predictor of, overall survival. So choose a therapy that, make those people go into a deeper responses. And the best that we have so far, honestly, are the bispecifics. Yes, we only use it now in the relapse refractory setting, but I think with time, definitely it will come to the front line because of the significant, deep responses we see. We keep changing mics. So the commonest mechanism of action is an antibody or an IgG monoclonal antibody that actually binds to the myeloma cells and fix it to a T cell, and that kills the myeloma cells. So the receptors we know nowadays are actually a BCMA, which is the most common one, and then the GPRC5D, which is an approved also medication that we have here in the region. And also we've got, an FCRH medication. And there's actually so many other receptors that we can target in myeloma. Some of these are actually not approved yet. So I think this is the age of immune-targeted therapy in myeloma. I think, by now, we've already stopped using, chemotherapy in myeloma, except in rare occasions. But our collective goal, when you combine this medication, is to cure those people. So a PCMA or a B-cell maturation agent is a receptor that is unique to plasma cells, and you cannot see it on B cells or there's a small clone of hematopoietic CD34 positive cells that carries this, but it's not common outside the plasma cells. So it's a good target. GPRC5D, we don't know where is this receptor works. We kind of figured now from the complications we get from talquetamab that it might affect hairs and nails and skin, but the expression is very high in myeloma cells, unknown function in human body. The FcR receptor homolog 5 is also a receptor that we target in myeloma. It's something that really expressed heavily in myeloma cells. Its function in human body is also not really clearly identified, but it's actually a target that we use in myeloma. So what do you have in the market? So we've got so many options. The only approved ones are teclistamab. So this is a subcutaneous medication that is usually given beyond the third line of relapse. Impressive responses, and this is usually in heavily pretreated patients. So you get responses that are beyond 60%. Very good amount of deep responses, especially in people with extramedullary disease and people with CNS disease as well. Elranatamab works exactly the same. It's another anti-PCMA directed monoclonal antibody. Works really well in about 60-65% of patients who are really pentarefractory, and it actually gives a deeper responses. So when you actually look at these numbers on the right, you can see that people live up to 2 years and 3 years. so prior to the bispecific era, those people only live 3 to 4 months. So I think we have made, a significant change in the disease trajectory with the utilization of these medications. So on the non-BCMA targets, you've got many targets, but the commonest one is, or the FDA approved one on the list is talquetamab, which is also a subcutaneous medication that has a way higher overall response rate. It's usually used in those who are beyond the 4th line of therapy, but unfortunately, it has a side effect profile that is not really pleasant. So we try to keep it, only if we need it, at the end of therapy. So going very quickly through the literature. So the Majestic one is a phase 1/2 that led to the teclistamab approval. It's been used, or this study included patients who are heavily pretreated. So everybody is penta refractory. Most of those people have, underwent all the usual NC38PI and EMID, combinations plus palma carfilzomib. And the overall responses have been, quite impressive. So you're looking at 63, 64% responses at the recommended level, recommended phase 2 dosing. The amount of CR is actually quite high, but there's a small fraction of patients who will not respond. So those people, do not actually entertain a very nice PFS. But out of those people who respond, their overall survival improves quite significantly to beyond 3 years. So that's out of those who respond, they actually live very long compared to those who do not respond. And it's important to, if you actually look at the details of the study, you can see those who received the therapy, with less than 3 lines of therapy in the past, they actually respond much better. So that tells you that the T cell health is very important when you use these medications. The Majestic have shown a safety profile that is not unknown to most of the myeloma physicians. So infections are very common with these medications, and there's actually a very detailed algorithm published by the Saudi Myeloma Group on how do you manage these complications. But they've got a unique profile of infections. We've started to see also some autoimmunity from these, but it's not very common. The magnetism is the study that led to elranatamab approval. Again, it's an open-label single-arm study. So most of these studies are actually just a single arm, either phase 1B or 2. But we've seen with the elranatamab that the overall survival is actually similar to teclistamab. The responses are quite similar to teclistamab. So it's really a potent medication if used appropriately in those patients with a reasonable risk of infections. And the good thing about elranatamab is actually you can actually move it to every 2 weeks and sometimes every month, quite sooner than teclistamab. And you can see that the rate of infections, improves a tiny bit. The rate of side effect improves if you switch it to Q4 weekly dosing. So the monumental study have looked at the talquetamab. So talquetamab is really a nice target that is potent when you target, but it has a unique safety profile of nail changes and skin peeling, sometimes even a change in taste that we people have not liked to use this earlier because of the safety profile. But you can see that with the follow-up of really close to 2 years, the overall survival within 2 years is about more than 60-65% are alive at 2 years, which is something impressive that we have not seen prior to talquetamab era. So now, when do we use these medications? I think we've got so many questions now that we've got all of these options. I think the questions that comes in mind is, how do we sequence these therapies? You've got so many options. You've got also a CAR T that's coming in the market that I have not, covered today because it will be coming in the next talk. If you use 2 bispecifics, which one you use, earlier? Do you space them, with chemotherapy in between or no? How much is a gap that you need, to restore the T cell health, and how do you actually manage the toxicity? So these are very important questions. In real world, we can tell you that looking at the Cleveland Clinic registry that looked at about 100 patients, we've realized that the anti-BCMA directed therapy works really well, but it doesn't work really well if it's been preceded by an ADC like belantamab mavedotin. It actually works reasonably okay, even if CAR T has been used in the past. So that's why we've, most of the community have decided that it's actually a good idea to exhaust all your, immunotherapy like daratumumab and all the PIs and IMIDs, and then preferably refer those patients for a CAR T. And then when they relapse, you can actually use the bispecific at that time. And when you use a bispecific, we'll talk about, which one do you choose, after a CAR T. But certainly they do not work really well if they're actually preceded by an ADC. And this is the data that came from the magnetism trial. They can see that prior BCMA is reasonable, so more than 50% they will respond. Responses are much lower if it's an ADC that was actually in the past. And this is the PFS that we've seen. After a CAR T, PFS remains close to 40-50%. If it's preceded by an ADC, it's actually in the range of 20%. In the talquetamab, which is a different receptor, so most of the CAR Ts we've got are actually a BCMA CAR T. So talquetamab also showed the same thing. It's probably an ideal to use it following a CAR T. This is the data we've actually seen from the magnetism. One of the cohorts that allowed people who received an anti-BCMA therapy. And the interesting thing is actually it works really well after a CAR T, but it actually works much better if there's actually a gap between an anti-BCMA and a GPRC5D. And as long as of a gap as possible, so those people who've got bispecific at their last line of therapy, they did not do very well, except those who had it with a good gap. So that's why we try to teach that talquetamab can follow CAR T, and if you're going to use another bispecific BCMA after talquetamab, try to use a chemotherapy or a palm-based therapy, between teclistamab or talquetamab. So that's what we adopted in the Saudi myeloma guidelines. So we've recommended exactly what I mentioned, that once they become pentarefractory, then they go to a CAR T, and then preferably when they relapse, they go to talquetamab, and then try to space out any therapy after talquetamab prior to going back to another anti-BCMA therapy. So do we have evidence for combinations? Unfortunately, we've always thought that maybe if you combine all this therapy, you can cure myeloma, and I guess this is not the case. So the best evidence we've got is from the TRIM and the redirect trial. So the TRIM have looked at talquetamab, daratumumab. Responses are really impressive, but they're not really durable responses. Probably if you sequence these, you get probably a much worthy time to the amount of money you pay. The redirect has been published and presented multiple times. It combines both teclistamab and talquetamab. Not a great idea to combine them at this point because of the safety profile, but it's an idea that was actually worth exploring. The overall responses were not really different than if you actually use them just back to back. We've got also elranatamab combination data. So elranatamab, carfilzomib with dexamethasone, overall responses are actually quite impressive, more than 80%. But the amount of toxicity that have been led to discontinuation of the study has been quite significant. So the last slide or so is going to be about side effects. So everybody with bispecifics will get a CRS, mainly with the BCMA therapy, and the CRS rate is actually very high, 60 to 70%. In almost everybody, it's a grade 1, so it's not really nothing to worry about. There's minimal amount of grade 2, 3, or even 4 in those studies. But there is an evolving evidence toward the use of tocilizumab prophylaxis. So most of the places in North America now are actually starting to adopt toci prophylaxis, especially in the first couple of days of teclistamab or elranatamab administration. ICANS is a big problem. It's not as much in bispecific compared to CAR T, which will be covered in next talk. So to avoid CRS, we actually use a step-up scheduling, so we don't give it full dose. We have to really use it slowly throughout the first 1 week, when we actually admit those patients in the first 1 week. CRS improves significantly, so it comes in day 1 in almost everybody, but then it goes down throughout the first 1 week, and it's rare in cycle 2, and that's exactly has been the case with elranatamab as well. And we've also showed you the data about tocilizumab prophylaxis. It actually improves the rate of CRS and brings it quite significantly. Infections happens in about 90% of those people. It's very important to use all antimicrobial prophylaxis, and IVIG is mandatory in those people. So you see that there's a significant improvement in tolerance and significant reduction in infections when you use IVIG. And that's what the Saudi consensus guidelines have recommended. So anti-viral prophylaxis against HSV, screening for HPV, IVIG, monthly GCSF, PJB prophylaxis, as well as vaccinations if possible. So these are the side effects we've covered. So infections, skin and nail changes I have not discussed because it's something that's related to GPRC5D. Dysgeusia is also something that we've seen with talquetamab. So these are some of the skin changes you can expect with talquetamab. We don't know really how to manage these things apart from maybe dose reduction, discontinuation of therapy for short intervals of time, and then some hydration and lubricants and dermatology consultations. So these are really impressive therapy, but they come at a cost. The most common cost is cost. So
ترى أعطيناك ال 2 minutes.
thank you very much. This is my last slide, but I think we're trying to hope for cure in myeloma. It's not the case yet, but probably in the next 10-15 years, we'll achieve or we'll become very close to this. I have not covered MRD, but it's a very long topic that we'll leave it for another day. Access is a problem. So in Saudi, you've got access to teclistamab and elranatamab. Talquetamab is through a clinical trial that it's been running in most of the major hospitals in Saudi. With that, I will leave the floor. Thank you very much.
Well, thank you very much, Dr. Ghazi. It seems that there is no discussion part, but if anybody has a burning question about the bispecific molecules, I have a question. Now, since we are using more frequently quadruplets in the upfront therapy, I mean, patients when they relapse, they almost, have exhausted most of what we have. The only left is probably KPD, KCD, or something like that. Would you use bispecifics in that setting now? Rather than going to KPD or PCD, because you have exhausted probably the anti-CD38 and VRD mostly.
Right. So one of the karmas have looked at CAR T in that space.
Yes,
I
but
think,
I leave CAR T.
yeah.
We'll use bispecifics.
So I think CAR T referral beyond the practice is probably ideal. And certainly if I have access to bispecific at that time, definitely I would. And we've got strong data to say that the duration of response is much better if you use these agents quite early. So we don't have the FDA label to use that. Even the Saudi FDA label is beyond the third line. But definitely our experience with with teclistamab in particular is actually those who receives it early, they respond much better compared to those who are really T-cell exhausted.
Well, thank you. Dr. Omar has a question.
So thank you, Ghazi, for this very nice talk. So I guess the biggest thing that comes to mind is now with all the bispecifics and how to sequence them, because you just mentioned once you start one, if you start one right after, you're probably gonna lose response. But it's easier said than done about bridging, because by then you probably have used a lot of the therapies available to you. So I guess my question is, in reality, would you consider like selinexor in this space? Like between bispecifics. It's not T-cell exhaustive at in that setting, I guess.
Yeah, you raised a very important point. I think we're not really utilizing selinexor or alkylators to the amount that we wanted to. So good old cyclophosphamide as a bridging therapy works really well at so many dosing. We can talk about this later, but so selinexor with or without Velcade combination, even in Velcade refractory people, it can actually bridge people to at least I would say 2 months prior to reinitiating another T-cell engager.
Well, with that, thank you very much, Dr. Ghazi. I'll hand over the microphone to my co-chair, Dr. Omar.
It's my pleasure to present the next speaker. He is Dr. Abdullah Saleh, the acting section head and consultant for adult hematology at King Abdulaziz Medical Center and the assistant professor of hematology at King Saud bin Abdulaziz University of Health Sciences. He's going to present a very important topic on the management of AL amyloidosis. It's one of the topics that's very passionate to my heart. Dr. Abdullah, the floor is yours.
Thank you so much for this kind introduction. I'm going to talk about light chain amyloidosis, and I'm happy to have a session about amyloidosis during this meeting. So we all know about amyloidosis. It's a term used to describe misfolded protein, mainly in the beta-pleated sheet forms. The problem with this protein that it deposits between the cells, and it leads to direct damage to the tissue and toxicity. So I'm going to start with a case to show you a very important aspect for the management. So this is a 65-year-old gentleman who was seen initially by the primary care physician because he had lower limb edema. The primary care physician does an echo, diagnoses him with diastolic heart failure. Then a year after, he presents with bilateral carpal tunnel syndrome seen by the neurologist, who nowadays all do the SPEP, and which shows a small clone of plasma cells. Unfortunately, the hematologist, when he evaluated this patient, immediately labeled this patient as MGUS. Then a year after, the patient presented with anasarca, diffuse lower limb edema, with a very low ejection fraction, and he was diagnosed at amyloidosis. So what is the important message from this case is that please be careful before labeling patients MGUS, they have amyloidosis, because the most important step in the management is actually early diagnosis, because time is money. If you catch these patients early, you can treatment, and if they progress and they have multi-organ failure, little can be done to these patients. So usually patients typically present 1 to 2 years later after diagnosis, and as you can see from the curve, the later you diagnose them, the more mortality for these patients because of multi-organ failure. So how do they present? So you have to understand the presentation in order to catch patients early. So can we have a different microphone? This is. So they present with fatigue, unintentional weight loss. It's important to ask about weight loss in these patients. Classic organ involvement, heart, the kidney, the liver, we all these presentations. So they present with heart failure with preserved ejection fraction, but then they can have low ejection fraction. They can also have conductive abnormalities in the heart. In the kidneys, they present with nephrotic range proteinuria. In the liver, increased alkaline phosphatase. And very important to recognize the autonomic dysfunction. So if you have a patient who you suspect they have amyloidosis, they have low blood pressure, their cardiac function is good, think about autonomic dysfunction. What is more important, that any organ can be affected. So this is one of the challenging case I had as a fellow, or patient who presented with diffuse joint pains, all of his joints. He have seen many rheumatologists, many orthopedics, and nothing was working for this patient in terms of pain management. And finally, an orthopedic surgeon decides to take a biopsy from the synovium. It came back positive for light chain amyloidosis. Another interesting case I had in the clinic is a patient actually who was seen by the pulmonologist with dyspnea over a year, he had CT scans done, bronch done, infectious workup is negative, rheumatological workup is negative. He had ground glass ossifications. He was labeled as hypersensitivity pneumonitis. He was managed by mycophenolate. Unfortunately, the patient was progressing, requiring home oxygen, and then the pulmonologist decided to do a bronch again with a biopsy, and it came back positive for light chain amyloidosis. So the second message here is that any organ can be affected, and keep your eyes open. Most of the patients present with multiple organ involvements. This is common because they present late. And some of the pathognomic findings for light chain amyloidosis includes the periorbital purpura and the macroglossi. So if you have a patient with these findings, this is pathognomic for light chain amyloidosis. So if you encounter a patient with AL, you need to look for the clone. And most commonly, it's a very small clone of plasma cells in the bone marrow. But please do not forget that lymphoma can actually present with AL, for example, Waldenstrom or CLL. They can have light chain amyloidosis as well. It's not only plasma cells. So I'm going to share with you another case with an important message. So this is a 69-year-old gentleman who was actually initially seen by the cardiologist for his lower limb edema, and then was diagnosed with echo showed sign of AL. Then the cardiologist actually did a good job screening for plasma cells, which actually came back positive for a clone of lambda restricted plasma cells. And then the patient was referred to me to start treatment. However, please be careful before labeling a patient with AL. You need to make sure it's truly AL. Why is this important? Because up to 40% of patients with ATTR, they can have a monoclonal protein. So before you say that this is AL, you need to actually to confirm it's AL. And usually we do this with mass spectrometry. So which organ to biopsy? If you do fat pad and bone marrow, you can diagnose up to 90% of the cases. In my practice, if this is negative and I still suspect AL, I get a salivary gland, a lip biopsy by the maxillofacial surgeon, and this is very helpful even if there are no symptoms. And then, unfortunately, sometimes if you still suspect AL, you have to go to the organ and do a biopsy. And we all know that Congo Red tells you that it's amyloidosis, but does not tell you the subtype. So the most the most accurate method for the diagnosis is actually the mass spec. Just 1 or 2 slides about the PYP scan. It's a nuclear medicine scan that is used by the cardiologist, and it's very helpful in ATTR. But keep in mind that up to 10% of patients with light chain amyloidosis can have a positive PYP scan. So when you have a diagnosis, you have to stage patients. And I'm not going to go into the details about the staging system, but all of them have one thing in common. They look at the cardiac involvement. They look at the BMP or the NT-proBNP and the troponin. And of course, if you have advanced disease, the outcomes are worse. One staging system is the Mayo 2012 staging system. It differs from the other staging systems in the form that it includes the burden of disease. So it includes the difference between the involved and the uninvolved free light chain as part of the staging. New data from the UK showing that global longitudinal stain is actually prognostic, especially in patients with stage 3B. And this is actually can be done by an echo. When you order an echo, you can include strain imaging to the cardiologist and they give you the strain measurements. And this has been prognostic. So what other prognostic factors we have? So of course, if you have overt multiple myeloma with amyloidosis, this is bad. Traditionally, translocation 11-14 has been prognostic, but now we also are getting some data about chromosome 1 abnormalities, chromosome 1q gain and 1p deletions have been prognostic in AL. So now switching gears to the treatment, which is important. So the landscape of treatment has changed over the years, starting with milphenol-prednisone, moving to stem cell transplant, and then using IMiDs and PIs the way we use in myeloma. But now the introduction of the daratumumab combination regimen has shifted the treatment. And I'm going to show you about also data about CAR-T and bispecific in light chain amyloidosis. So we all know about this trial, the Andromeda trial, which randomized patients with a newly diagnosed AL to DARA VCD for 6 months compared to VCD. And then DARA was given for 18 months afterwards. But keep in mind that the inclusion criteria was restrictive in this trial. So patients with advanced heart failure, with ECOG more than 2 or GFR less than 30 were excluded. And these are not the typical patients we see in real practice because usually they present late. So DARA VCD, of course, the response rates are better. And initially, in the initial trial, the progression-free survival defined by progression in terms of organ or hematological progression was better in the DARA arm. But updated analysis showing the response rates are actually the same as the initial publication. But if you look at the PFS curves, they have dropped a bit, but still the median is not reached in the DARA VCD arm compared to the VCD arm. And more importantly now, we have actually survival benefit, overall survival benefit, and this is no doubt is the standard of care in our patients. But how about using DARA VCD in patients who are not presenting like in the trial? So patients with advanced heart failure, can you still use this combination? And this is an important publication, retrospective analysis showing that even patients with advanced heart failure, you can start this treatment, but there are some tricks to the treatment. So it's effective survival. There is the median survival is not reached in patients even with stage 3B and stage 3B patients. With over 60% of these patients are still alive in this retrospective analysis. So if you have a newly diagnosed patient, if you have anti-CD38 based combination, you should use it. Keep in mind that there are some milestones that you need to reach. For example, you have to achieve partial response, hematological partial response after 2 cycles, and very good partial response by 4 to 6 cycles. I typically collect all of my patients for stem cell transplants because you might use this therapy later in the relapse setting. However, there is a population that I still consider upfront transplant if they are eligible. So these patients with overt myeloma and amyloidosis, I do upfront transplant for these patients if they are transplant eligible. One slide about transplant, there is a very strict criteria for transplant because the mortality is higher than in myeloma. But I just wanted to mention one thing about this stem cell transplant, that actually traditionally 3 organs or more was considered as an absolute contraindication for transplant. But this was one of my first projects as a fellow. We looked at patients who had 3 or more organs. What was the outcome for these patients? And what we have found is that actually if you have a good cardiac function and the patient needs a transplant, you can still do transplant. So please do not exclude patients if they have 3 or more organs just because of the number of organs involved. Another burning question in amyloid is should you do any consolidation/maintenance if you do upfront transplant? Again, this is a dilemma for amyloid, and limited evidence exists. But what we have found is that actually if you have a patient who had a transplant and then at day 100 you do the response and they have less than very good partial response, there is a role for consolidation/maintenance as shown in the right for the progression-free survival and trend for overall survival. It's very important when you treat these patients to look for the hematological response and keep in mind that this response is different than myeloma. For example, you look at the difference between the involved and the uninvolved light chains. If it is decreased by 50%, this is partial response. If you subtract the numbers and it's less than 40 milligram per liter, this is very good partial response. Sometimes you have a patient who have a very small clone, so it's difficult to assess the response, especially if the light chains are, for example, between 20 and 50 milligrams per liter, and then you look at the difference. If it's less than 10, this is considered partial response. There's normalization of the light chains, or if the uninvolved is higher than the involved, this is considered CR. So why do we care about response? We care about response because the deeper the response you get, the hematological response, the better the outcomes. That's why I mentioned the important milestones about the response. I'm not going to go into details about organ response, but I just wanted to mention that traditionally there have been organ response criteria. But what is more important is that actually we are going into deep definitions for the organ response. So as in the hematological response, now we have cardiac, renal, and liver response, and it's also graded based on the deep depth of the response. For example, in the cardiac response, you look at the NT-proBNP and you assess how much was the reduction in order to define the response. So as I talked to you about the typical patients we see in the clinic, so this is an elderly patient who has a lot of comorbidities, hypertension, uncontrolled diabetes, presents with AL, mainly cardiac, with high troponin 1400. So how you manage these patients? There is a trick in the management for these patients. And what I have learned is that any patient with comorbidities, you don't start with the full doses. They will not tolerate. So you need to be careful. You start with a reduction, mainly the bortezomib and the dexamethasone, and then you increase as tolerated. Almost all of the patients who have cardiac involvement and nephrotic rage proteinuria, when you start the treatment, especially the induction, the first 2 cycles, they will go into exacerbation. So most of them, they will need admission. They will need IV albumin, Lasix, in order to manage them. This patient did well. I started with 50% reduction, and then I increased the dose, and the patient now is in CR. Another case with an important message, this actually was a referral for a patient who has myeloma, started VRD, started 2 cycles, then referred to our center for transplant. When the patient came to my clinic, he said, I'm not going to continue treatment. This treatment destroyed my life. I have severe fatigue. He had lower limb edema, although he didn't have anything in the beginning. So he was lambda, and his troponin increased, although he did not have any cardiac disease before. So what is the message here? The message, if you have a patient with myeloma and you start treatment with an IMiD-based therapy and they go into complication with heart failure, fatigue, think about AL, because patients with light chain amyloidosis, they don't tolerate IMiDs, especially the full-dose lenalidomide. So keep this in mind. So switching gear now to the relapsed AL, you have to ask yourself 3 questions. Did the patient get daratumumab? Is the patient transplant eligible? Did they get transplant or not? And do they harbor the translocation 1114? So it's simple. If the patient did not get DARA up front, you can consider DARA-based combination. If the patient is eligible for a transplant, you can consider a transplant in these patients. And for 1114 patients, you can use venetoclax-based therapy. IMIDs, PIs, and alkylators can be combined together, but keep in mind that if you are starting an IMID, you have to start with a small dose and then you increase as tolerated, especially lenalidomide. So the tourmaline trial is a famous trial for AL in which patients with light chain amyloidosis were randomized to Exadex versus physician best available therapy. And unfortunately, this trial, the hematological overall response, which was the primary outcome, was not difference between the 2 groups. However, when they looked at the vital organ response, it was maybe slightly better in the Exadex arm. You typically do not jump to Exadex in patients, but I keep it in my mind because other therapies are available. So daratumumab is very effective in the relapse setting. You can get an overall response rate reaching 80% with the CR rates reaching 30 to 40%. Venetoclax is very effective, especially in patients with 1114 with its VGPR CR rates reaching up to 80%. I want to spend some time actually in the supportive care because this is very important in AL and it's commonly missed. So even the cardiologists sometimes they don't recognize this because it's a rare disease. So for example, in the cardiology section, patients with AL, they do not tolerate beta blockers. If you start them on a beta blocker, you will destroy them in terms of symptoms. They will have severe fatigue, they will have hypotension, so they don't tolerate it. Maybe patients with low ejection fraction, you can consider beta blockers, but keep in mind it should not be used routinely. Actually, in some retrospective data, it was associated with sudden death. ACE inhibitors are angiotensin receptor blockers. Can be used, but again, if the patient has autonomic dysfunction and low blood pressure, you should be careful. In terms of the GI, some of the patients will have diarrhea, and the diarrhea can be difficult to manage, so you start with loperamide, but some patients will need advanced therapy in terms of, for example, atropine, opioids, and others. Autonomic dysfunction, so these patients can have low blood pressure and it can be managed with compressive stocking, and sometimes you have to use other therapies such as midodrine. The nutrition is very important, especially in patients who are malnourished, so their role is very valuable in these cases. So just 3 slides about where are we going. So in ASH 2023, there was an interesting talk about CAR T in patients with amyloid who are actually refractory to multiple lines of therapy, and the results were updated in the 2024 ASH. So if you look, these are 11 patients. Almost all of them had advanced stages. Some of them actually had stage 3A and 3B. And what is interesting, that because of the small clone, is none of these patients had severe CRS or ICANS. And the response rates, all of them responded with very good partial response or better. So CAR T is tolerable, and almost all of these patients had MRD negativity. How about bispecifics? Yes, there are some retrospective data about bispecifics in AL. And as in CAR T, actually, this treatment is actually tolerable. CRS and ICANS rates are low, and patients are doing very well with excellent responses, both hematological and organ response. So one slide about monoclonal antibodies. So we talked about targeting the clone. How about the amyloid deposition that is already there? Can we do anything about it? So there are some monoclonal antibodies being studied now. One of them is bertamimab. In the initial trial, the vital trial, actually it was closed early because of the futility. But when they did a subgroup analysis or post-hoc analysis, they found that patients with stage 4 amyloid did benefit, as you see in the curve. So what are they going to do now? There's a ongoing trial, bertamimab with DARA-VCD compared to the DARA-VCD to see if this population it's helpful or not. So my last slide about localized AL. So sometimes you have a patient who's referred to your clinic and they have amyloid in one organ, but when you do screen the other organs, it's negative. When you look for the clone, there is no clone. So this is localized AL. most commonly in the upper respiratory tract, for example, the nasopharynx. In the GU, the most common site is the bladder. In the GI, for example, the colon. You can also have patients who have multiple pulmonary nodules and they are AL. What is good about these cases is that the outcome is good. So if the patient does not have symptoms, the amyloid is not causing organ malfunction, you can keep it. You can consider surgical excision for the amyloid and the outcome is good. Radiation can be considered, but all in the retrospective studies, the response rates are between 30 and 40%. And most of these patients do not require systemic therapy. And the progression to systemic AL in these cases is very rare. So in summary, please remember lesson number 1, we talked about it. The most important thing in amyloid is early diagnosis. So keep your eyes open because time is money. When you have a patient, you have to stage them. You have to look for the extent of organ involvement. When you diagnose a patient, you do plasma cell directed therapy if it's AL, but don't forget supportive care is very important. When you treat them, you look at the milestones. Make sure you are achieving the milestone, the hematological response for all of these patients. And as I discussed, novel therapies are emerging in the form of CAR-T and bispecifics. Thank you very much.
Thank you, Dr. Abdullah. So I guess now we're back on track in terms of time. We'll open the floor for a couple of questions. Any questions? Dr. Hatib.
Thank you very much for those excellent. I have a question for Dr. Abdullah. Thank you very much for highlighting the important points in management. My main question is, how would you adjust your management if someone presents with cardiac amyloid and specifically high-risk arrhythmias in regards to monitoring early on and steroid and other medication adjustment?
Sure, this is very important aspect, and don't forget that we always need the help from our colleagues. So in terms of a hematological point of view, if I have a patient with advanced heart failure, the most important thing is the bortezomib and the DEXA. So if it's extensive severe cardiac involvement and the patient is, for example, advanced active heart failure, maybe I will start with DARA, cyclophosphamide, and supportive management with diuretics, and then start the bortezomib and the DEXA slowly and then build it up. Don't give the full dose up front. This is the most important thing. Of course, in terms of the arrhythmia managements, there is a lot going on with the ICD, and we don't have, unfortunately, good evidence for prophylactic, but again, the cardiologist's role are very important. Don't forget beta blockers, try to avoid them. I know some cardiologists use, for example, digoxin and others for the management, but beta blockers are not tolerated.
Dr. Bus.
Question to Dr. Abdullah. Thank you for the nice lecture. Just a question about diagnosis, since it is very important. Practical question. In your clinic, how do you do the typing? Do you send it out? Do you do it in-house? Do you rely on immunohistochemistry, or do you just do mass spec for everyone?
This is a very important question. So if you have mass spec, it's the best. What I do is we have a collaboration with Mayo, so we send it to Mayo Clinic. In terms of immunohistochemistry, I can tell you it's maybe I would accept it if it's in the kidneys, because the pathologists are happy. They tell you it's with immunohistochemistry, I see kappa or lambda restriction, I see the amyloid. So if it's in the kidney, it's only the kidneys, and I don't have mass spec, I might consider it. That's a diagnosis of AL, but otherwise I try to get the AL, especially if you have a patient who presents only with cardiac and a neuropathy. So this is might be ATTR. So in this patient, I would fight for the mass spec. So mass spec is needed.
شكرا دكتور عبد الله. We were talking about late diagnosis in myeloma, and even with amyloidosis is much later. We have all of us, we have experience with like patients who are presenting very late and we cannot do anything for them at that time. From your recommendation, from systemic point of view, how can we improve early diagnosis for amyloidosis and also for myeloma?
So I mean, the most important thing is, I believe, is education. So family physicians, where do these patients present? They present mainly to the family physician. they present to the cardiologist, the nephrologist, and the neurologist. So early education and increased awareness about amyloid is very crucial, and advocating for early testing, if especially in patients, if you don't know what's the cause, or if they are not doing well on treatment. So I believe the education is the most important thing, and early referrals.
Well, thank you. I guess no more questions. All right. Thank you, Dr. Abdullah. With this, we conclude the non-sponsored myeloma session, and we will come to the sponsored myeloma session that is chaired by Dr. Ghazi. But before Dr. Ghazi starts, I would like to announce that we have an open trial, the monumental trial in our center. So if you have patients, you can call me or call Dr. Abdullah or anybody to include patients. It's about patients who have relapsed after at least one line of therapy that could be randomized to either teclistamab plus talquetamab or talquetamab, POM, or standard of care, which is PVD or LOPD. So please don't forget if you have such a patient. I mean, the main issue is using pomalidomide.
Yeah.
So with this, Dr. Ghazi, floor is yours.
Thank you very much, and thank you to the myeloma team for bringing time back on track. So the next session is the satellite symposium sponsored by Johnson & Johnson. Actually, the next two sessions. The first one is a very interesting topic. Will be presented by my colleague Dr. Amr Abdul Jalil, who's a consultant hematologist from the Eastern Province King Fahd Specialist Hospital. He's actually a really instrumental member of the Saudi myeloma group. He'll be talking about the Maya protocol. So basically, DRD versus VRD in transplant ineligible population. So Omar, the floor is yours.
Thank you, Dr. Ghazi, for the introduction. Thank you for the organizing committee for inviting me today, and to Janssen as well. So I'm sure you've all seen the topic's title on your agenda. It's quite long and descriptive title. But it is essentially about DRD, Daral index versus VRD, bortezomib Lindex in the transplant ineligible myeloma. Now, why those two? Because these are the two most widely used regimens in the transplant ineligible myeloma. You might be wondering, well, isn't the debate now about quad treatment? True, but it's not been widely adopted as of yet due to many issues. This is still emerging data, and it's surely be coming over the next few years. So the question here is, we have been using these two, but there hasn't been really any head-to-head data suggesting which one is better. So this is what we are going to discuss here today. And I'm not going to be, bringing up all the protocols for transplant ineligible newly diagnosed myeloma, and we're going to focus solely on those two regimens. And if we have enough time by the end of this lecture, I'll present a case that we can learn from. So can we put the slide? So yes, so a few words of wisdom, since we're talking about transplant ineligible myeloma, a patient cohort that's in many ways are in the older population. So when an old man dies, a library burned to the ground. That's an African proverb. So what it means is that those elderly carry such invaluable knowledge and experience and tradition that it cannot be replaced. Desmond Tutu, a South African bishop, said, "We are made for goodness and we are made for love. And the elderly are our wisdom keepers." Dr. Atul Gawande, a surgeon, he wrote in his book, Being Mortal, "Our ultimate goal, after all, is not a good death, but a good life to the very end." So remember, when you're treating your elderly, is that don't give up on them. Try to give them the best quality of life that you can. I'm not going to dwell on this slide. You all know the myeloma diagnosis, CRAB, and now slim CRAB. But remember the precancerous condition of MGUS and smoldering myeloma. It is the second most common hematologic malignancy. After a non-Hodgkin's, myeloma represents 10 to 15% of these hematologic malignancy. Median age in the West is 69. And in the US, there are 35,000 new myeloma cases annually, but it's only 7,000 undergo transplant. And what that tells you is that for the most part, those patients are transplant ineligible patients. But the survival has improved over the years. Back in 2014, just 10 years ago, it was 5 years for myeloma patients. The estimated average survival now is around 15 years. And this is a typical age distribution where you see the peak in the older age between 65 and 75 and 80. And although it is true in our population, our median age of diagnosis is 59. So we have more transplant eligible patients in our cohort. And as you can see from that, although there's a minor peak in the older population, their 70s, we still see commonly patients in their 40s and in their 30s with myeloma. So we tend to have more transplants than what happens in the West. So myeloma survival have increased, as we said, over the decades. But as we remember, and Dr. Ghazi mentioned this before, myeloma is, for the most part, an incurable disease. I often tell my patients, probably if you live 1,000 years, you're probably going to have relapses for 1,000 years. So, with each successive treatment, you get your best response usually when the first line of treatment, and the deepest response in the first line of treatment. And as you move to successive relapses and successive treatments, this becomes shorter and less with less depth. So this is why it's important to always consider your best treatment early on. And also deeper responses, including the MRD negativity, has been shown to be a surrogate to a significantly extended survival outcomes in myeloma. And this is because of, all the introduction of all the new novel agents right now, starting from 20 years ago with bortezomib, all the way now with bispecifics and CAR-T, whether it's as a single agent or in combination therapy. But let's not forget, this is a bit of tangent, let's not forget where it all started. So I presented this in the webinar before. The very first trial in myeloma actually was actually back in 1966. This was published in Blood, if you can believe it. So this was a urethane versus a placebo, which was cherry flavored cola. So actually that showed no difference. And in fact, those who had urethane, which is a nitrogen mustard and a chemo, died earlier, and the control enjoyed their cola. So how do we approach frontline therapy in those patients? So the historical battle, Ghazi mentioned here, cure versus control, for the most part is control. We're trying to extend their survival. As of now, we don't have cure for myeloma. There is now the quad therapy is emerging for this subset of patients, and consolidation therapy, we're looking at MRD negativity as a goal. It hasn't been a standard of care as of yet. And now maintenance is part of any treatment in myeloma and its successive relapses. Since we're talking about transplant ineligible myeloma, those are not eligible for transplant, but maybe some of them can have consolidation with CAR-T in the future. So treatment paradigm of myeloma, you all know this. If you're transplant eligible, induction, consolidation with transplant, maintenance. If you're ineligible, then you go with induction and continuous therapy, maybe taper some of that treatment later on. So why do we care much about transplant? Well, because time and again, hematologists have tried to, take out this transplant. It's a toxic procedure. Patients, don't feel well afterwards. They take a few months to recover. But time and again, even in the latest trials, the determination, the IFM trial, showed that those who do undergo transplant in the VRD era, they still do much better than those who did not have transplant. So who is a myeloma transplant candidate? Is it all about age? Well, somewhat. I mean, we always say it's not chronological, but you won't transplant a 90-year-old. But if, it's a combination of, age, performance status, organ function, and then you go ahead and give them high-dose melphalan, which is usually 200 milligrams. Or if they're not a candidate, then you don't transplant. Some will give somewhere in the middle a dose of 140, but there is conflicting reports about the value of giving 140. And recent EBMT report data suggests that it showed no survival advantage in giving melphalan 140, except for some subset of patients with suboptimal response to induction therapy. So this is the evolution of therapy and transplant in eligible myeloma. It all started with melphalan prednisone. Then they thought, okay, let's add a drug to that, thalidomide, bortezomib, lenalidomide. Then they had the VMP thalidomide. Then we went on with IMEDs with Lindex, then the VRDs, and then came in the DARA Lindex, DARA VMP, which is more used in Europe. We don't use it here in the US. And then now the emergence of quad therapy with DARA or azacitidine VRD. So, and we're now moving from fixed duration to treatment back in the day to continuous melphalan-based regimens, well, all fixed because of the cumulative toxicity, the risk of long-term leukemia risk, and also with bortezomib and thalidomide, they were also limited duration because they had this neuropathy risk. And the introduction of lenalidomide, subsequently DARA, this allowed for long-term administration and changed the treatment paradigm because they're mostly well tolerated among the patients. So I'm not going to go, as I said, into all trials in myeloma, but this is where it started. Melphalan, prednisone, then, well, we thought adding thalidomide to MP is better than MP. And then the VISTA study looked at bortezomib MP, and it showed that it was better than MP alone. And then, well, a subset of patient, well, looked at different PI combinations and showed that for frail patient, VD is okay, bortezomib dex. And then the first trial, looked at Lendex and showed that continuous Lendex better than a finite course of Lendex and better than MPT. So let's start now with the first trial that started VRD which was the landmark trial, the SWAG trial study. So this one recruited more than 500 patients, randomized to VRD, and the control was RD, and then followed, this was around 6 cycles RD, 8 cycles of VRD, and then RD maintenance until progressive disease or toxicity. Now, have in mind, this actually was not a transplant ineligible population. They did not have transplant, but they were rather had no immediate plan for a transplant at that point. However, 1/4 of those patients in this study were transplant ineligible. So we all know this data by now. VRD showed significantly better median PFS, but that also translated to a median overall survival advantage as well. So 6 months of bortezomib in the VRD arm gave them 12 months of overall survival advantage, and hence why VRD always became a standard in transplant eligible and a transplant ineligible at that point. But then this was a post hoc analysis of efficacy and safety. And this was stratified by age, done by the author of the trial. So they stratified it between patients above 65 and below 65. So if you look at the right-hand side here on this table, so above 65, this is being a proxy for transplant ineligible patients, right? So if you look at the PFS, the PFS here is 33. It is compared to 55 for those younger patient population. This also translates in their overall survival with a median of 63 compared to not reach for the younger patient. And even grade 3 or more toxicity and treatment discontinuation was higher in both the VRD and RD in those older patient population. So those older patients, although they did have a good PFS, it wasn't nearly as good as those who were younger and more transplant eligible. And this paved the way for VRD Lite, which basically is reducing the dose of lenalidomide. So the SWAG gave everybody 25 milligram, even those who were frail, something we might not do now these days. So the VRD Lite now is a lenalidomide lower dose, 15 milligrams, lower dose of dexamethasone at 20 milligrams, and it produced good results, median PFS of 35. But if you looked at the post hoc analysis, it's not that different from what they had in the older age population at the median PFS of 33. So what about the Maya trial and the DARA Lendex? So this looked at DARA Lendex versus Lendex. Now the median age in this is a true transplant ineligible population. So and the median age was around 73, 74 respectively, and it was disease until progression. The primary endpoint was PFS. You all know this by now. The DRD produced more overall responses, better depths of responses, more VGPRs, 80% or more compared to 50% or more, and even tripled the MRD negativity at 24% compared to 70%. This translated to a higher PFS at 30 months of 71% DRD versus 56% for RD. A longer term follow-up at 64 months showed that the more separation of curves for the PFS and the median DRD. Now PFS is around 62 months compared to 34 and a half for the RD. But this also translated now to an overall survival benefit, where the median DRD was still not reached at 60 months and the RD at around the median of 64 months. They also looked at MRD status, and this is something now a lot of trials are looking into. So if you achieve MRD negativity, whether with RD or DRD, you still do better than those who do not achieve MRD negativity. But if you notice here in the top two curves, DRD MRD negativity is still did significantly or statistically better than those with RD MRD Lindex MRD negative. Why? Because it's not just enough to achieve MRD negativity, it's the quality of the MRD negativity. So it's sustainability of your MRD negativity. So if you notice here, patients with Lindex did not sustain, only 4% sustained the MRD negativity after 2 months compared to almost 18-19% in the DRD. But it's not only that. Not many do achieve MRD negativity compared to that. As we said, 11% only in RD and triple that in the DRD population. And DRD was found to be beneficial in almost all the subgroup analyses, save for maybe those with very ultra high risk patients, 2 or more high risk cytogenetics, where no difference was shown. But Facone presented in the last EHA 7-year overall survival update. And now the median DRD, median overall survival for DRD at 7 years was 53%. And the median of 90 months. And if you think about it, the median age of Maya trial was 74. So you're telling me at 7 years plus, you can, more than half of the patients can reach more than the age of 80. So you're giving them with a combination, an average life expectancy that is comparable to the normal person, anywhere in the world. So it is a very good regimen. It's only one combination that can give them that. We also looked at the impact of frailty, and the non-frail patients had longer PFS than the frail patients. But the PFS benefit of addition of DARA was maintained across those subgroups. And of course, when it comes to adverse event of grade 3 or more, the most common ones are neutropenias, which is around 50+% with that combination, and infections, but particularly pneumonia with around 19% of patients. But this is a comparative summary for the SWOG and DRD in terms of the treatment emergent adverse event. So peripheral neuropathies obviously is more with VRD. This is why it's not a continuous treatment. Neutropenia is more common with DRD. It's still around 28-30% with VRD. And infections is a bit higher on DRD and mainly with pneumonia. Infusions reaction is not really an issue now because DRD, DARA is given subcut. Fatigue and GI toxicity more or less is similar. So a takeaway from the side effect comparison is that VRD is more neurotoxic, and which is key when you consider giving the treatment for frail patients. DRD has more myelosuppression and infection risk, but it is better tolerated in the long term, something we have seen in practice. So this also paved the way. Well, we have a lot of possibly more infections with DRD. What can we do to improve that? So in the last ASH, there was an abstract on trying to ditch the DEX with DRD. So lose the DEX after a couple of cycles. So they theorize DRD and RD are common regimens in the transplant ineligible and frail patients. However, the rates of infections in pneumonia was still high in the DRD compared to RD. So they hypothesized that maybe dropping DEX could improve the infection rates. So this was truly a frail and older population, more than 65, but truly frail. They had Daralin versus Lindex. So the thing about the Daralin arm is that the dexamethasone in this arm had only been given in the first 2 cycles, then been dropped completely afterwards, and the treatment was until a progression or toxicity. Primary endpoint was PFS, and as you might expect, Daralin had a median PFS of around 53 months compared to 22 months with RD, so almost comparable to the median PFS of Maya. Maya had a bit higher, but when you look at the infection rates and the neutropenias, 46% of neutropenia, but mostly not grade 3, and the pneumonias was around 19 to 20%. in the Maya trial is now only 3% in this study. So they concluded, the authors, that DR improved PFS and survival, but without increasing the infections or treatment-related adverse events. And they would consider this a practice changing, that you don't possibly need give dexamethasone beyond 2 cycles, especially in this patient population, the old, the frail. You have to be really mindful. So okay, so we talked about VRD, we talked about DARA, Lendex, but you can ask, well, Omar, we don't know which one still is considered better. Well, the answer is there has now been prospective randomized trials looking against, pitting both against each other. But there has been retrospective studies. So this study, which is a multi-center studies published in the Lymphoma, Myeloma, and Leukemia, looked at PFS of DARA RD versus VRD in a newly diagnosed myeloma patient transplant ineligible, and they called it the TARAS chart review study. And it's multi-center, 9 sites, and it was done to help inform the selection of the optimal first-line treatment for transplant ineligible. And it's the first real-world head-to-head study comparing the PFS treated with DRD or VRD. So it's non-interventional, only included patients were 65 or older, and were considered transplant ineligible by the treating physician. They included all DRD patients and then a random sample of VRD to match the number of DRD. Obviously, VRD patients were higher at that point because it was an older combination. Then were followed until the last date of clinical activity or death, no later than January 2025. This is the method of the study. The primary outcome was the PFS during the first line, and defined as the time from the initiation of treatment to disease progression. So these were the baseline characteristics, and the pre-weight, there was some discrepancies between the characteristics between DRD and VRD, which is expected when you do some kind of a historical chart review comparison. But then after weighing, there were remaining 91 DRD patients and 87 VRD patients, and the characteristics were well balanced between those cohorts. Median follow-up was around 18 months and 20 months respectively. So what were the results? So the comparison showed at the data cutoff that 14% of patients of DRD and 28% of patients with VRD experienced disease progression or death. So double that than DRD. And a 12-month rate of patients without progression or death was 93.94% in DRD and 74% in VRD. So this analysis showed that the patient treated with DRD had a 65% lower risk of disease progression or death compared with first-line VRD. As you can see here, the hazard ratio is 0.35, and that had a significant p-value of 0.005. So they concluded, what's that?
2 minutes.
Is it?
Absolutely.
Okay, so I guess we'll not discuss the case. I'll finish it quickly. Death, DRD was associated with a lower risk of disease progression or death compared with VRD as first-line treatment. So I will go to this other study, and this is the last thing I'll present. This study was done by the authors of the Maya and SWOG, so by Dury and by Facone. So they wanted to see which one also is a better regimen, adjusted indirect treatment comparison of PFS with DRD and VRD based on the Maya and SWOG. So obviously data sources were Maya and SWOG, and they only included patients who were 65 years or older as a proxy for transplant ineligible. There was a propensity score weighting and an anchored ITC using RD as a common comparator. So RD was both the control arm in both studies. So what was the result? If you look at the PFS in the third line, DRD versus VRD indirect comparison, the hazard ratio was 0.59 and it was statistically significant in favor of DRD. And the sensitivity and subgroup analysis showed that it confirmed this robustness of results. Again, the third line here, DRD versus VRD in this patient population also has a ratio of 0.57. However, a small sample size in these subgroups. And they concluded that DRD showed a superior PFS compared to VRD in this transplant ineligible population, which can guide treatment decision in practice. And it supported the clinical preference for DRD in transplant ineligible myeloma, and it was associated with a significant reduction of 41% in the risk of disease progression or death. Obviously, there are limitations to this study being a historical retrospective historical control. So since we're at the end of the talk here, is just these guidelines now continue to change rapidly, and the latest iterations of these guidelines look into quads as to be, now we're dividing patients: transplant ineligible, frail, transplant ineligible, non-frail, maybe consider quad, maybe not. But if you not have quad, consider DRD maybe in standard risk. The ESMO guideline is kind of outdated and due for an update. I came across the Memorial Sloan Kettering approach. So what they do is, for transplant ineligible, DRD for all standard risk patients, and DRD DARA VRD light for high risk patients, with only a few exceptions. So this is our previous consensus in the myeloma Saudi or the Gulf Saudi Gulf myeloma group. DRD and VRD were preferred option lines. That was 2 years ago. And of course, we're talking about quads now emerging as possibly new standard in the future. This will also be reflected in our new guidelines in the Saudi myeloma working group, being a quad being used if possible and if available to in the non-frail population, and DRD in the a frail population, or VRD. This is a summary of most important trials, as we talked about SWAG and Maya, and now the emergence of IMROS, CFIUS, and BENEFIT, looking at the quad therapies. That'll be the end of my talk. We'll do the cases maybe some other time. Thank you.
Thank you very much, Dr. Omar. Really wonderful summary of transplant ineligible, literature. Any questions? Dr. Abu Harbish?
And they are in their 70s, but in reality, actually, most of our myeloma patients, they are much, much, much younger than this age. Yeah, we are seeing patients with multiple myeloma in their 40s. This is my point, which just want to mention. The other point, which I think regarding the dexamethasone, that omitting the dexamethasone, and because in the trial, if you look, you are giving big gun, which is the Revlimid with
Lendex versus Dara-Lin.
yeah, Dara and Revlimid.
It's not a fair comparison, yes.
Yeah.
Yes, you're right.
There is no way. So I think dexamethasone, it will stay forever. And four of us, all we are a clinician, we are seeing patient, and sometimes, this patient, he's not fit for treatment. So we just give him dexamethasone.
Yes. So you're absolutely right. So for the first point, you're absolutely right. That's what I mentioned, that in the West, most patients are not transplant eligible, but our patient population are for the most part transplant eligible. In our centers, around 70 to 75% of patients. But what to do? The question is what to do with the other patients, the transplant ineligible. What is the best treatment to give out there? So that was mainly what I'm focusing on. In what you mentioned about steroids being there, well, you're right. I mean, we all feel reluctance to change some kind of a standard of therapy, but you remember low dex therapy, which is the 40 weekly that we give now, used to be high dex therapy, which is 4 days on, 4 days off, and everybody thought, oh, you guys are mad to changing this to 40 weekly. So, and then we went to with the light regimen 20 weekly. So you never know about this whole dropping the dex. It could be something good eventually for the patient. Although you're right, this is not a fair comparison. I tried to compare the RD to the Maya arm, and showing that, well, they do have less infections, a very comparable PFS rate to the Maya trial.
Thank you, Omar. Dr. Musa?
Thank you for the lecture. Just a question about what do you think about generalizability of the trial on our population? Because as you know, the racial representation of patients in the States is not very well balanced, and even there are differences between Black and Caucasians, but in
Absolutely.
our population also, like tolerability and things like that. So what do you think that this is generalizable, or we need to publish our own data?
Yeah, I mean, I think you answered the question as well. And as for those who attend ASH in the last few years, it's all about inclusivity and looking at, and any trial, including, these minority patients, Latinos, Black African Americans population. Obviously, the Middle Eastern population is not well represented in this group. So honestly, you're right. We definitely have to start, doing our own trials to extrapolate this data actually does hold true to our population, because we do tend to see our patients maybe not tolerating not just myeloma treatment. We've seen it like treatments across hematology spectrum. In the West, they would give maybe hyper-CVADs in their 60. We give it in their 40s and 50s, and they end up in ICU sometimes. So you're absolutely right, but unfortunately, we don't have any other option for the timing, and this paves the way for us to start maybe starting our own trials in this patient population.
Okay. Shukran, Omar. Thank you very much.
Thank you.
And so moving on for the last session before Friday prayer, we've got a way more interesting topic. We always talk about CAR-T, and it's presented by even a way more interesting speaker. So Dr. Ahmed Al is a very senior hematologist at National Guard Jeddah. He's a founding member of the Saudi Myeloma group. He's been actually instrumental in the foundation of this, excellent group. So Dr. Ahmed Al is going to talk about the role of CAR-T in management of myeloma. So, Dr. Ahmed.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Ghazi. Thank you, organizing committee. And thanks for Johnson. So, continuing talking about myeloma after bispecific and some conventional, now we'll talk about, I think, one of the most interesting maybe treatment for myeloma nowadays, about CAR T cell and myeloma. So we'll try to see what is the situation of using CAR T cell in myeloma internationally, and I'll try also to see what can we do for our patients here in Saudi Arabia. So starting with that, the treatment of myeloma continue to evolve over the last 6 decades. And as mentioned earlier, that steroid was the treatment of choice 60 years ago, then melphalan introduced, and with time, we have more and more, and especially for the last 15, 20 years since the introduction of Velcade, lenalidomide, and now we have more and more treatment. And now if we see what are the recommendations now for frontline treatment in 2025, last year we had 2 phase 3 randomized trial recommending quadruplet as a frontline treatment, whether in transplant eligible or non-transplant eligible. So majority of the patient now, they will go for quadruplets, and then maintenance. In addition to the standard of care lenalidomide, there is also interest in using anti-CD38 also as a maintenance treatment. And with this approach, we see the overall survival of myeloma patients significantly improved. But despite of this improvement, myeloma, still we inform our patients this is incurable disease, and majority of the patient, they will relapse, so they will need treatment. And now it's difficult because, as I mentioned, that we are using the quadruplet in majority of the patient as a front line. So when they relapse, what to do for them, and especially if we are using a maintenance with lenalidomide and anti-CD38. So these patients, or many of these patients, will be considered as a lenalidomide refractory patients. And historically, we know that the outcome of these patients, unfortunately, is not that good. So now we have a challenge if we are using a quadruplets and maintenance treatment, and when they relapse, so we are already used our conventional treatment. So this is why we have to think and to have a new concept or a new mechanism of some medications. So we consider a novel therapy for patients with myeloma who relapsed. And the T-cell redirected therapy for multiple myeloma is very interesting now, and most of the work is actually on the T-cell redirected. So we have CAR T cells. We have already 2 CAR T cells. We have bispecific. We have 3 bispecific approved recently, and we have also drug conjugate. And this also affect now the treatment of relapsed multiple myeloma. And my talk will be now just focused on the role of CAR T cell. Bispecific already discussed earlier. And now we have two approved CAR T cells by FDA and by EMA in relapsed refractory myeloma. We have ide-cel and we have cilta-cel. And ide-cel is approved by FDA in after 2 to 4 lines, and it's not approved yet in Saudi Arabia. Cilta-cel is approved after 1 line of treatment, and it's approved by Saudi FDA. And as you see in the first relapse, cilta-cel now is considered one of the option of treatment for patients with relapsed multiple myeloma. This also has an impact on the use of cellular therapy in myeloma. So if we see the activities of all transplant and cellular therapy in hematological malignancies in general, we see there is increased sharp of using CAR T cell in the last few years, in addition, of course, of allogenic and auto transplant. This includes all hematological malignancies. But if you focus more on multiple myeloma, you see there is a significant increase of using CAR T cells in multiple myeloma with the stable or a steady use of auto transplant and decrease in allogenic transplant in these patients. And if you go by CAR T cell use by indication, we see that the multiple myeloma in 2024 was the second indication after large B-cell lymphoma. In CIBMTR data, there are about 2,000 cases of multiple myeloma used CAR T cell in the last year. And most of these CAR T cells was cilta-cel. We see the significant increase in the use of cilta-cells compared to the ide-cel. So more and more use of CAR T cell in the treatment of multiple myeloma landscape. As I mentioned, we have 2 approved CAR T cells in multiple myeloma, and the evidence of using this initially comes from 2 trials, KarMMa-1 and CARTITUDE-1. So KarMMa-1 for ide-cel and CARTITUDE-1 for cilta-cel, and they were used in patients with multiple relapse. So the median line of prior lines of treatment in these 2 patients was 6 lines. So imagine myeloma patients after 6 lines of treatment. So what was the outcome? Impressive outcome for both of them. So the median progression-free survival with ide-cel was 8.8 months, but the most impressive one is the median progression-free survival of cilta-cel, which was 34 months, 3 years. So myeloma patients after 6 lines of treatment, when we use cilta-cel, we have a 3 years progression-free survival. So they are working after 6 lines. Can they work earlier? And this usually what happened with all treatment lines in multiple myeloma. They start initially in multiple relapsed patient and they moved early. So yes, they were tested, both of them, and ide-cel was tested in KarMMa-3 in a patient who received 2 to 4 lines of treatment, and it showed an overall response rate of 71% and the median progression-free survival of 13.3 months. Now we will focus more on the CARTITUDE-4 study, which is using of cilta-cel in early relapse of multiple myeloma. So as you know, cilta-cel is a BCMA-directed CAR T cell with 2 BCMA targeted in single domain antibodies. So cilta-cel tested in CARTITUDE-4, which is a phase 3 open label randomized trial testing cilta-cel in a patients with lenalidomide refractory multiple myeloma, and the eligibility criteria includes 1 to 3 prior lines. Patient, they could have auto transplant and they could use also anti-CD38. So randomized cell-to-cell against standard of care for relapse like DBD or BVD. And the primary endpoint was progression-free survival, and many key secondary endpoints, including CR, MRD negativity, overall response rate, and overall survival. So 400 patients were randomized, and 208 patients were randomized to cell-to-cell. All these patients were leukapheresis, but only 84.6% received the cell-to-cells, which means that there are 15% of patients they could not go for the infusion, and mostly this is because of a disease progression, and this is a challenge in all CAR T cells in myeloma and lymphoma, auto CAR T cell. So coming to the baseline characteristic, it was generally balanced. You see that the median age is 61, and the median prior line of treatment were 2. 1/3 of the patient, they received only 1 line of treatment. And the high-risk cytogenetic group was around 60% of the patients, and around half of the patients, they were refractory to NPI. Just to remind you, all these patients were lenalidomide refractory patients. So what is the efficacy of cell-to-cell? So initially, the study was presented at the median follow-up of 16 months in June 2023. And the median progression-free survival was not reached for the cell-to-cell group compared to 11 months for the patients with the standard care with a significant hazard ratio of 0.26. Then we will talk more about the updated efficacy at follow-up of around 3 years, 33.6 months, and this including pre-specified overall survival analysis. So at 30 months, the rate of overall survival in cell-to-cell group is 76.4 compared with 63 or 64% in the standard of care, with a 45% reduction in risk of death, and the median overall survival not reached for the cell-to-cell group. So this is the first CAR T cell in myeloma, which showed an overall survival benefit in relapsed refractory multiple myeloma. This survival benefit is seen across all the subgroups. So everyone is benefiting from cell-to-cell, whether high risk, whether regards of multiple lines, or regards of what treatment they received before. Now, for the progression-free survival at 3 months, the rate of progression-free survival was about 60% in the cell-to-cell compared to 26% in the standard of care, with a 71% reduction in the risk of progression, and the median progression-free survival was not reached in cell-to-cell group. The depth and the duration of response also was significantly in favor of cell-to-cell. And as we see that the depth of response is improved over time with cell-to-cell. So at 16 months, the stringent CR was around 60%, and at 3 years, it even improved, and it's about 70%. And the median duration of response was not reached in the cell-to-cell group. MRD negativity, as mentioned earlier, the MRD negativity in myeloma is a surrogate marker for better survival. And as we see, the MRD negativity is significantly improved either to the power of 10 power -5 or -6. It was significantly better in cell-to-cell compared to the standard of care. So cell-to-cell in CARTITUDE-4 showed improved progression-free survival, overall survival, response rate, and duration and deep of response. Now, what about the safety profile? Always there is a concern about the safety profile of using CAR T cells in hematological malignancies. So 97% of patients, they have grade 3 or 4 hematological toxicity, and it was similarly compared to the standard of care, and this was expected, but most of these patients, they improve, and by day 60, by 2 months, majority of this grade 3 and 4 hematological cytotoxicity improves, and only minor patients will continue with more than grade 2. Infections, so there were around 62% patients had infections in cell-to-cell compared to 71 in the standard of care group. And the grade 3 was also similar, around 26%. But just keep in mind the study was done at the era of COVID. Now, talking more specific at CAR T-cell specific toxicity like CRS. So CRS was seen in about 83% of patients, but fortunately it was mostly grade 1, grade 2, and only 4% they have grade 3 and 4. The median time to onset of CRS was about 1 week, and the median duration of CRS was 4 days. And luckily, all the CRS patients' symptoms, had resolved. So CRS is not a major issue with myeloma CAR T-cell. One of the most interesting, and it's still under a lot of discussion, is the neurotoxicity of CAR T-cell in multiple myeloma. So from CARTITUDE-4, the rate of neurotoxicity was about 20%, and the grade 3 or 4 was about 3%. These neurotoxicity included ICANS, which was seen in about 5% of patients, and also included some other neurotoxicity like cranial nerve palsy, peripheral neuropathy, and movement and neurocognitive toxicity. There was an analysis of around 400 patients of myeloma who were included in different trials of cell-to-cells, not only CARTITUDE, and the ICANS the neurotoxicity was seen in about 23% of these 400 patients, with the 5% of patients had grade 3 and 4, and the ICANS were seen in 11% of the patients, with the grade 3 or 4 seen in 2%. The median time to onset of ICANS was 8 days, and the median duration was 3 days. Other important toxicity of CAR T cells in general is the secondary malignancies. And in CARTITUDE, there were a similar rate of secondary malignancies between CAR T cell and standard of care, around 13%, mostly cutaneous. There were some few cases of hematological malignancies. So in conclusion, one-time cell-to-cell infusion significantly prolonged overall survival and improved quality of life in these patients. So because of this now, as I mentioned, that CAR T-cell, cell-to-cell is an approved indications for treating patients with relapsed refractory multiple myeloma after 1 line of treatment. So if it is working after 6 lines and working after 1 to 3 lines, could it work after, for newly diagnosed patient? And there are ongoing trials, not approved yet, but there are ongoing trials testing CAR T-cell in the newly diagnosed multiple myeloma. And CARTITUDE-6, which we all are interested to know, is comparing cell-to-cell versus autotransplant in the front line. And we will wait and see the outcome of this, which might also change the routine practice. So what are the future of CAR T-cell development in myeloma? There are novel targets now. This is BCMA. There are other targets like GPRC5D, and there are ongoing trials of using CAR T-cell for GPRC5D. And not only that, there are dual CAR T-cell where we are targeting BCMA and GPRC at the same time. And there are a novel construct, allogenic CAR T-cells is also under a lot of investigation. And anito-cell is D-domain BCMA, where we're using synthetic binding protein to minimize the toxicity of animal products. And in conclusion, CAR T-cell therapy in myeloma is associated with high overall response rate and promising duration of response, acceptable safety profile, and use of CAR T-cell in earlier lines is coming soon. Now in Saudi Arabia, in our center, in Princess Noor Oncology Center, we are working to have the first patient on cell-to-cell expected will be in 2 to 3 months from now, inshallah. And there are also other centers in the kingdom. They are also working to have to bring cell-to-cell to our patient. In the last 1 year or 2 years, we used to send some patients after multiple lines of treatment to do CAR T-cell in United States, and they do CAR T-cell, they come back for follow-up, but hopefully we'll have it soon this year, inshallah, available for our patients. And by this, I come to the end of my talk, and thank you.
Thank you very much, Dr. Ahmed. Very excellent summary of the CAR T space in myeloma. So we have only one opportunity for one question, which is usually to Dr. Ayman Hijazi.
And I have one question and one issue.
We'll start with the question.
With the question first. So we have the ide-cel and the cell-to-cell that is approved in myeloma so far. There is a huge difference in the PFS between these two CAR T-cell therapies in myeloma, around 9 months, and this is almost 3 years. But what is concerning about cell-to-cell is the presence or the development of non-ICANN neurotoxicity movement disorders that have been seen lately in these patients. About 5% of patients who went through the CARTITUDE study developed movement disorder. Now, having such a major side effect, it's not negligible. It's about 5% of patients will develop this. And would you trade this late onset profound neurotoxicity with a median PFS of 9 months or 10 months from ide-cel? Or what would you do? How would you choose your patient between ide-cel and cell-to-cell, given the late neurotoxicity that could arise?
يعطيك العافية. I mean, this is, as I mentioned, a hot issues in myeloma, but there are certain things we have to mention. The approval for cell-to-cell and ide-cel is different in the far, like cell-to-cell is approved after 1 line, ide-cells after 2 lines. As you mentioned, the progression-free survival is significantly different. And I showed one graph in CIBMTR, how significant increase the trend of using CAR T-cell in US is mostly now is cell-to-cell, and even in Europe. Now, coming back to the neurotoxicity, it's a major concern, but we are learning with time, and we see now the majority of reported non-ICANS neurotoxicity was with CARTITUDE-1. CARTITUDE-4 compared to CARTITUDE-1 is much less of neurotoxicity. So is it because the type of patients are different, the heavily pre-treated patients, and we don't know. But there is clear data that the neurotoxicity with treating patients earlier with CAR T-cell is less than patients who are treated after late or after multiple lines. I cannot compare. There is no comparison between ide-cel. This is indirect comparison for progression-free survival and for toxicity.
If you could say, ide-cel has shown actually a very favorable safety in the elderly.
In the elderly, yes, but it's indirect comparison. It's indirect comparison, and as I mentioned, what is seen now is significantly shift to cell-to-cell.
And
I'm not advertising, but I'm showing what is available.
I mean, BMS will never bring
I brought this CIBMTR curve just to answer your question.
If I have the choice of both, I'll probably leave the choice to the patient.
But no, you have efficacy at one time
versus toxicity.
So we have to balance this, and patients, they are not the same. Even we will learn more and more which type of patients will benefit, for example, from bispecific, from CAR T cell, from other things. So as you know, myeloma is a heterogeneous group, and the risk stratification of myeloma is depending on multiple factors. So I'm sure there is no one treatment will fit all the patients.
There's actually area cell that is has a PFS of about 30 months with no neurotoxicity that's been presented in last time.
والانتشال كمان. طيب. Access, yes.
Yes.
Yeah.
I mean, BMS will never bring ida-cell to the region, so
BMS
we shouldn't actually.
So we will have only cell to cell. You will have cell to cell in few months.
طيب, the issue.
Okay.
The issue is about
2 seconds, please.
2 seconds. The issue is about Cartitude 4, which have used CAR T in earlier lines. I do not really think that it's a fair comparison given the comparator arm, where they have used only DARA-PD or PVD, which is POM-based regimens that give you a PFS of around 1 year. I mean, the most commonly used regimen in the relapse setting is carfilzomib-based regimen plus anti-CD38, which gives you about 28 to 34 months. So,
I meant for clinical trials, the issue of
you
control arm,
use the weakest
control
arm to show
So,
difference.
if we'll talk about this,
But it's not the difference that we're looking at here. It's not a p-value comparison. It's actually a PFS of 33.4 months. So I think it's meaningful to look at the.
It is.
Yeah.
It is. But the comparator arm is not the usual standard of care.
But at that time, this was done 5-6 years ago, or even.
It's in the NCCN box.
It is.
Okay, I think we'll leave it at this. Thank you very much for the attendance. We've got a couple of seconds to actually, thank the sponsoring companies. This will be led by Dr. Ahmed. Thank you, Dr. Ahmed.
Thank you so much for all the speakers and the moderators for the previous sessions, and most importantly for the attendees who showed up here on time and participated in the discussion. First I will call Prof. Ahmed Al-Askar and Dr. Hatim Al-Ahwal, the chairperson of the scientific committee, for honoring our sponsors. First, we would like to thank the sponsoring companies for their contribution. These meetings would not happen without their support and their dedication toward education and supporting the scientific committees. First, we'll thank our main sponsor, Johnson & Johnson. Second, our platinum sponsor, Vertex. Thank you. Our gold sponsors, starting with Sanofi. And our gold sponsor, Comel.
شكرا طول عمرك شكرا
Thank you. Our silver sponsors, Stago, موجود represented. Okay. Bronze. Okay. Stago ما حد منهم موجود صح؟ خلاص. Our bronze sponsors, Biologics.
شكرا شكرا
And Sobi. سميرة بس سميرة هناك بس بعيدة شوي. تفضل. يعطيك العافية.
تفضل. يصير
أهلا وسهلا. يعطيك العافية. And Novo Nordisk. ما في أحد من شركة نوفو؟ أوكي. باقي أحد. And CSL V4. يعطيك العافية.
نعم تفضل.
طيب, I would call everyone to come up to the podium for a group photo, and then we'll have a break for the prayer and the lunch, inshallah. Few things for the prayer. There is a mosque just 10 minutes walk from here, and also there is a prayer room in the MP floor for people who want to pray here. The lunch will be in the MP floor in the Mayara restaurant, and we'll be back here at 1:30 inshallah.
Good idea. Good idea.
يعطيك العافية. الله يسلمك يا رب.
احنا القصار تسلم وجودكم والله.
اي واحد عنده مايلوما يسوي له انتي بروبال
لاين واحد اللي فوق. لا ما شلته، ما شلته برا. ستوريو ريتيرن. ها في صوت؟ ها ايوه في صوت.
طيب السلام عليكم أسعد الله مساكم بكل خير. Good afternoon everyone, and I hope you have all a refreshing lunch, and hopefully you are ready to dive into this session. This session is titled as acute leukemia, and today we have two distinguished speaker. We'll start with Dr. Naif. Dr. Naif Al-Juhani is a transplanter at King Faisal Specialist Hospital and Research Center. He's the deputy chair of the oncology. He's well known in the field nationally and also in academics, published many papers. His talk today is about targeted therapy in AML, a field that continues to change. And hopefully today we will hear from him when to use it, how to use it, what to use in those difficult cases. Without further delay, the floor is yours, Dr. Naif. Thank you.
Assalamu alaikum. I'm just waiting for the new presentation. I'll try to be more concise. I'll give introduction about the molecular landscape in AML, and then we'll go through the approved and emerging targeted therapy in AML. And then we'll go through the resistance mechanism and few slides about challenges and future direction. So we'll wait just for the presentation to come.
Sorry for the delay. Okay, so thank you. Presentation mode. طلع هنا شوفوا لا طلع بس دقيقة ليش خلنا can start slideshow right slideshow يعني أنا عندي ما يطلع كذا مش slideshow اوكي طيب شرفوا هذا خلاص it's okay بس السكرين طالع صح؟ خلاص اوكي طيب شو it's moving can you show the presentation? Yeah, it's not the same here. Okay. طيب, thank you. We'll in the next 20 minutes we'll talk about targeted therapies in acute myeloid leukemia. So my agenda today will be introduction to AML molecular landscape, and then we'll talk about key mutations and actionable targeted therapy approved medications, and also the emerging agents, and a few slides about combination strategies and resistance mechanisms, challenges in real-world implementation, and the future directions, and personalized approach. So the sake of time, we'll try to be short as much as I can. So as you know, AML is a clonally heterogeneous malignancy. There are lots of dynamic and evolving genetic mutations that are identified like every year, and that's why in the every few years we have a new ALN classification and coming with new mutations that have different prognostic and diagnostic kind of either challenges and prognostic implications too. Right now, the myeloid NGS is really a standard of care. So if you kind of acute leukemia center
here in Saudi Arabia. You should have an access for NGS, myeloid NGS for patients with AML. It's now standard of care. It is very important to help you to classify, to risk stratify patient and prognosticate and then choose the right treatment based on the specific mutation identified. More than 95% of AML patients, they harbor at least one identifiable somatic mutation. So it's quite common. If you do the right diagnostics, you should be able to pick most of the important somatic mutations that need to be addressed by specific therapy. Molecular diagnostics are no longer optional. They are central now for AML decisions. So knowing the mutation defines the therapy. So this is an important study that was published this year in blood cancer. And it looked at patients who are having AML, about 591 patients, so a very large number of patients. And they looked at their molecular landscape in terms of what is the most frequent driver gene mutation that lead to leukohomogenesis, progression of patients to leukemia when they harbor this specific mutation. So as you can see, the most frequent mutations here are the DNMT3A and the TP53 and the TET2 mutation. They are present in at least 20 to 25% of patients with AML. And then the rest of the mutations, they can be seen, as you can see on the screen. The RANX1 mutated AML comes next at about 22%. If you look at, for example, the different AML mutations, they have a different frequencies. So that's just to give you the idea of what is the common type of frequent or common type of a driver gene mutation in AML. So those are the three top ones: the DNMT3A, the TP53, and the TET2 mutation. The one on your right side is the most important one to me. Again, this is a large group of AML patients when they looked at this data. So this is variant allele frequency and the top 10 mutated genes on the left side. So what do you notice here? As you can see, TP53, it's very striking, very high VAF percentage. So it has the highest one. And this means that when you have a TP53 mutation in an AML patient, it is usually associated with a high allele frequency. And this suggests that they usually develop early in the leukohomogenesis, and they are the usually driver, or not usually, probably most of the time they are the driver mutation for AML. So that's why now in the classifications, you see AML with a mutated TP53 to have a distinct biology, and they should receive a distinct type of treatment. If you look at the other variant allele frequencies and the other top 10 mutated genes, you'll notice that FLT3 is the one that has probably the lowest VAF. What does that mean? Usually this means that it's usually later event during leukohomogenesis, or it could be sometimes a subclone that is probably not the driving mutation for AML. So that's just very interesting charts taken from this study. Those are the key observations from the previous image, that the DNMT3, TP53, TP2 are the most frequently mutated driver genes from this AML cohort. And the MPM1 and the FLT3, they have the lower VAF, indicating they arise later in leukohomogenesis. Now we have another very interesting image from this study. Just I will try to explain to you the how you can read this chart. Sorry, this image. So what you see here on the right side, I think it's your right side, yeah. So you have the normal karyotype, the complex karyotype. You have then deletion 5q or monosomy 5, deletion 7q or monosomy 7, and then it goes on core binding factor, MML rearrangement, DNMT3A, TP53, TET2. So what you notice is usually there are certain gene mutations that they co-occur together, and there are certain gene mutations that exclusively mutual, meaning they come together. So if you have a patient with AML, for example, who has a complex karyotype, let's maybe look at the complex karyotype here. So the down on the screen. What you notice for the complex karyotype, the most striking mutation co-occurring is what here? TP53, right? So if you have a TP53, most of the patient, they will have complex karyotype. And you really don't need to focus on the other mutations in that specific patient. You just need to treat him as a TP53 mutated AML. So now let's look at the normal karyotype, okay? So the one on the right here. What is the most frequent mutations occurring in normal karyotype AML patients? So the red ones are the most prevalent ones. Sorry, it's here on my screen. It's very tiny, so I can't see it very well. But anyway, so you can see the MPM1 are the DNMT3A. So this is called the triad, usually seen in normal karyotype AML. So you have the MPM1, you have the DNMT3A, and you have the rest of and the IDH2. So usually those are the three co-occurring with the normal karyotype AML. If you look at the FLT3, for example, if you go down here, the FLT3 ITD, so and then you go and we see what could be occurring usually with the FLT3 mutated AML. So the commonest one, as we said, it's the normal karyotype AML. And then you have the DNMT3A and the MPM1 mutation. Okay, 61 and 63. So if you have a FLT3 ITD patient, usually they have associated MPM1 and DNMT3A. So this is just to give you kind of introduction to the molecular landscape for AML patient. Based on the initial findings from the karyotype and the IML FISH, you should really focus on what is likely to be co-occurring with the initial mutation that was detected. That can, save you time and maybe money also over time. So those are just, again, the key observation from the previous chart, that MPM1 frequently co-occur with the FLT3 ITD and DNMT3A, and usually called the mutational triad for de novo AML with a normal karyotype. TP53 is usually mutually exclusive and not associated with another co-mutation, but associated with a complex karyotype. In secondary AML, typically what you see is our myelodysplasia-related changes. So you have the RUNX1, the ASCL1, and the TIT2 mutation seen in this group of patients. Okay, so now we'll move to key mutations and actionable target therapies. So the way I did it is I'll try to summarize, what has been published in this field. So as you can see, those are the categories that I did here for mutation-driven therapies. So you have, for molecular and other genetic and transcriptional epigenetic mutations seen in AML patients. So we have the mutation-driven one. This is similar to FLT3, IDH1, IDH2, TP53. So you have a specific mutation, and you can target that specific mutation, and they are druggable mutations. We have also the epigenetic. This includes menin inhibitors. Menin are usually small molecules. They bind to menin, and they prevent menin from binding to the usual KMT2A or MPM1, so leading to the not leading to the usual transcription of the usual transcriptional factors associated with AML that lead to progression in that specific type of AML. We have also surface antigen category. survival pathway like the BCL2, and the signaling cascade like RAS, SYK, and KIT mutation. So we'll go one by each category, the approved and the emerging therapies. For mutation-driven AML, we do have 5 approved, FDA-approved medications. So this table really summarize all these studies done. Those are the leading studies that led to the FDA approval. So we have the FLT3 ITD, the TKD midostaurin was approved based on the ratified study. It was a phase 3 study, newly diagnosed AML patient. Median age was 47. Patients had ECOG 0 to 1, and 77 of the patients had the ITD type of mutation. TKD has, I would say, less well studied in the FLT3 mutated AML, but usually usually it is known to have likely maybe a less negative prognosis compared to the ITD mutation. But generally speaking, we use midostaurin on those patients if they have a TKD mutated AML. In the ratified study, the overall survival was clearly better, almost more than double in terms of the median overall survival. And the CR rate was about 60%. And right now we use it in combination with 7+3. Now it should be standard of care for FLT3 ITD intensive eligible patients. They should receive midostaurin plus 7+3. And that was based on the ratified study published in 2017. The next one is the gilteritinib. It was a phase 3 study, Admiral study for relapse refractory. Median age was 62. And 60 patients had a prior chemotherapy. The primary endpoint was overall survival, and the outcome was doubled with the use of gilteritinib, and that led to FDA EMA approval as immunotherapy in patients with relapsed refractory AML, that is FLT3 ITD mutated. Midostaurin and gilteritinib are both type 1 FLT3 inhibitors, so they can work in both ITD and TKD. This is different from quizartinib, which is a type 2 and only works in patients with ITD mutated AML. Moving to the third one is the quizartinib, based on the Quantum first phase 3 trial that included patients with newly diagnosed AML. The results were significant, as you can see in terms of the overall survival, 15.1 months compared to 31.9 months, leading to FDA approval. That was published in Lancet 2023. And then we have the ADH2 mutated AML. It is approved as immunotherapy for patients with relapsed refractory AML who harbor the IDH2 mutation. The ENAS idanib is the approved based on that single-arm study back in 2017. And then we have the EVOS IDH1 mutated AML based on the AGILE phase 3 study. Again, showed remarkable results in patients with a newly diagnosed unfit for intensive chemotherapy. Patients 24 months compared to only 7.9 months, and leading to FDA approval about 3 years ago in combination with azacitidine. If we look at the other investigational mutation-driven AML therapies, there are a few. I don't know if we have time for that, but I think these. I mean, the table can summarize. You can table the summary of those results. The EPRINA showed early promise as a TP53 targeted therapy, but failed to demonstrate superiority over azacitidine in the phase 3 studies, so that was not approved by FDA. Magro has a very interesting story that I will come to in the next slide, based on the ENHANCE 2 and ENHANCE 3 trial for TP53 mutated AML. And MPM1, we have an emerging medication called ziftomenib. It's based on a phase 1B for relapsed refractory NPM1 mutated AML. The CR rate were about 30% as immunotherapy, single arm. That was in ASH 2023. I think probably, maybe it will come and approved by FDA soon if in a phase 3 larger study it should maybe with combination with another medication like Vidaza showed better results. For NRAS, KRAS, we have two different medication, the TP and the trimetinib. The results were actually disappointing, I would say. That was done for a phase 1, phase 2 study for RAS mutated AML. And the CR rate were very low. I believe it's like 10 to 11%, and that did not result in FDA approval. So Magro, the do not eat me kind of mechanism. So what happens, as you can see from the slide, so we have the AML blast and we have the macrophage. So what happens usually is the macrophage will eat the AML blast. So this is called do not eat me signal. So you can see it here. So what happens, the magro comes in and block that interaction, okay, between the CD47 and the surface antigen here on the macrophage, and that lead to eat me kind of signal. So the myeloblasts will be eaten by macrophage for this specific surface receptor that occur in TP53 mutated AML. But although the early studies showed some promising data and activity in the specific subgroup of patients, I think the CR rate were about 48%. That had what we call the PTD designation. So it was given a breakthrough accelerated approval. That back was in 2020. But then, unfortunately, Gilead had acquired that specific medication from 47. But later in a larger study in ENHANCE-2 and ENHANCE-3, it actually failed to meet the primary endpoint. So now it still remains investigational and not approved. This is the study taken from just to show you the magro plus azacitidine versus physician choice and untreated TP53 mutated AML, the ENHANCE-2 study that did not show any benefit. Now moving to the approved therapies in the other category, now the epigenetic therapies. So we have a few. We have essentially three medications, the azacitidine, the cytarabine, and revumenib, which is a menin inhibitor. So menin is, it works as an epigenetic modulator. So it's under the category of the epigenetic therapies. So typically those therapies, they target chromatin modifier, DNA methylation, as you know, epigenetic fusion partners, etc. We know the famous study of azacitidine that led to its approval, essentially doubled the overall survival and the CR rate compared to the best supportive care back then, and the same thing also for the cytarabine. Revumenib was recently approved or given an accelerated approval for CAM2A in April 2024, but not for the NPM1 mutated AML, because menin inhibitors can work on both mutations. I don't know anyone use menin inhibitors here in Saudi, because I tried to acquire it, to use it for 2 patients that I have. And the response from the company was the patient has to be in the center that they provide the menin inhibitors. Yeah, they have to travel to either Europe or the States. Go ahead. 2? 3 minutes, okay. That's the approved epigenetic AML therapies. The investigational ones, we have the menin inhibitor for NPM1 mutated AML that I just discussed in the previous 2 slides, the ziftomenib. We have a very interesting medication that I think likely will have an FDA approval called ladadumstat, and based on phase 2 study for relapsed refractory AML patient with FLT3 mutated AML. It has an overall response rate of 55%, so that was quite remarkable. We have also another investigational agent for SH2 mutated AML, and we're waiting for more data for rivonemib in NPM1 mutated AML. Then we have the apoptosis and the immune checkpoint AML therapies. We have the BCL2 venetoclax is approved for in combo with azacitidine. Now it's essentially the standard of care. And we have also another medication. It is still not approved, but there is a going study called OV-AML 123 trial that included patients with venetoclax vidaza in combination with cusatuzumab in patients with a newly diagnosed AML as unfit. It targets CD70, but still we need to wait for more results to come. Then we have the other category, the fourth one, the surface antigen targeting AML therapy. And we have three targets. The first one is an approved one by FDA. I think most of you know it, the gemtuzumab ozucomycin. So that has been approved in patients with intermediate and favorable risk AML that they have CD33 positive AML. We have another two medications that might get approval soon. For one targeting CD123, another one, the third one is essentially CAR T-cell targeting CLL1 receptor on AML patients. We don't have any approved CAR T-cell products yet for AML, but this one may get approved soon. The gemtuzumab ozucomycin, as you know, it went through multiple key events, I would say, since 2000. But right now, it's FDA approved at a fractionated dose of 3 milligram per square meter on day 1, 4, and 7, plus 7 plus 3. Signaling cascade, we have a few few drugs that target specific pathways. None of them are approved. They're all investigational, but those are the three common types in terms of signaling cascade that we see: RAS, PI3K, and JAK-STAT pathway. So in summary, we have this is just to show you what is approved and what is investigational based on the category of how it is targeting AML. So for mutation driven, we have 4 and 4 still investigational, and then we have the rest shown on the slide. I think just for the sake of time, we have lots of, now we're moving to the combination strategy part of the presentation. We have many approved combination chemotherapy targetable agent in AML patient. But the most common one that we use is the azacitidine venetoclax, but we have other combination, either azacitidine plus IDH inhibitors, FLT3 inhibitors, menin plus FLT3 inhibitors, etc. But the common one, the standard of care right now we use is AZA and venetoclax. The resistance. So despite the progress we see in patients targeting therapies in AML patients, still resistance is a major clinical challenge. So this is summarize the different resistance mechanisms across different targeted agents and other clinical implications. How the BCL2 get resistance is usually through upregulation of something called MCL1 and BCL6, which really lead to, I would say, anti-apoptotic effect of the leukemic cells, so leading to resistance of the leukemia cells. Excuse me. And the FLT3 inhibitors also, they may get resistance by the emergence of a specific mutation that work as a gatekeeper. So it's essentially keep the target not been able to be interacting with the FLT3 inhibitor. So they call it gatekeeper type of resistance mutation for FLT3 inhibitors. IDH inhibitors usually by the way of switching. So the patient IDH1, they will switch to IDH2. That lead to resistance for that specific targetable mutation. And then we have the same for menin inhibitors. We have a different mechanism, essentially through regulation of a specific targets in menin. So what challenges we have right now for targeted AML therapies: access and cost. I believe some centers, they don't have access to certain medications, so referral may get delayed and the patient may not receive the standard of care on time. Diagnostic bottlenecks, as you know, delays and molecular profiling. I don't know how usually you get your molecular results back when you have a new case of AML. It should not be more than 7 days in general. Comorbidity and frailty, usually older unfit patients are underrepresented in the trials, so it's usually difficult to generalize outcomes. Real world toxicity versus trials. We may see sometimes higher incidence of cytopenias infections than reported in RCTs. Drug-drug interactions, another challenge with azoles. Resistance and relapse patterns and limited combination data. Sometimes we use off-label combination clinical practice that is not approved, and that may be sometimes be disappointing in terms of results. Last slide. This is future directions, and just put some thoughts into what could be in the future for targeted therapy in AML. As you know, multiomics now is becoming really kind of more important. So we should not rely only on genomics. We should include also epigenetic, proteomics, metabolics. You may see a patient with AML that has no more methylene FLT3 mutation, but still they have resistance to therapy because they may have a different proteomics and metabolics that leading to resistance that have developed in the patient over time. Clonal evolution tracking, this is really important. The patient may have different clones being suppressed or represented over time since the patient get diagnosis of AML until maybe several years after treatment. So there may be FLT3 ITD may become positive initially, then negative, then again positive, and another co-mutation will become positive later. So that's why you have to recheck always molecular profiling in patient whenever they relapse, because you may see a different clone coming out. Expanded targetable mutations. So we need more clinical trials and studies addressing the different mutations. AI and the role of risk prediction and therapy selection is evolving right now. And also evolving treatment platforms like the CAR-T therapy and TCR and NK cell therapy. Thank you so much.
It's excellent talk. It's actually quite enlightening. And I'm realizing now that AML is competing with myeloma and options of new therapies and combinations. Hopefully the future is going to be bright for AML. Thank you very much. It's my pleasure to introduce our next speaker, Dr. Salim Al-Dada. He's a renowned hematologist and transplanter at Princess Noura Medical Center at King Abdulaziz Medical City. Hematology program director at King Abdulaziz Medical City. He will be switching the talk to acute lymphoblastic leukemia, Philadelphia positive patients specifically, and updates in that talk. The floor is yours.
Thanks, Dr. Hatem. It's a pleasure to be here. So.
لا مش هيعمل على الشاشة بس تقدر تقلب بيه مش هيدي إضاءة على الشاشة.
هنا بس. Assalamu alaikum. Good afternoon, everyone. I would like to thank the organizing committee for inviting me to speak to you today. So my task will be to discuss updates on the treatment of Philadelphia positive ALL. So before the introduction of TKI, the outcomes of Ph positive ALL were poor. The MRCU Cal 12 ECOG 2993 reported a 5-year overall survival of 267 patients of 22%. These outcomes improved with the use of CR1 allogenic bone marrow transplant, and the outcomes were best with matched sibling transplant. So after the introduction of TKI, these outcomes has improved, and the same trial reported pre-imatinib era outcomes, and with the use of imatinib, the outcomes significantly improved. And what they showed also that the early use of imatinib has been associated with a better outcome. So basically, there are 4 treatment strategies for Ph positive ALL. The first one is to use an intensive chemotherapy with TKI. And over the last 2 decades, we had multiple clinical trials using this approach. The outcomes range between 40 and 50% in patient getting intensive chemotherapy with first generation TKI, and these outcomes has improved to a range of 60 to 70% overall survival with the use of intensive chemotherapy with second and third generation TKI. So this is the first strategy. The second strategy is to use a low-dose chemotherapy with TKI, pioneered by the French group. And in this approach, you will also need to do a lot of CR1 allo because you are using lower intensity chemotherapy. And the outcomes are comparable actually to the intensive chemotherapy plus TKI. The third approach pioneered by the Italian group is to use chemotherapy-free regimen with steroids and TKI. And actually, this is associated with very low toxicity and very high CR rates. However, the relapse rate may approach in some trials 50%. So you need again to rely on CR1 allogeneic bone marrow transplant. The fourth strategy, which is an emerging strategy, is the use of blinatumomab with TKI, pioneered again by the Italian group and the MD Anderson group, and I'm going to discuss that in detail in my presentation. So which one is the standard of care and the recommended treatment strategy in the guidelines? So if you look at the most recent NCCN guidelines, this was actually I accessed this, it's 2024, but it's actually 2025. I accessed it like 4 days ago. So all of these strategies are mentioned as an option in the therapy of Ph positive ALL. So you look at Blina plus TKI, CLGB 10701 plus TKI, which is chemotherapy with TKI, steroid plus TKI, SFAL plus TKI, which is actually a pediatric regimen, dose-adjusted hyper-CVAD with TKI, and even VCR dexamethasone TKI. All are mentioned as recommended regimens by the NCCN guidelines. So basically, there is no standard of care for therapy at this moment. So as I mentioned, the Italian group pioneered the chemotherapy-free regimen with steroid plus TKI for Ph positive ALL. And in this trial, they used imatinib plus steroid. 30 patients were treated. CR rate was 100%. However, 50% of patients relapsed within 4 months. In their subsequent trial, they used second generation TKI dasatinib. And in this trial, they used dasatinib again with TKI, 84 days induction, and with intrathecal chemotherapy. So CR rate was high. However, again, 43% of patients relapsed after induction. T315I was detected in almost 70% of relapse cases. And at 20 months, the overall survival was 70%, almost 70%. Disease-free survival was 51%. The MD Anderson reported first in 2010, 15 years ago, the result of hyper-CVAD plus dasatinib in Ph positive ALL. Their initial report with 33 patients, disease-free survival 60% at 2 years, and overall survival 64%. And they had 4 patients who died in remission. So 5 years later, they reported their long-term follow-up with the dasatinib hyper-CVAD. In this paper, they had 72 patients with a median age of 55 years. 96% of patients achieved CR, and among those who achieved CR, 93% achieved MMR at a median of 4 weeks. 94% were negative MRD by flow cytometry at a median of 3 weeks, and 16 patients in that trial underwent allogeneic bone marrow transplant. 7 patients relapsed, and these patients who relapsed had BCR APL kinase domain mutation, including 4 with T315I. And if you look at the 5-year overall survival, 46%. So in the same paper, patients who were transplanted actually did not do better. The 5-year survival was 33% for transplanted patient versus 49% for patient who did not underwent transplant. And if you look at the purple curve, patients who are above 40 and were transplanted had inferior outcomes. So age had an impact on the outcome of transplanted patient with hyper-CVAD with dasatinib. The MD Anderson subsequently used ponatinib, the third generation potent TKI with hyper-CVAD in the treatment of Ph-positive ALL. And in this report, they had 86 patients treated. Median age was 46, with a quarter of patients above the age of 60. 23% of patients underwent allogeneic stem cell transplant in CR1. So if you look at the outcomes long-term, at 6 years, the 65% event-free survival and 6 years overall survival was 75%. So we're even now approaching 80% long-term survival. The outcomes, interestingly, were not different between patients who are younger and older. So the outcomes were similar in patients younger than 60 and older than 60. And transplant actually was not associated with better outcome in that trial. The French group pioneered the use of lower intensity chemotherapy with imatinib in Ph-positive ALL. And in this trial published 10 years ago, they used an experimental arm, which is arm A, with vincristine, dexamethasone, and imatinib. And they compared this experimental arm to control arm of hyper-CVAD using vincristine, dexamethasone, anthracycline with cyclophosphamide, and TKI. So the induction only was different. Subsequently, the consolidation, which is cycle 2, was similar between both arms, which is arm B hyper-CVAD, MTX, plus RSC and TKI. They looked at the hematologic CR. If you look at arm A, the hematologic CR was approaching 99%, statistically better than the control arm with intensive chemotherapy, which was 91%. What was the reason for that? The main reason for that were the induction death and the early death. If you look at day 60 mortality with the control arm were 9% as compared to 2% in the experimental arm. So lower intensity chemotherapy was associated with less early death. So what about the major molecular responses and molecular CR? They were exactly similar between both arms. When they looked at the event-free survival and overall survival, there was a trend toward a better outcome in the experimental arm. However, this did not reach statistical significance. So what they did, that also patients who were achieving CR, they were assigned to receive an allogeneic bone marrow transplant if a donor was available. So a total of 63 patients of the population in the trial underwent allogeneic stem cell transplant in CR1. And for patients who did not have an allograft, 14% of those patients, 35 patients out of 93 underwent auto transplant, which is a total of 14% of the whole trial population. The transplant actually in that trial improved the outcome. So if you look at the relapse-free survival and overall survival, superiority of the transplant arm versus the no transplant arm with a significant p-value. However, an important lesson we get from that trial that patients who are in molecular CR did not benefit from transplant. You see that the molecular CR curve is actually overlapping with the transplanted patients. A recently published trial was the trial of ponatinib versus imatinib in the frontline therapy of Ph-positive ALL, the Falcon trial. And in this trial, they compared ponatinib at a dose of 30 to imatinib at a dose of 600 with reduced intensity chemotherapy, followed by single agent ponatinib or imatinib after cycle 20. And the ponatinib dose was reduced to 15 milligrams, when achievement of MRD negative CR. They had 245 patients, 2-to-1 randomization, median age 54. The MRD negative CR, which was the primary endpoint of the trial, was higher with ponatinib versus imatinib, 34% versus 16.7%, and median event-free survival was not reached versus 29 months. The most common adverse events were similar between treatment arm, and interestingly, the arterial occlusive events were infrequent and comparable between both arms. Now I come to the emerging treatment strategy, which is the use of TKI with blinatumomab, and this was pioneered by the Italian group. This paper, the ALBA trial, published in the New England Journal of Medicine in 2020, 5 years ago. They had 63 patients, and median age was 40, range between 24 and 82. So what they did in the trial, they gave dasatinib and steroid for 85 days, and after 85 days, they did an assessment. And regardless of the assessment, patient proceeded to blinatumomab consolidation with dasatinib. The blinatumomab was given up to 5 cycles. The primary endpoint of the trial was the molecular CR, a molecular response, which is defined by CMR, or positive non-quantifiable disease, after 2 cycles of blinatumomab. And CNS prophylaxis was used all over the way. So almost half of the patient had Icarus deletion, and the Icarus plus defined by Icarus plus PAX5 deletion and or CDK into AB deletion was present in around 17% of the cases. So as I mentioned, the primary endpoint of the trial was the overall molecular response after 2 cycles of blinatumomab, and that was 60%. So 42% achieved molecular CR and 18% achieved positive non-quantifiable response. What's the percentage of patients receiving allogeneic bone marrow transplant? 38% of patients in that trial received CR1 allo. So it's not actually completely a chemotherapy-free regimen. The induction could be, but however, even the induction, we get intrathecal chemotherapy. So in the JCO 2 years ago, they reported their long-term outcomes. So you look at the disease-free survival at 4 years was 75%. And now we are seeing an 80% 4-year overall survival in Ph-positive ALL. What was an emerging concern in that trial is the rate of isolated CNS relapse and CNS combined with molecular relapse. I think this is an important slide. This is from the updated result of the DALBA. So they compared the disease-free survival probability based on the outcomes at the end of induction response. So before they get blinatumomab. So the one you are seeing to the left is the one before you get blinatumomab. So patients who are actually achieving a molecular response before you start the blina, they had 100% 4 years disease-free survival. After you start the blina, there is no difference between patient who got a molecular response and patient who did not get a molecular response. So what's important here that early molecular response is very important and prognostic for the long-term outcomes. Again, overall survival 100% for patient achieving end of induction molecular response. They also showed that patient with Icarus plus molecular profile had inferior outcomes. If you look at the gray curve on both sides, the outcomes is less than 50% at 4 years. They also compared the outcomes with the previous trial they had, the LAL 1509, and the outcomes were superior in the DALBA trial. And if the patient achieved molecular CR or molecular response or no, the outcomes were better in the DALBA trial as compared to the previous trial. In the last ASH, in last December, the same group presented their a new trial, the Gemima ALL 2820. And in this trial, they're using ponatinib rather than dasatinib in combination with blinatumomab. And this is actually a randomized clinical trial. So they had an experimental arm of ponatinib plus blina, a control arm of chemotherapy plus imatinib. And they are increasing the CNS prophylaxis because of the concern of CNS relapse. And allogeneic bone marrow transplant allocation is according to the molecular features.
Dr. Salim, 2 minutes.
Yes. So the experimental arm, they reported the experimental arm, they had 151 patient, median age was 57. And if you look at the complete hematologic response, 96%, and the overall molecular response were higher in patients at the end of induction and after 2 cycles of Blina in this trial as compared to the D-ALBA trial. This is the, although short follow-up, impressive overall and disease-free survival curves. So 7 patients died on the trial, and they had 14 relapses. 3 of these relapses were in patients with Icarus plus signature. So transplant allocation in the first complete hematologic response, transplant was done in 16 patients in that trial, 7 for MRD persistent and 9 in the Icarus plus patients. So I'm coming to the last trial I'm going to discuss, which is the MD Anderson approach of ponatinib blinatumomab in Ph positive ALL. They reported, this is the updated report in JCO, and they presented their updated result in the last ASH. So I'll show you the protocol. So what they did, they give induction of ponatinib blinatumomab, so simultaneously, not like the Italian approach. You start with blinatumomab 4 weeks on, 2 weeks off, total of 5 cycles, and they increase the number of ITs to 15. And the dose of Bona is decreased to 15 milligram after complete molecular response is achieved. So they had a total of 76 patients. Median age was 50. CR/CRI was 98%. CMR was 83%. However, when they went back to the 8 patients who had CMR, which they didn't have a CMR, they tested for NGS MRD, and they were actually NGS MRD negative. So these patients could have actually clonal hematopoiesis of Ph positive clones. So this to show you the patient disposition. 2 patients underwent allogeneic bone marrow transplant in CR1. The updated result, the 3-year overall survival, 88%, approaching 90% at 3 years, and disease-free survival, 78%. So this is the oncoplot of 48 patients who were in the trial, Icarus plus in more than 50% of cases. And they had a new mutation called, they described that mutation VBREB1. And when they did univariate analysis, only white count more than 70 CNS at diagnosis, and the presence of that mutation, VBREB1, were associated with increased relapse risk. Interestingly, the Icarus Plus in that trial did not had not had a statistical significance increase in relapse risk. So the relapse risk with white count more than 70 and VBR-EB1 deletion were actually more than 50% in the MD Anderson report. So what are my take-home messages? First, the outcome of Ph positive ALL has significantly improved over the last 2 decades. Early TKI therapy is essential in Ph positive ALL. CR1 allo stem cell transplant improved the outcomes in MRD positive Ph positive ALL patients. And the Blina plus TKI is an emerging therapeutic strategy in Philadelphia positive ALL treatment. However, longer follow-up is needed as CNS relapse could be a concern. And high-risk molecular profile, such as Icarus Plus and high white cell count, have shown to increase the risk of relapse in patients with Ph positive ALL treated with the phase 2 trials of Blina plus TKI. Thank you all for listening.
Thank you very much, Dr. Salim, Dr. Naif, for this excellent session. With this, if you allow me, I will skip the question part due to the limited time constraints. I would like to welcome Dr. Hussein Al-Bargi. He will be leading a satellite symposium regarding beta-thalassemia management. تفضل.
Assalamu alaikum and good afternoon, everybody. And now we are moving from the malignant hematology to benign hematology. We have a session about the new therapeutic modality about beta-thalassemia. First of all, I will touch briefly on epidemiology of beta-thalassemia globally and locally. For the global data, we have around 56,000 infants. They are born annually with thalassemia, and almost 1.5% of the global population, they are affected with beta thalassemia. And of course, the highest frequency, it's mainly in the sub-Saharan Africa and Middle East and South Asia. For Saudi Arabia, we have almost the prevalence of total carrier of our population is almost 1.2%. And there are 130 infants. They are born annually with thalassemia. And the estimated number of the patient get affected with thalassemia, it's almost 9,000 in our country. When we are looking for the prevalence rate of beta thalassemia by region and time in Saudi Arabia, it almost show a fluctuating pattern across the 13 region of Saudi Arabia over the 5 years. And of course, the highest region or the highest prevalence rates, it's mainly in Jazan, then Eastern Province. Well, without any further delay, it's my pleasure to introduce my colleague, Dr. Abdullah Zaid. He is a senior consultant hematology working at MOH at Al Qatif Health Network. Dr. Abdullah is well known by his interest in hemoglobinopathy and other hereditary blood disorder, and he is the leader of hereditary blood disorder at Eastern Province. Welcome, Dr. Abdullah, and the floor is yours.
Thank you very much, Dr. Hussein. Really kind introduction. I would like to express my gratitude also to BMS for this kind invitation to be here among dear colleagues and friends. My talk will be about the future frontiers, innovative therapies for beta thalassemia. And here are my disclosure. So we've been taught when we were in medical school that these are the typical clinical features when we have a patient with mongoloid features of the eye, with also depression in the nasal bridge and the maxillary hypertrophied. And these are what's called chipmunk facies. And I have to stop here that I have to say should not be seen anymore if we treat our patient really properly. So this should be only history. So we're talking about the spectrum of the thalassemia. It is wide spectrum. Some patients, they may have completely no symptoms, and this is basically for the trait or minor. And some patients, they may have mild to moderate, where they may occasionally require transfusion, or intermittently when specific situation like infection, pregnancy, they will require some blood transfusion. And this is called the non-transfusion dependent thalassemia. Shortly, we call it non-TDT. And the last one is the severe disease, which is basically those who are transfusion dependent thalassemia. We call it shortly TDT. So with the pathophysiology, when we look at the erythropoiesis, the normal erythropoiesis is really very complicated, and there are a lot of network cytokines and transcription factors, but it is basically two parts. The first part is the erythroid proliferation, and the second part is basically the erythroid maturation. And every stage there is some cytokines and growth factors. But in thalassemia, we have what's called the ineffective erythropoiesis, where there might be some changes here because there is suppression of the erythroid maturation, where the erythroid proliferation is going within normal range, but however, because there is a delay in the maturation, there will be expansion of the erythroid precursors. And we will look at the regulation of erythropoiesis. Normally, everything is going with smoothly, but when we have this ineffective erythropoiesis, there will be expansion of the erythroid progenitor, and that basically the erythropoietin will go up, while there is also TGF-beta superfamily ligands increment, and that again will lead to pooling of these erythroid expansion, and that will lead to halting the progression and maturation of the red blood cells. That will lead ultimately to anemia, but it's not stopping at the anemia side. So there is consequences of the anemia where there will be poor tissue oxygenation and poor growth. There will be iron overload, the cardiac, liver, and the endocrinopathies can happen. The bone marrow will be changed, the microenvironment. There might be bone deformities, hepatosplenomegaly, and extramedullary hematopoiesis. Hypercoagulability, also very important risk for those patients, and some patients, they may develop thrombotic event and even pulmonary hypertension. Talking about the management, some patients, they may require splenectomy where they're trying to target the anemia. However, this will be at the expense on developing hypercoagulable state, and those patients who are transfusion dependent, they may also require transfusion regularly, and that basically to fight the ineffective erythropoiesis and also trying to improve the anemia. But again, that will lead to secondary iron overload, and the secondary iron overload will necessitate the treatment for iron chelation therapy for both primary or secondary iron overload. If you look carefully, there are still a lot of challenges for those patients who are facing this on a daily basis. Some patients, they may not have access to the hospital care, or they may have a lack of efficacy of the treatment, difficulty in getting adhered to the treatment, in addition to the cost and financial issues. Here, the luspatercept comes and address the ineffective erythropoiesis. So luspatercept is one of the first-in-class recombinant protein that binds to the TGF-beta superfamily ligand and inhibits the SMAD2/3 signaling and enhances the late stage. So basically, luspatercept will come and attach to the TGF-beta superfamily ligand, and that will lead to inhibition of what is stopping the maturation. So basically, we are inhibiting the inhibition, and that will lead to a stimulation of the erythropoiesis. And the treatment of luspatercept has been already studied in two main landmark clinical trials. The first one is the BELIEVE trial, which was published in New England Journal of Medicine in 2020, and that's basically for those patients who were transfusion-dependent thalassemia. And the second trial was for those patients non-transfusion dependent thalassemia, and it's called the BEYOND trial and was published in 2021. So the BELIEVE trial is a randomized, double-blind, placebo-controlled phase 3 study on patients who are adult above 18 of age, and they are transfusion-dependent thalassemia. The group of patients were randomized in 2-to-1 ratio. The arm of the luspatercept included 224 patients, where the patient will receive 1 milligram per kg subcutaneous injection every 3 weeks, in addition to the best supportive care, where the placebo arm will only receive a placebo injection with best supportive care. And those patients will be followed up in the double blind period, which is 48 weeks. This will be followed by the open label up to 5 years, and the cross over was permitted on this open label. Then the patient were followed up in the post-treatment follow-up in total of 3 years. And you can see the primary endpoint was achieved. So the p-value was significantly in favor of the luspatercept. Those patient has already a reduction by 33% and the transfusion burden during the weeks 13 to 24 weeks of using the treatment. And when you look at the subgroup analysis, again, you can see majority of those patients or those groups are in favor of the luspatercept, and among all of them, those patients who were non-beta 0 improved better, and those patients also who were splenectomized has also improved better outcome. With regards to the secondary efficacy, there was also a significantly greater proportion of the patient received luspatercept that has also reduction in the transfusion by 33% or more and by 50% or more. And you can see that it is a significant p-value here. With regards to the ruling analysis, during any 12 or 24 weeks interval, there was again a significant reduction in the total transfusion burden. And you can see in the first graph in the left side, those patients at any 12 weeks interval, and again, there is improvement in the luspatercept arm with a significant p-value. And those patients at any 24 weeks interval, again, there is a significant reduction on the blood transfusion with a significant p-value. There is also a cumulative effect of over any 12 weeks period, and you can see from the 2018 until the 2023, the cumulative effect has improved from 70 to 80, and that indicates that the longer the patient on treatment, the better improvement. And with regards to the long-term safety profile was also acceptable. With regards to the treatment emerging adverse event, most of the symptoms were basically musculoskeletal symptoms like back pain, headaches, bone pain, and arthralgia, but it was really tolerable by the patients. And even with the long-term safety profile, you can see the majority of the patients have reported headaches, arthralgia, bone pain, and sometimes flow symptom-like. With regards to the iron overload, with the using of luspatercept, the iron profile has improved. The serum protein who were above 1,000, they improved to below 1,000. And the long-term luspatercept use resulted in decrease in the serum protein as well as the liver iron concentration despite of a lower dose of the iron chelation therapy. And that's basically likely due to the reduction in the transfusion burden. And that's why the luspatercept was already included on the TIF guidelines for managing those patients who has the TDT disease. The other trial, which was the Beyond the trial, which is basically for those patients with non-TDT patients, the phase 2 randomized trial using luspatercept, and the aim for those patients is basically to get at least 1 gram increment by the use of luspatercept, and that patient already randomized on 2:1 ratio, 100 patient on the luspatercept arm and 50 patient on the placebo arm, and they were followed up accordingly. And the primary endpoint was achieved on in the patient who were receiving luspatercept, and you can see 77% improvement and achieved 1 gram increment, while it was 0 in the placebo arm. With regard to the subgroup analysis, again, it were all in favor of the luspatercept. And if you look carefully, you can see that there was increment by the mean of the hemoglobin by at least 1 gram and 77%, but also there are patients who achieved 1.5 gram, and those patients were 52% in total. And with regards the patient who achieved more than or equal to 10 gram by the time point, there was also significant number, and you can see the number in the placebo is low, while the patient who receiving the luspatercept is significantly higher. With regards to the quality of life for those patients who are receiving luspatercept, there was significant improvement in the fatigue-related symptoms, and that's basically attributed to the luspatercept arm. Again, the safety profile is similar to the Believe It trial with no change in the long-term follow-up or new side effects. It was again integrated in the management guidelines of the TIF for non-transfusion dependent thalassemia patients. But when we look on the novel therapies, we have always to think of a curative disease. If we can cure a disease, it's definitely better than to just control it. So when you look at the novel therapies, we have to talk about curative therapy such as stem cell transplant or gene therapy. And we know that the patient with beta thalassemia are between two options. The first option is to receive a blood transfusion, and we treat the iron overload complication, while the second option is basically to go for allogeneic stem cell transplant, keeping in mind that we don't really need to have a graft versus malignancy here, because this is a benign disease. However, not all patients, they have a matching donor, and that's why we have to have an alternative, and gene therapy is basically was really a good alternative for stem cell transplant. And thalassemia patients, or thalassemia disease itself, was one among the first genetic diseases which gene therapy was proposed for. And the advantages here basically that we don't really need to have a matched donor, because this is like just an autologous stem cell transplant. It will eliminate the risk of graft versus host disease, and there is no worry about the graft rejection in those patients. And one of the gene therapies that was used for treating thalassemia, and it is approved for in Saudi, is the extracellular gene therapy. And you can see the green lines are for those patients who were really transfusion independent, and they did not receive any transfusion post gene therapy modification. And here in Saudi, we have already 3 patients received gene therapy, 2 patients in pediatric and 1 patient in adult, and they are doing very great. With regards to the gene therapy, it was also integrated in the TIF, and that this is the 2022 edition, which back then it was only the Zynteglo, the beta cell. It was approved by in the EU, but Exacel or the Casgevy was not yet approved by US, so it was not included in the guidelines for TIF. But again, whether the gene therapy is gene addition or gene addition is really, we have always to think about the price, and not all patients will be able to afford this treatment. Beta cell, for example, may reach the price to 2.8 million US dollar, and the Casgevy is 2.2 million US dollar. So it is really expensive to be offered to all patients. Looking at the horizon, and have to talk about the metabobat, which is basically the pyruvate kinase receptor activator, and it is being used for 3 diseases: the pyruvate kinase deficiency, and thalassemia, as well as the sickle cell. The approval was already for the pyruvate kinase deficiency, and it's been approved in the US, and they are using it. And on the other hand, the Rise Up trial for sickle cell disease was just completed few months ago, so we are expecting the result to be announced by the end of this year. So here we are focusing on the thalassemia part, and there are 2 clinical trials already completed, the Energize and the Energize T clinical trial. So talking about the metabobat, it is really one of the novel therapies, first in class oral small molecule allosteric activator of the red blood cell specific form of the pyruvate kinase. And basically, hemoglobinopathies, they have low ATP inside the cell and inside the red blood cell. But when we got the pyruvate kinase activator, that will increase the ATP basically, and prevent the accumulation of 2,3 DPG, and that will make the span of the red blood cell is longer, and that definitely will improve the anemia, that will improve the ineffective erythropoiesis, and ultimately will lead to decrease in the iron overload. So the Energize T is basically done on patients for both alpha and beta thalassemia, and the number of patients was 171, and the metabobat and the placebo was 87, and they were followed up over 48 weeks, followed by 5 years on the open label extension, and all the patients will receive metabobat, and then there will be also a safety profile follow-up for those patients. And you can see the definition of the primary endpoints for those patients are mainly for the primary endpoint is what's called the TRR, the transfusion reduction response, and that's defined by more than or equal to 50% reduction or plus more than 2 unit or more reduction in the transfusion. But there are also other secondary endpoints, the TRR2, the TRR3, the TRR4, and these are basically the number of reduction by 50% or 33% in a fixed period of time. And the results showed a significantly improvement with 30% of the patient receiving mitapivat. The other one is the non-transfusion dependent thalassemia, and again for both alpha and beta thalassemia, and it is called the Energize, where the patient being randomized in the mitapivat arm as well as the placebo in 2-to-1 ratio, and they basically they look at the increment in the hemoglobin by at least 1 gram. And again, here you can see there is an improvement by 1 gram on those patients and reach to 42% for a patient on the mitapivat. You can see the difference here as well, the patient receiving mitapivat. And again, this is for both patients, alpha and beta thalassemia, and they showed improvement in the response. Whether luspatercept has to be against the mitapivat, I wouldn't say it should be head to head, but rather hand in hand in order to improve the patient's outcome. And I would say, yeah, it is not yet approved, the mitapivat, but it is a promising drug, maybe coming in the coming few months that will really make our patients happy. The approval for the luspatercept was for both beta thalassemia and myelodysplastic, and mitapivat up to now is only for pyruvate kinase deficiency, but they have already submitted the approval papers for the US FDA, the UAE FDA, also the Saudi FDA for approval, and we expect that might be soon, hopefully. There is an ongoing clinical trial for sickle cell disease by the Rise Up, and we expect again the result by the end of this year. So luspatercept thankfully is already approved by the Saudi FDA and it's been used in clinical practice in Saudi, and it is approved for both transfusion dependent thalassemia and non-transfusion dependent thalassemia, but beta thalassemia. In summary, there is still unmet need for beta thalassemia, although stem cell transplant as well as gene therapy may be a promising curative therapies, but most of the patients are still dependent on the transfusion and iron chelation. There are really a paucity of a treatment for the beta thalassemia, and there are also the current care is really associated with complication, and the therapies that we have is really reduce the patient reliance, and really it is provide really a large bothersome effect on their lives. However, we have to be very optimistic that the life of our patients has already, the lifespan has already prolonged. In the past, they usually dies in their 20s, 30s, but now we have patients who live to the third decade, and hopefully one day we'll hear that they will have full lifespan. And with this, I end my talk, and thank you very much for listening.
Can take 1 or 2 questions. Okay, 1 question. طيب دكتور عبد الله بس I have a comment for the luspatercept and transfusion dependent. How we can predict who is the early responder and who is the late responder? Is any predictive module for this?
I don't think this was addressed on the clinical trial, but from the subgroup analysis, the early responder or those who improved better were those patients with non-beta 0, and those who were splenectomized. So those patients will definitely respond earlier than the others. But who will stay on luspatercept in order to get the cumulative effect over months and years, that's difficult to be answered, I would say.
Thank you so much. We'll maybe have just the next session starting. Well, a short break for 5-10 minutes, and we'll start sharp at 3:10, inshallah.
طيب بسم الله الرحمن الرحيم. I guess we can get started. Thank you very much for remaining with us. My name is Ahmed Absi. I'm the section head of hematology at Princess Noor Oncology Center, King Abdulaziz Medical City of National Guard here in Jeddah. First of all, I would like to thank the organizing committee, specifically Professor Ahmed Al-Askar, Dr. Ahmed Baraf'a. This is the third combined meeting of the SSBMT and the Saudi Society of Hematology, plus many other numbers and years of meetings for individual societies as well. This is very important meeting, I think, because it brings together a wide range of colleagues, friends that we are all proud to know and to have been worked with over the years. This is the fourth session of this day. I'm honored to be chairing this session with my friend Dr. Abdurrahim Basandwa. He's a consultant at King Fahd Military Hospital here in Jeddah, Hematology. This is the fourth session of the day. It's about rare disorders. Dr. Abdurrahim, تفضل.
Bismillah ar-Rahman ar-Rahim. Would like to introduce the first speaker of our session today, Dr. Hanan Hamid. She is a professor of internal medicine and clinical hematology at Ain Shams University, Cairo, Egypt. She is the vice president of Egyptian Society of Hematology. She will talk about histiocytic disorder, and she will focus on Langerhans cell histiocytosis and Rosai-Dorman syndrome. Floor is yours, Dr. Hamid.
I can't see. No. I don't. I need to see that. No. Okay. So make it full screen. I cannot see it like that. I cannot read it like that. Need it full screen. If I thought that for me to do it like that, I would have brought my. Is there anybody else can do that? I cannot read it. Just yes. I'll read it. Yeah, that's it. Thank you very much. I'm sorry for the delay, for just technical error. Bismillah ar-Rahman ar-Rahim. Thank you very much for the organizers for giving me the great opportunity to be with you today. What I'm going to do, I need the slides on the screen, please. Yes, I'm going to discuss something which is quite there, but a lot of times we are missing those patients. This is my campus. Part of our campus. I have nothing to disclose. I'm an ancient hematologist. I'm an old hematologist. I have been through for decades a lot of cases, and I will start with you 31 years ago with a patient who started to let me very much devoted to search for those patients and to look for them and to properly diagnose them. My patient at that time, it was 1994. I was just promoted as a lecturer, and he was 36 years old, and his story started maybe 10, 11 months by weight loss, bone aches. Then few months he started to have sporadic skin rash increases with time. Before coming to us, he started to have a complaint. Some people used to laugh of it, and they thought that he might need a psychiatrist. And his complaint was he is not able to bite hard object. And I have seen the same complaint as well from monocytic acute myeloid leukemia. So then after that, the patient start to have bruises, recurrent attacks of fever with marked weight loss. On examination, when he came to our institute, the patient was markedly underweight, generalized skin rash, but no lymph nodes, subcutaneous bleeding, bony tenderness, particularly on the jaw. And the lab work showed pancytopenia, markedly elevated ESR with a fair normal metabolic and immunological survey. X-ray survey showed multiple osteolytic lesions everywhere, including the jaw. Some people thought in the grand round of our unit that this could be a typical presentation of myeloma. I didn't believe that. Again, we are in 1994, not in 2025. My objection was on two things. Number one, this recurrent increasing skin rash, which we have never encountered before in multiple myeloma. Number two, and this still قائم إلى اليوم, how many of us have seen multiple extensive jaw osteolytic lesions in multiple myeloma? So these 2 points were on a clinical base against the diagnosis of multiple myeloma. So we went back to the lab, bone marrow aspirate and trephine. There have been collection of cells which look like histiocyte with increased mitotic changes, and this could be a malignant histiocytic infiltration. Again, remember, we are 1994, so the advanced flow cytometry was not available at that time. So I have been having a couple of options at that time to diagnose my patient. The first is immunohistochemistry, which confirms the positivity of CD1A. And the other thing, which we are not consuming nowadays, but still it has a very important diagnostic impact in this group of patients, is the electron microscopy study. And I was looking for this. This is what is known as Berbick granules. And they are coming in two shapes, step ladder shape and what we call tennis racket appearance. زي مضرب التنس, looks like it. And this tennis racket appearance does not appear in medicine except in two situations. In the electron microscopy of the histocytosis or histiocytic disorders, and in the bacilli of the tetanus. So in all medicine, we don't have tennis racket appearance except in these two conditions. 2 years later, I got a daughter of a patient coming with anemia. She came with her papers. The patient didn't come with her. Coming with all her papers with anemia, elevated ESR, and a GP asked her to do a bone scan, isotopic bone scan, and again we were in the 90s, and the patient had multiple uptake with lesions in the bone. And she said, he told me, this could be a myeloma, go for hematologist. I said, 100% this is not myeloma. Why? Because myeloma infiltrations in the bone does not give positive result in the isotopic scanning. In the PET-CT, in the MRI, okay, but never in the isotopic scanning. So this is a very important differentiation 30 years ago. With that, we start to build up our experience concerning this group of diseases. We are a heavily populated country, so I have seen plenty, a wide array of different presentation with patients with histiocytosis, including pulmonary, including cutaneous, including osteolytic lesions. The nomenclature came from the tissue cell who are too much. It was 1987 for the first time to have a classification of these histiocytic disorders, and they classify them into dendritic cell disorder, macrophage cell disorder, which refers to the cell of origin, and malignant histiocytic disorders. And we kept cornered with that classification for almost 28 years. Then in 2016, we have had the classification we are still utilizing till today, which classify histiocytic abnormality into 5 groups. The L group, which is Langerhans cell related. The C group, which is mainly cutaneous. The presentation is mainly cutaneous. The R group, which is a Zarozai-Dorfman disease, which is one of the 2 diseases we are going to focus on today. The M group, which is the malignant histiocytosis, like our first patient. And the HLH, or the H group, which is related to HLH, other congenital or familial or acquired. These are the 5 groups and the subtypes of the diseases which are belonging to each of them. There are 3 diseases have been moved from being benign disorders into consideration as malignant disease. Why? Because a specific mutations have been identified in these 3 diseases, which make them having a pathognomonic molecular abnormality, rendering the cells in this disease abnormal cells, which could be considered a malignant cells. They are the Erdheim-Chester disease, the Langerhans cell histiocytosis, and the Zarozai-Dorfman disorder. And the percentage of this genetic abnormality ranging from 50 to 90% of those patients, particularly in Zarozai-Dorfman, it has been shown not a malignant pathway, it's more chronic and more benign-like presentation. As in lymphoma, when you have a malignant disease, the most important thing to do is to know the cell of origin. The cell of origin will tell you a lot about the biology of the mother cell and the expected behavior of the disease. All histiocytic disorders coming from 2 cells, either monocytes or macrophage. The Langerhans cell histiocytosis and Zarozai-Dorfman disease coming from different origin. Zarozai-Dorfman coming from the macrophages, while Langerhans cell histiocytosis coming from the monocyte, which progress more to be a dendritic cell, and the most important histopathological marker for them is ZAP-TB46, and it is positive in more than 90% of cases. So, the new WHO classification and the book which have been published by the end of 2023 have categorized the malignant histiocytic and dendritic cells. There is a first group which is plasmacytoid dendritic cell neoplasia, and I'm very much interested of the blastic plasmacytoid dendritic cell neoplasm because I came across a couple of cases, again, presenting with skin lesion. Maybe later in any meeting we can discuss that together. Then we have the Langerhans as other dendritic who are originating from the monocyte, and we have the histiocytic abnormality with Zarozai-Dorfman disease. We will start by Langerhans cell histiocytosis. It's not a rare disease. Its estimated prevalence is 1 to 2 in 100 individual, not 100 patients of something else. And because of its not rarity in occurrence, but rarity in diagnosis, a lot of physicians are lacking experience about this disease. And we have to know that in this particular disease, Langerhans cell histiocytosis, the cells could migrate from the skin or a cutaneous lesion to the lymph nodes, which is a behavior of a real malignancy, okay? So what are the clinical manifestations of Langerhans cell histiocytosis? These are the manifestations, and you can see clearly that the most common is the osteolytic lesion, followed by the endocrinal, particularly diabetes insipidus, because of the high rate of CNS infiltration, particularly at the hypothalamic pituitary axis. And diabetes insipidus in those patients could precede the clinical manifestation of Langerhans cell histiocytosis by years. And the third common is the pulmonary, and it is a category in adult Langerhans cell histiocytosis by itself. This is another way of tackling. The first is Mayo Clinic in the previous slide, and this is with the international expert consensus. And the same is there. You can see in the up panel the osteolytic lesions, the brain affection, mostly in the hypothalamic area here. We have here case of pulmonary histiocytosis, and of course the skin and the osteolytic lesion. So, is this disease divided into subtypes? Yes. Langerhans-Hill histiocytosis is divided into 4 types. The first is a unifocal lesion in one system, and this is called unifocal. And a specific subtype, which is the pulmonary Langerhans-Hill histiocytosis, or a single system with multifocal lesions. For instance, lung with multiple foci, liver with multiple foci, bones with multiple foci, and the last is multisystemic multifocal. This supposed to be the first case described for Langerhans-Hill histiocytosis 1865. Then we start to know that the bones are the most common. Where are the bones which are mostly affected in Langerhans-Hill histiocytosis? Skull, legs, ribs, pelvis, spine. No bone is immune, but most tendency for the flat bones. But in my hands, most of my cases, if not all of them, are having jaw affection. So the simple panoramic view of the jaw can tell you a lot about your patient and can confirm your diagnosis. Then the lesion could be in a fungating mass pattern like this one, or in a real defect in the jaw, which can be seen from the oral cavity like the one on your left hand. The second category is the pulmonary Langerhans-Hill histiocytosis, which could come with just having some shortness of breath with effort, up to a syndrome of fatigue, fever, chest pain, and weight loss. And we have to remember that 10 to 25% of those patients will have spontaneous pneumothorax. And we attribute that to the patient that you are a smoker, you could have a bully or something like that. I saw with the chest department in our institute, we followed up for a long time those especially young people who came with spontaneous pneumothorax. At least 10%, 7% of them developed skin rash. Then they proved themselves to be Langerhans histiocytosis. And the first thing to do for this patient, stop smoking now, not gradually, now. And those patients could be in a morbid shape, necessitating lung replacement or lung transplantation. Another system we didn't see a lot in the last 10 years or so that it is affected in such condition, which is the GIT. And now, in the last couple of years, we are having plethora of publications confirming the presence of GIT infiltration in Langerhans-Hill histiocytosis, either as a single polyp or multiple, or telangiectasia or ulceration. All of that have been described, up to that there is a case report on the last year published of two infant with extensive GIT infiltration by Langerhans-Hill histiocytosis. Now, how to diagnose? In histiocytosis, the tissue is the issue. We have to have a biopsy. This is non-negotiable because only the immunohistochemistry and then the molecular will tell us what we are dealing with. In RDG or Rosai-Dorfman, we will have positive CD163 and OCT2. While in Langerhans-Hill histiocytosis, as I said before, CD1A, CD207, which is the Langrene, and the ZEPTAB7, then these are pathognomonic for Langerhans-Hill histiocytosis. What about the genetics of these diseases? In 2010, we are confirming the presence of BRAF mutation in 50% of cases of ECG, or Erdheim-Chester disease, while the same is present in Langerhans-Hill histiocytosis but within 40-45%. But don't forget that we are having another 19% of other mutation, not V600 of BRAF, which is amenable of treatment with targeted therapy with BRAF inhibitor. In case of Rosai-Dorfman, we are having KRAS or RAS pathway and MAPK mutations. And these are the cornerstone for targeted therapy in these disorders. So,
Dr. Hannah?
Yes.
5 minutes.
Okay, I will do my best too. These are the genetic background, and these are the genetic, pathology, the immunohistochemistry, and they used to tell that, that this nucleus looks like the coffee beans in those patients. Luckily enough, we are having now guidelines which have been published in this January for treating those patients. For Langerhans cell histiocytosis, if it is local and you can observe no symptoms, go like that. If it is topical for cutaneous, if it is radiotherapy or surgical, go ahead. If it is systemic, either chemotherapy or targeted therapy. And as I said, the RAF pathway and the MEK pathway, and these are the drugs we are using nowadays or guidelines, vemurafenib for RAF mutation and copimatinib for cases of MAPK mutation. This is the algorithm. Go whatever you want, but at the end of the day, if you have a mutational documented, go targeted therapy with, as we said before, and this is the different overall response in cases of Langerhans cell histiocytosis. None of them like the targeted therapy. To make long story short, before 20 years, we give mild chemotherapy. Above 20 years, we give cladribine or cytarabine, which is more aggressive. And if we relapse, we will go the same way. Concerning Rosai-Dorfman, here we are having mostly lymphadenopathy, cutaneous and extra lymph node and skin. Most important, retroperitoneal. The kidney is the most important of them. I have seen a couple of cases, and it is characteristically in the sonar what we call hairy kidney when the infiltration with Rosai-Dorfman, and these are the different systems which could be affected in Rosai-Dorfman. And for investigation, according to the guidelines in 2024, PET is essential for all patients, and we go directed according to the system affection by imaging, and we can find everywhere affected lymph nodes. Some other less common, like the brain, the eye, the parotids, the heart, here is the hairy kidney, the breast, the liver, and even the thyroid. And these are the investigation. And again, tissue is the issue, immunohistochemistry and genetic study. This is immunohistochemistry of Rosai-Dorfman, and the classification of Rosai-Dorfman is either familial or sporadic, dependent where we are affected, and we classify them like that. We shouldn't forget that we might have what we call overlap between the different histiocytic disorders. Treatment of Rosai-Dorfman is either conventional with different chemotherapeutic agents or targeted, and these are all the red arrows showing 100% response, either as primary first line or as secondary line, starting from surgery with radiotherapy, chemotherapy, and targeted therapy, and rituximab. And some of my patients took rituximab, and they are doing perfect. Because of this study, FDA approved copimatinib, which is a MAPK inhibitor, in November 2022, and this is the algorithm for 2024. If you are having no symptomatic, no organ damage, observe. If you have symptomatic, go ahead with either minimal treatment up to targeted therapy. And to sum up what I said, histiocytic disorders respects no age, no sex, and it can affect any person. Various organs could be involved. Exhaust your investigation. Again, the tissue is the most important. Genetic study, not only for diagnosis, but for targeted therapy, and be aware of associated condition like autoimmune or other malignancy, particularly in Rosai-Dorfman disease. We should always think that we are treating rare patients. They are not rare. We don't diagnose them enough, but we have to speak for them and to educate for them and to be their voice if they are voiceless. And thank you very much.
Thank you very much, Professor Hanan. Excellent lecture. My honor to introduce our second lecturer of the day, also coming from beloved Egypt, Professor Azza Tantawi. She's also professor of pediatrics at Ain Shams University in Cairo. And she is the head of the pediatric hematology and oncology unit at Ain Shams University. And she is the president of the Egyptian Society of Rare Disorders in Pediatrics. Her lecture for the next 20 minutes will be titled Unexplained Splenomegaly, Think About Rare Disorders. The discussion for the 3 lectures will be left till the end.
Okay, I can start till the slides are ready. Thank you very much, Mr. Chairperson. Thank you very much for you and for my invitation to share in this always successful event of the Saudi Society of Hematology and the Saudi Society of Bone Marrow Transplantation. Professor Jaouni, she is my friend, and we are friends for a long time. And I congratulate the organizers of this event this year. It's really very successful. Thank you for you. I am going to speak about whenever you have a patient presenting with splenomegaly and you go through investigations and you don't find a diagnosis. Why I'm going to speak about rare disease and rare diseases, their definition is variable in different areas. Let's say in the United States, they say is a rare disease is a disease where its prevalence is less than 1 in 2,000. While in the Europe, they say it's okay, it's the disease where the prevalence is less than 1,000. I'm not sure this is true or I have reversed it, but it's variable. Every country puts its own definition of a rare disease. And this is what we should do. That's why I will use this. That's why when we speak, always we say we need registry. Whenever you go to rare disease, you say, I need registry, because whenever you have registry, you can say, this is my rare disease. Okay, I want to, yes, I want the full screen, yes. To allow me to see. Yes, thank you. Okay, excuse me, perhaps this one. Perhaps this one. Okay, and let's make this. Okay, it's okay, I will manage. Thank you very much, thank you. So, because the spleen is an organ with many functions, splenomegaly can arise from different causes, including infectious diseases, immunological disorders, hematologic disorders, benign or malignant, and others like angioimmunoblastic lymphadenopathy, Castleman, sarcoidosis. Thank you very much, Professor Hanan. In pediatrics, patients with LCH, they may present with organomegaly and splenomegaly, and the skin rash is very characteristic. Then I said this rare disease, so it's in the United States, less than 1 per 1,000, in the European, less than 1 in 2,000. It's rare, but every disease is rare, but the whole diseases are not rare, because the rare diseases all over the world, they constitute 6% of the population, so they are important. 80% of them are genetic diseases. Usually they are chronic and they are life-threatening, but there are rare infectious diseases. It may differ in each country than the others. In my country, malaria is a rare disease and leishmania is a rare disease. But in Saudi Arabia, they are not rare diseases, okay? So it will be different, thank you very much. It will be different from country to the other. Generally, it is said that we have 7,000 rare diseases. And what's the problem of rare diseases? What's the problem of this patient presenting with splenomegaly and having rare diseases? I'm going to show real cases, okay? And you are going to put what I'm saying on these patients, okay? First, most physicians, they don't know this disease. They don't have an experience, they don't recognize, and they don't know how to manage the vast majority of these rare diseases. So the diagnosis is often delayed up to 20 years in a US study. Sometimes the patient gets a wrong diagnosis and a wrong treatment, بعد كده نرجع في الأول نقول he did not respond, let's think possibly there is another thing which is quite different. So I'm going to speak about my lecture is an awareness presentation based on real life case scenarios. I like to go to clinical. This young boy, as you see, he's bad. He presented by the age of almost 14 or 18 months. He had anemia. He had severe thrombocytopenia. He had huge hepatosplenomegaly. I think this is not the first slide. Okay. Okay. He has a huge hepatosplenomegaly. I believe this is not the first slide, no problem. But this child was symptomatic since he was about 6 months old. And he was diagnosed by 18 months. We had a long time. He was transfusion dependent, frequent hospitalization for chest infections. He was in a very bad condition, okay? And he had all the investigations, including the bone marrow. The initial bone marrow, which was done early, said, okay, there are no abnormal cells, okay? But then when he presented to the hematology clinic, we did for him a bone marrow, and it reveals the presence of lipid-laden macrophages. This child was first referred always to a hepatologist. So when we found the lipid-laden macrophages, we said it's okay. Possibly he is having a lysosomal storage disease. And so let's go to an enzyme assay, which is available, and we can use the enzyme assay test. I should make just one comment that in lipid storage diseases, in 20% of the patients, you will not find lipid-laden deposition in the macrophages. So the bone marrow may be normal. So this is not against. We do, when we test these patients, we test for 2 enzyme assays. One for the Gaucher disease, which is leukocyte acid beta glucosidase in the peripheral leukocytes. Sometimes it is done in the skin fibroblast. Our experience with the skin fibroblast is not successful. This is number 1. But taking the blood sample لازم يكون فات شهر على blood transfusion. Otherwise, you are going to get a wrong result. Because there is an overlap between Gaucher disease اللي كنا بنسميها قبل كده نيمان بيك تايب A و B اللي بنسميها دلوقتي lysosomal acid no, it's not lysoma. ASMD, sphingomyelinase deficiency. فقلنا خلاص لازم كل مرة you test for the beta glucosidase, you test for ASMD, acid sphingomyelinase enzyme. فلقينا في الولد ده البيتا جلو is low, sphingomyelinase is normal. وبنستخدم كنا زمان بنستخدم بايو ماركر اسمه كايتوترايسيديز وستيل it is in use. كايتوترايسيديز بيعلى لما بيحصل deposition of the sphingolipids في الماكروفاجز، فالماكروفاجز تبتدي تبقى irritated وتطلع لي ده في البلازما. it is a biomarker. It is not specific for Gaucher disease، لكن بيعلى في الجوشيه وبيعلى في نيمان بيك وبيعلى في الثلاسيميا وبيعلى في التي بي وبيعلى في حالات كتير جدا. تمام، بس its value in patients with Gaucher is very high. يعني العيان ده لقيناه 3209 النورمال up to 80. very high burden للعيان ده، وده يساعدك في الفولو اب بتاع العيان. دلوقتي بنقيس one of the intermediary metabolites. انا عارفه ان انتوا هتسعدوا بكره في سيشن سيمبوزيوم جوشيه ديزيز، فيعني ان شاء الله تسعدوا بيه. واكيد هيكلموكم على الجلوكوزايل سفنجوزين. اوكي ليتس سي. طيب احنا دلوقتي خلاص انا شخصت العيان بتاعي عنده جوشيه ديزيز، هعمل له جينوتايبنج. دلوقتي بقت الجينوتايبنج افيلبل، لقينا عنده حاجه بنقول عليها هوموزايجوس فور ال4 بي جين، واللي فيكم هيقرا جوشيه هيقولوا لكم ان هم غيروا النومنكليتشر بتاعه، بس هو بقى اسمه ال4A3P. تمام، اما الاقي هوموزايجوس للجين ده او حتى هيتيروزايجوس معناها it is a severe disease and it tends to be neurogenic disease. قلت لكم انا الجوشيه بيحصل فيه ايه، بس انا عندي 3 تايبس من الجوشيه ديزيز. التايب 1 اللي هي visceral وما فيهاش neurological manifestation and they can present at any age وممكن يعيشوا لغايه a very old age. والتايب 3 اللي هو sub acute في visceral وفي neurological complications بس they are not severe and they are very variable. تايب 3 ده حاجه كده زي ما الدكتور كان بيكلمنا على الثلاسيميا، عامل زي الثلاسيميا انترميديا اللي هي الفينوتايب can be very variable from a very mild from a severe phenotype. So it's type 3 is very heterogeneous in its neurological manifestation. Type 2 ده بقى بيشوفوه اخواننا اللي هم بتوع النيوناتولوجي و in the very early infancy بيجي بسيفير neurological manifestation و it can cause myoclonus and they can do die early وفي منه اكتر من تايب لتايب 2 disease. هو انا مش النهارده هكلمكم على الدايجنوزس اكتر من اي حاجه، يعني احنا بنعمل برين ستورمينج. حاجه مهمه جدا للعيان بتاعنا ده لما جه انا بعمل له اسسمنت، تمام؟ اما عملت له اسسمنت ببص لعينيه، تمام؟ ده جوشيه، بصينا لعينيه لقينا عنده اوفثالموبليجيا، عنده سكوينت، تمام؟ الاوفثالموبليجيا والسكوينت this is a characteristic feature of type 3 Gaucher disease، تمام؟ يبقى العيان بتاعي is type 3 Gaucher disease وده ماشي مع الجينوتايب اللي احنا عملناه. عملنا ايكو كارديوجرافي، ايكو كارديوجرافي طلع ان عنده بريكارديال افيوجن لكن نورمال كاردياك فانكشن. الكاردياك تشينجز في العينين بتاعت الجوشيه مهمه لان في جينوتايب موجود في العرب وموجود في اليابانيين اسمه D409H. الدي 409H ده بيبقى فيه كالسيفيكيشن في الكاردياك فالفز وكالسيفيكيشن في الميوكارديوم. لكن هو عيانين الجوشيه كلهم مش ممكن يحصل لهم كاردياك تشينجز؟ ممكن يحصل لهم بريكارديال افيوجن في السيفير فورمز اوف جوشيه ديزيز. طب عملنا له سي تي لقينا عندنا بايلاترال بيري برونكيال بالمونري انفلترت زي ما حضراتكم شايفين كده، وده شفناها كتير جدا لما عملنا سكريننج للولاد and we have published this data of pulmonary disease حتى لو asymptomatic، لكن الكومن symptom is wheezy chest. So احنا لازم نفكر ان جوشيه ديزيز is a multi system disease، مش جاي بتاع الهيماتولوجي وبس اللي هشوفه it needs multidisciplinary care. اوكي، يعني اطمنكم يعني واقول لكم ان الولد ده بعد الانزيم ريبليسمنت ثيرابي لان التريتمنت از افيلبل والانزيم ريبليسمنت ثيرابي هو اللي انديكيتد في التايب 1 والتايب 3 ديزيز بس مش بيعدي البلاد برين بارير، وان كان بعض النيورولوجيكال مانيفستيشن they may improve in individual patients. بعد 5 سنين من التريتمنت بيروح المدرسه وبيلعب والايكو از نورمال وما عندوش اورجانوميجالي وهو النهارده عنده 12 سنه. بس الاوفثالموبليجيا ستيل بريزنت، تمام؟ بس ستيشنري وده كويس. فماي مسج لحضراتكم ان جوشيه ديزيز از فيري هيتروجينوس، ممكن يجي لك بحاجات كتير، ممكن يجي لك زي الولد ده بثيرد ديجري مرازموس هيباتوسبلينوميجالي ترانسفيوجن ديبندنسي وثرومبوسايتوبينيا من غير نيورولوجيكال مانيفستيشن، في الاخر طلع تايب 3. الولد ده كان بريزنتنج بجنرالايزد اناساركا ويز هيباتوسبلينوميجالي اند ويز بريكارديال افيوجن. الولد ده كان تايب 3 او تايب 2 ما تقدرش تحدد قوي، كان عنده سيفير ديزيز وهو رافع رقبته كده عشان يعرف يبص للي قدامه، هي از هافينج اوفثالموبليجيا، تمام؟ وهيباتوسبلينوميجالي. ده المنظر بتاع الكاردياك كالسيفيكيشن اللي انا قلت لكم. ده بنوته سيفير ديزيز لو بصيتوا هتلاقوا عندها spasticity of the lower limbs، عندها retroflexion of the neck، severe neurological، بس عندها حاجه مهمه، عندها في الابدومن في ليمف نودز في الابدومن، infiltration of the lymph nodes في العيانين بتوع جوشيه بنسميها جوشيرومز، وتدخل في الديفرنشال دايجنوستس بتاعت المالجنسي. وجوشيه ديزيز كمان is a potential malignant condition، فناخد بالنا من الحاجتين. اخر حاجه بقى، وحضراتكم فيكم كتير بتوع ادلت هيماتولوجي، التايب 1 ديزيز اكتر حاجه بروجنوستيك ليهم في الموربيديتي از بون ديزيز، اوستيوبروزس واوستيوليتيك ليجنز يا دكتور حنان وباثولوجيكال فراكشر. والمنظر ده بتاع الافاسكولار نيكروزس اوف ذا هيد اوف ذا فيمر، ده ولد جالنا كان عمره حاجه و20 سنه، ومن هو عمره 10 سنين عنده ليمبينج، اتشخص ان عنده افاسكولار نيكروزس، عمل هيب ترانسبلانتيشن، بعد كده بيعملوا له ابتدى رجله الثانيه تبقى افكتد، بيبصوا عليه لقوا عنده هيباتوسبلينوميجالي وبنسايتوبينيا، قالوا والله ده جوشيه ديزيز، ما كان خدنا تريتمنت من الاول. سو ليت دايجنوزس يؤدي الى لونج تيرم سيكولي. ده كلام جميل. البنوته الحلوه دي انا اتفقت مع حضرتك لما تلاقي الدنيا كده جاست تيل مي. البنوته الحلوه دي شي بريزنتد وهي عندها 22 سنه بانيميا 10 جرامز، مش سيفير، ثرومبوسايتوبينيا 61,000، هيوج سبلينوميجالي، هيباتوميجالي ويز هيباتيك فايبروزس. عملنا لها الفايبروسكان طلع الفايبروزس ستيج F3 وعندها interstitial pulmonary infiltration بالسي تي chest في ground glass appearance وعندها restrictive pulmonary functions. تمام. neurologically free عندها positive family history of a similar condition of other two sib deaths and a cousin having the same disease. ففي الرير ديزيز مهم قوي الفاميلي هيستوري. تمام. فاتعمل لها بيتا جلوكوسيديز او اسيد سفينجومايلينيز، لقينا انهم البيتا جلوكوسيديز is normal لكن الاسيد سفينجومايلينيز enzyme is 0.2 it's very low. تمام. يبقى العيانه عندها what we call acid sphingomyelinase deficiency اللي هو بنقول عليها نيمان بيك تايب A ولا نيمان بيك تايب B، مش تايب C، لان تايب C is a different disease. sphingomyelinase فيه بتبقى normal. اوكي. طيب very good. وهي اللي بيحصل في الاي اس ام دي، اللي بيحصل في الاي اس ام دي طبعا هي اوتوزومال ريسيسيف، ان انا عندي ديفكت في في السفينجومايلينيز انزيم، فبيحصل اكيوميليشن للسفينجوليبيدز في حتتين بقى، مش بس في المونوسايت ماكروفيج سيستم، بس كمان في الليفر بيديبوزيت في الهيباتوسايتس. عشان كده العيانين دول ملايبل للهيباتيك فايبروزس اكتر من العيانين بتوع جوشيه ديزيز، لان الديبوزيشن كمان بتحصل في الهيباتوسايتس نفسها. تمام. and it infiltrates different tissues including the brain. في severe cases خلينا بسرعه نعدي على السبيكترم اوف ذا ديزيز اللي هو الاي اس ام دي. عندنا تايب A اللي كنا بنقول عليه نيمان بيك تايب A، وعندنا تايب B. تمام. التايب A early infancy rapidly progressive severe visceral disease severe neurodegenerative disease، وفي 50% بتبعته لبتاع الاوفثالمولوجي يقول لك انا عندي تشيري ريد سبوت وهيموت by the age of 3 years. التايب B it's visceral، ما عنديش neurological manifestations it is slowly progressive، بس برضو ممكن ياخد الليفر وياخد اللنج. تمام. وعندي نوع في النص كده اسمه ASMD type AB. ده it can occur at any time during childhood. It is slowly progressive variable visceral disease variable neurodegeneration developmental delay intellectual disability ataxia peripheral neuropathy. تمام. طيب ده كلام جميل. هو انا بقول الكلام ده ليه؟ انا بس احب ان انا ان اهم حاجه ان انا يبقى عندي
بروفيسور عزة
ديزيز
5 minutes اذا ممكن.
اوكي. اما يبقى عندي ديزيز ابقى عارفه ان الديزيز ده له تريتمنت. تمام. بما ان له تريتمنت انا مش هتكلم على انزيم ريبليسمنت ثيرابي ان اي اس ام دي، بس الانزيم ريبليسمنت ثيرابي ان اي اس اي افيلبل وبيعمل فيري جود ريسبونس للبالمونري والليفر ديزيز، ودي حاجه اوف جريت امبورتنس. ثالث حاله بقى انا هكلمكم عليها قريبتهم كده، انا هكلمكم على this patient and another patient وخلصت عشان نبقى غطينا جزء الانبورن ايرز اوف ميتابوليزم. البيشنت دي she presented by the age of 2 years first cousin parents عندهم similar condition in a cousin جايه بابدومينال انلارجمنت من سن 6 شهور delayed motor وmental development difficult swallowing recently عندها convulsions weight and height below the third centile huge splenomegaly moderate hepatomegaly الهيماتولوجيكال parameters are not severely low والبون مارو examination is infiltrated with lipid laden macrophages. يبقى دي lipid storage disease. حضرتك عملت سفينجومايلينيز وبيتا جلوكوسيديز اس طلعوا نورمال، يبقى العينه ديت لا هي اي اس ام دي ولا هي جوشيه. حضرتك بقى هتعمل ايه او اللي احنا عملناه بالظبط؟ هتبعت العينه testing for molecular diagnosis of Niemann-Pick type C. طلعت positive for a gene of Niemann-Pick type C. ومش بحب النيمان-Pick it's not an enzyme deficiency. النيمان-Pick is ان الميوتيشن في ال NPC1 or NPC2 genes بيمبير intracellular transport of cholesterol فيعمل lipid accumulation in different organs including the brain, so it is a neurodegenerative disease فيعمل لي progressive neurological and developmental problems. خليني اقول لكم يعني it can present من اول الانفانسي بفيتال اسايتس هايدروبس neonatal كوليستيزس. يبقى لازم نسال على كله splenomegaly in the different phases of life and it can result in neurological and psychiatric manifestations. كنا قبل كده بنقول ان التريتمنت الوحيد الموجود اسمه ميجلوستيت، والميجلوستيت ده بيشتغل على النيورولوجيكال مانيفستيشنز فاشل. تمام. recently 2024 في FDA approval of a new drug اسمه ميبلايفا. ما فيش لسه ستاديز كتير بتقول على الريزلتس بتاعته، ننتظر بقى ان حضراتكم تكلمونا على الستاديز. اخر عيان انا هتكلم عليه العيان ده، وانا اعتقد ان this patient is very important. جه الهيماتولوجي كلينيك لما كان عمره 3 شهور، هي بيبي جيرل عندها progressive abdominal distension severe failure to thrive pallor recurrent fever recurrent attacks of vomiting and diarrhea over the last month. البيرنتس فيرست كازن كانوا عايشين بره مصر She has a similarly affected son who died at the age of 1 month. الفاميلي هيستوري فيها maternal cousin died early in the first 3 months with a provisional diagnosis of familial hemolytic hemophagocytic lymphohistiocytosis without molecular confirmation. تمام. ده المنظر اللي انا قلت عليه clinically and by CBC. CBC severe anemia thrombocytopenic لكن very تمام. فلما نيجي نبص كده طيب حلو شكينا في الاتش ال اتش، عملنا الانفستيجيشنز بتاعت الاتش ال اتش، فايبرينوجين واطي، فيرتين 1600 عالي، ال دي اتش عالي، ترايجليسرايدز عاليه، اي ال تي يعني نورمال، لكن الاي اس تي از دبل ذا نورمال، الالبومين از لو والكومز تيست از نيجاتيف، وعملنا بومارو قال لي ما عنديش لا مالجنسي ولا عندي هيموفاجوسايتوس. لكن العيانه دي كانت fulfilling 5 of the 8 criteria of HLH، فتعالجت على انها HLH. وبعتنا الموليكولر ستاديز للفاميليال ليمفوفاجوسيتك هيستيوسايتوزس للجينيتك لاب. خدت التريتمنت بتاعنا بتاع الاتش ال اتش اللي انتم كلكم عارفينه، الدكستا واتوبوسيد وانترستيكال ميزوتريكسيت. وان سبايت اوف اتش ال اتش تريتمنت الكلينيكال كونديشن بتاعتها كانت deteriorating. Progressive increase in organomegaly, recurrent diarrhea, progressive anemia with thrombocytopenia, elevation of liver enzymes, prolongation of PT وPTT. فيرتين بقى كان عمال يعلى يعلى يعلى، وصلنا الى اكتر من 20,000. البون مارو اكزامينيشن واز ريبيتد، وحاولنا نشيل الاذر انفكشوس كوزز. بون مارو كان طبعا كان شوكي. البون مارو كان فيه ليبيد ليدن جاينت هيستوسايتس، انا بتكلم على حاجه من ليبيد ستورج ديزيزز. فعملنا بيتا جلو اسي وعملنا سفينجومايلينيز طلعوا نورمال. تمام. وقلنا طيب احنا هنعمل للعيانه دي وجالنا ساعتها الجينيتكس بتاعت الفاميليال ليمفوهيستيوسايتوزس طلعت نيجاتيف، يبقى العيانه بتاعتي ما عندهاش فاميليال هيموفاجوسيتك ليمفوهيستيوسايتوزس، هي عندها اتش ال اتش سكندري تو اي ليبيد ستورج ديزيز. فكرنا جديا في البوسيبيليتي اوف وان اوف ذا ديزيزز اسمها لايزوزومال اسيد لايبيز ديفيشنسي، واتعمل لها الجينيتك ستادي. الديزيز ده كمان بنسميه وولمان ديزيز، وفي منه الهوموزايجوس فورم والكومباوند هيتيروزايجوس بيجي كومبليت لايزوزومال اسيد لايبيز ديفيشنسي ورير presents in neonatal وليثال in the first month of life. لكن لو عندي mutations فيها still a residual اسمها cholesterol ester storage disease less severe exhibiting variable phenotype، بس characteristic ليها كمان عشان عندي insufficient free cholesterol available for steroidogenesis ممكن يحصل فيها adrenal insufficiency و subcapsular adrenal calcification. The diagnosis is by enzyme SE. There are a lot of reports of HLH secondary complicating Wolman syndrome. اللي يهمكم حضراتكم ان النهارده وولمان سندروم ليها علاج. تمام. اخيرا انا هقول بس التايتل. البيشنت ده بفكركم ان one of the manifestations لما يجي لي عيان عنده autoimmune hemolytic anemia with splenomegaly، تمام، واي جي جي بتاعته عاليه، وعنده recurrent chest infection، تمام، exclude primary immune deficiency. ومن الحاجه اللي احنا بنشوفها كتير دبل نيجاتيف، تعمل دبل نيجاتيف تي ليمفوسايتس عشان الاوتو اميون ليمفوبروليفراتيف سيندروم، لان الاوتو اميون ليمفوبروليفراتيف سيندروم اسوشيتد وذ انكريزد ليمفوما ريسك. ما ينفعش تدي ريتوكسيماب، هتزود له الريسك اوف انفكشن، وما ينفعش تعمل له سبلينكتومي عشان لو عملت له سبلينكتومي ستيل هيحصل له الهيموليسيس هتكمل، وسبلينكتومي از اسوشيتد وذ انكريزد ريسك اوف sepsis related death. وبفكركم دكتوره حنان، بفكركم هقول لكم بس التايتل. عيان ده زي الاولاني اللي انا وريته لكم هيباتوسبلينوميجالي وبنسايتوبينيا و14 شهر، بس طلع في الاخر دايجنوزس فكروا فيه من فضلكم جوفينال مايلومونوسيتيك لوكيميا. تمام. and the last patient كان طلع childhood sarcoidosis، مع ان الساركويدوزس is not rare in adults بس childhood sarcoidosis is rather rare in children. تمام. ف my last message is splenomegaly could be the clue to serious but treatable. ده اهم حاجه. rare diseases rare disease rare causes splenomegaly ممكن تبقى metabolic، يمكن دي اللي ركزت عليها، immunologic neoplastic or induced by rare infections should be recognized, investigated, early intervention to avoid misdiagnosis which is not uncommon in rare diseases. وطبعا طبعا 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 لما يبقى عندي such a disease اهم حاجه عندي ايه؟ prevention. تمام. to avoid consanguineous marriage، نعمل antenatal diagnosis. So treatment is not just the treatment of the disease، لكن أنا I am working to decrease البردن على الهيلث policies والهيلث economics والفاميليز and their quality of life. شكرا لحضراتكم.
Thank you very much, Professor Azza. And I think we will move to the third talk of our session with hyper-eosinophilic syndrome update on management. It will be presented by Dr. Adib Balkhi, who is an associate professor of medicine at Al Qura University. He's a consultant of internal medicine, allergy immunology at King Abdullah Medical City and International Medical Center in Jeddah. So, floor is yours, Dr. Adib.
Thank you so much. All right. Thank you so much for, I would like first of all to thank the organizing committee for the invitation, and it's really a pleasure to be here. I always say we interact with many specialties, including pulmonologists, ENT nowadays, GI. I think we find challenges, dealing with the other specialties, but I always enjoy working with our colleague hematologists because we speak the same language. We speak the same cells. So we have common understanding. It's really
It's a shared feeling.
Yeah, the same. Yeah, thank you so much. So it's very interesting how we really now evolved and how things has been changed on the landscape with the precision medicine and precision therapy that we are sharing nowadays. So I think the same talk and the same talk with all the previous speakers when we talked about the rare disease. We think rare disease, but we have to think it's not a rare disease, probably it's underdiagnosed, or now we are more and more have more restricted definition where basically what we think different diseases is different entity, but it's now it's common group and the newer entities. Now, one of the things I think you'll see it more and more hyper-eosinophilia. It's coming more and more common, especially with evolving what we call it now type 2 inflammation in the realm of atopy, with now more of genetic, pulmonologists, ENT, and other specialties now looking into these diseases. We start seeing eosinophil, which is a very dear cells to our immunology, where basically you see these referral to you and to us more and more, and we think about these diseases not a rare disease anymore. So this is my objectives. I'm not gonna touch base on it with the limited time that we have, but I'm just gonna focus on the last two quickly later on. Now, this is something that we all know. Hyper-eosinophilia or eosinophilia in general, it's divided in mild, moderate, and severe based on the level of eosinophil count. When you have 500 and more than 500, you think about eosinophilia, but from 500 to 1500, we call it hyper-eosinophilia or mild hyper-eosinophilia or eosinophilia. From 1500 to 5000, we call moderate and markedly eosinophilia more than 5000. Now, one of the biggest mistakes when we talk to our colleague in primary care physician and internist, when they think about eosinophilia, they always look into percentage. Never ever look to the percentage. Never ever. We always say look to the absolute. Absolute is the key. So, and they always look to the WBC. I always tell them don't ever use CBC alone. Always get DEF with the CBC. That's going to give you more information. Now, believe it or not, it's our immune system is very interested, especially in this situation, where we basically we have two different pathways. Where basically sometimes you see eosinophilic disease as an autoimmune disease, and sometimes as an atopic disease. It all goes back to genetics and the milieu of cytokines that drive the disease. So it has two sides. Maybe they can present as an autoimmunity, or sometimes they present as disease of atopy. Now, when it comes to hyper-eosinophilic syndrome, simply speaking, this is known to all of you. We have 1500, that's a cutoff, that's a clear cutoff, and you have to redo it at least once a month in different between two phases, and then you have to have an end organ damage. Whatever the end organ damage, neurogenic, cardiovascular, pulmonary, or cutaneous, but you have to have an end organ damage. Now, they say it's a rare disease, but to be frankly speaking, it's more than that. And as my Dr. Hasna or Dr. Azza, Prof. Azza before said, it's all about the society. Our society is different. Unfortunately, we don't have our own data. It's all relied from US and Europe, but we don't have our own data. But I think our patient population is unique. It's not like others. So I think we are having more patients more than the others. Now, this is how they usually present, and this is the end organ damage. When we think about hypereosinophilic syndrome, we have to think about end organ damage. Once we see 1500, you ask about end organ damage symptoms. And usually this is the most common presentation when it comes to asthma or pulmonary involvement. You have wheezing, shortness of breath, and cough. But I want to highlight one of the most, and I wouldn't say characteristic, but almost always in every patient with hypereosinophilic syndrome, they have this symptom, which is fatigue. Believe it or not, fatigue, it's universal. That's why even in the clinical trials, they look to the fatigue score, and it's one of the primary and sometimes secondary endpoints and sometimes the primary endpoints, okay? So fatigue, it's one of the key things that you have to look into as well. Now, the pathogenesis, where it happens, what's exactly happening? I mean, the most one you are dealing with as a hematologist is somatic mutation, where you have FIB1, L1, PTGRF1, alpha and beta mutation, or the growth factor mutation and the receptor mutation. And this somatic mutation is deletion of the microsomal level, where basically they give you clonal myeloid variant. But the other ones, you don't have any problem with the cells itself. We don't have a mutation or clonality. Sometimes you have another one also, you have clonality with lymphocytic variant, but the problem is with over-secretion of the cytokine that produce or make these eosinophils proliferate and survive for a longer period of time. So the other one is cytokines that producing the eosinophilic survival rate. And the last one, that's something we don't know yet. There is 2 families only in the world that known to today days. They have familial hypereosinophilia, but nothing else than that 2 families. So it's not one of the categories that we think about nowadays. Now, we have idiopathic. Idiopathic means we rule everything, exclude everything that we call idiopathic. And you can see here is the majority of patients. More than 50% of patients, they are idiopathic. So it's very common from among all hypereosinophilic syndrome. But when you talk about overlap, it's one of the hard things, especially when we deal with asthma, with nasal polyps nowadays. We don't know which comes first. They have 1,500 eosinophil counts, more than 1,500. But who comes first? Is it the disease itself caused the hypereosinophilia, or the hypereosinophilia infiltrated the tissue and caused hypereosinophilic syndrome? We don't know which one comes first, the chicken or the egg. And this is when we call it the overlap. They have a single specific organ, not different organs, only a single specific organ where we have hypereosinophilia. So that's we call it overlap. Until today, we don't know how we can differentiate which one comes first. The second one, which is the one you probably face a lot, which is lymphoproliferative variants, where basically you have lymphoproliferative variants where you have basically neoplasm, you have somatic mutation with FIB1, PTGRF gene mutation, JAK2 mutations, and the other mutations that you deal with, and that's basically in the realm of hematology. The one is coming more and more, and we have to think about it more, which is lymphocytic variants, where basically you have apparent CD3 negative, CD4 positive lymphocytes, where basically these cells, they start produce IL-5 like crazy. Now, it's hard because they don't present in the plasma or in the blood, too many of them, so it's hard to make the rearrangements. It's hard to figure out if there is a clonality in these variants or not. And unfortunately, some of them, they may progress to lymph malignancy as well. Lastly, which is associated, which is basically patients have a mild eosinophilia, fluctuating up and down with other atopic conditions or other conditions. Now, why is very important we have these to identify all these variants? Because we moved, you are leader in this. We are dealing with precision therapy since before other specialties. But in this realm, we have to identify these variants so we can target the treatment based on each variant. Now, This is probably just published 2 months ago. It's the biggest data yet we have on patients with hyper-eosinophilic syndrome, where basically they looked into all patients with eosinophilic disorders, and you can see it including IgG4-related disease, IgBA and lymphoid variants, and neoplasm variant. But as you can see, it's even with real-world data. This is more than 700 patients, or close to 800, but they have complete data of 550 patients. About 50% idiopathic. So we don't know exactly what's happening, why the disease is driven by that. And majority, the others is subdivided on the other subcategories. But what's interesting in here, I want you 2 points to highlight here. The common organ that involved in hyper-eosinophilic syndrome related to lymphoid and myeloid, it's a skin. And this is you see it a lot in your in clinical practice, where basically they present with cutaneous disease. But the other one with idiopathic, we probably see it with the lung and nasal tissue as well. Now, unfortunately, because of the nature of the disease, especially the idiopathic, the treatment is a steroid. We're going to talk about the steroid and the treatment itself. But as you can see, only minute of patients, about 15%, they have a single flare. They have during the course of the disease. The nature of the disease is remitting, relapse and remitting disease. And some of them, they have a persistent disease. So these type of patients, they will require a steroid for a long period of time. We all know the complication of the steroid and the things related to steroid. So to speak quickly about basically the disease, it's not rare. But if we look into the disease, we see that disease, it has a very long until we receive the patient and we diagnose them. By that time, probably these patients already have end organ damage. And these end organ damage is irreversible. And the problem is with the empirical treatment, it's steroid. The morbidity and mortality related to steroid is too high. We have to think outside the box and not to be dependent on steroid. And talking about psychological related illness due to the disease. Now, how we approach these patients. Sorry. Okay, sorry. So we have 1,500. We have to think about secondary causes. First of all, we have to think, is there end organ damage or not? We ask about these symptoms that related. If it's no secondary cause, if there is secondary cause, so we have to treat the underlying cause, parasitic infection, so on forth. But if it's not, then we have to do the cytogenetic testing and do the testing for molecular testing. If it turned out to be what we call in myeloid lymphoid neoplasm with eosinophilia, this is in the word of hematology. In the word of hyper-eosinophilic syndrome, we call myeloid myeloid variant. Then we have to treat it the same and treat it in different ways. We can't talk about the treatment plan. If no, then we have to think about clonal, or we could think about lymphocytic variant. And we can also have to rule out eosinophilic leukemia. And if it's still not positive, then we think about more and more towards lymphocytic variants and what we call it idiopathic hyper-eosinophilic syndrome, and we treat it based on that. So I have one patient now investigating and went through a lot of investigation. Unfortunately, this patient, his eosinophil count usually around from 7,000 to 10,000, okay? And he's completely asymptomatic. Should we deal with this patient, or we just watchful waiting? I'm telling you, from eosinophil, there's 2 types of eosinophil. There is what we call a resting eosinophil, and there is reactive eosinophil, okay? Once eosinophil become reactive, never stops. We don't know one. But now, especially in the area of asthma and nasal polyps, we're trying to be proactive, not to wait until we have the end organ damage. Once it happens, it's irreversible. So we have to think proactive and not leave this patient because it's going to happen sooner or later. Now, quickly, on the treatment of these subtypes, when we have, based on the myeloid, when we have the mutation, again, everybody knows it's Gleevec. Go ahead and give Gleevec, imatinib, where basically it's probably you can reach the cure with Gleevec. If you treat it about 45 months, equal to 7 years, you may reach to the cure. So that's why it's so important to check for FIB1L1, because once you have that gene, you maybe have the risk, or sorry, the potential benefit of having cure to these patients. But sometimes it's negative, then probably you think our other gene mutation, then we usually send it to our colleague hematologists, where basically they have different treatment. Now they have, I think, one of the JAK inhibitor, tyrosine kinase inhibitors, I think bigomanetic or something like this. So there's other modality of treatment that we don't deal with it. Usually we send it to our colleague hematologists. And unfortunately, and one of the key things, usually sometimes I test my patient when they come to with higher hyper-eosinophilia, I give steroid, a course of high dose steroid. If they're not responsive, this is almost always is myeloid variants. So it just matters until we do genetic testing, until we get it. I'm not sure literally if this is affect your cytogenetic testing or not, but this is one of the tools that we usually screen or hypothetically screen for a possibility of myeloid case. So other TKI, dasatinib, it's been investigated, and sorofatinib as well is being investigated. You know, second line of treatment like hydroxyurea and interferon gamma, interferon alpha, it's something also being used. Quickly speaking about CD3 negative and CD3 negative, CD4 positive lymphocytic variants, basically, or idiopathic, usually the first line of treatment is steroid. Steroid is the first line of treatment, but usually it's not the one we prefer, because surprisingly, you give it to the patient miraculously improved. But you would struggle with the patient, trying to taper it down. Once you taper it down, patient flare, you go up and keep on forth. And you start keeping these patients on 10 milligrams, 7.5 milligrams the rest of their life, or trying your best, trying to wean them off. But usually they stuck with it. This is when we start thinking about steroid-sparing agents. Previously, we were only thinking about interferon, bigylated interferon alpha, where basically it's the safest one among all interferon gamma, but when it's affect both lymphocytes and IL-5 and eosinophil both. So interferon gamma and the other one hydroxyurea, which basically decrease all the lineage, not only affecting eosinophil. Why it's not important anymore? Tell me how many time you have?
2 minutes.
2 minutes?
Yeah.
Bye. Wait. Why these is not very effective anymore? Because most of these patients with second line, either they are lacking efficacy or they're not responding to the treatment. This is when we have to think outside the box. We are going to more targeted therapy. So we know that eosinophil, it's highly dependent on IL-5. They cannot survive with IL-5. So we should target these cytokines where basically it's evolving in eosinophilia voices or migration or recruitment to the tissue. So this has been investigated and has been highlighted. There is so many targeted area where basically you can think about and already been approved, like have been approved, and pertuzumab, it's been under investigation, and you can think about JAK2 inhibitors like roluxetinib, and imatinib, where basically TKI, it's one of the things. Now, one of the most exciting one, it's actually just preclinical has moved, and they are now doing the research on it. It's EMR1. EMR1, it's exclusively on the eosinophil, on the mature eosinophil. It's not found in any other myeloid cell. So this is one of the things that you can selectively go ahead and give it to the patient, but it's still phase 1 and phase 2 trials ongoing. Cyclic 8 has been investigated in asthma. It's failed to improve in asthma, but it's significantly reduced the eosinophil count. Other ones, integrins, that migration of the eosinophil to the tissue, you could think about. So quickly, I'm just gonna briefly just talk about the one who's already approved, where basically it's meblizumab. Meblizumab, it's been investigated for a long time, since 2005, since it was IV formulation. It's showing over and over it's affecting or decreasing the eosinophil count and decreasing basically the flares by 50% compared to placebo. And even in annualized reduction, it's up to 60%, 66%. And not only that, also it decreased the eosinophil counts significantly. This has been also extended over a year. This is what's 32. This is called FLAIR-2, FLAIR study, but extended over a year, and it shows continuous improvement despite being while being on mepolizumab. Even placebo group, when they switch to mepolizumab, has significant reduction in their eosinophil count. This is not only that, but also decreased the dependency of oral systemic steroid. So oral systemic steroid goes down with time as long you're on mepolizumab. Lastly, just showing highlight, only 1 minute, highlighting the other medications like benralizumab has been investigated. It's already passed phase 2 trials, showed significant results, and it's ongoing phase 3 trials nowadays. And we've been experiencing patients with benralizumab, and they're doing extremely well on benralizumab. Ruxolitinib, basically, it's a JAK inhibitors. It works on the same pathways, where basically JAK-STAT pathway, where basically stopping the IL-5 receptor antagonist, IL-5 to the down signaling cascade. This is the data, has been phase 2 trials. Tyrosine kinase, we talked about it, imatinib. It's already been showing in patients with positive mutation, but also being investigated with negative mutation and showing good results as well. Last thing, this is very interesting pathway and we'll call it target. They didn't target nowadays only eosinophil. They went up higher, where basically they're trying to target CCR4, which is the receptor for TARC, CCL17, where basically with mepolizumab, it's through the antibody-dependent cytotoxicity effect, basically depleting only CD3 negative, CD3 positive T cell apparent cells. So think today more and more not to be dependent on steroid. Think about steroid, maybe the first line, maybe you give it for one trial, but if the patient relapse, you can quickly move on the second line of treatment, which is a much safer line of treatment, which is eosinophil targeted therapy. We are doing this even in other atopic condition or type 2 inflammation more early now. We don't wait to have end organ damage from asthma, from the nasal polyps as well. So, trying to catch up quickly. So, quickly, nowadays we always think about multidisciplinary team interaction. So we are trying our best to be collectively discussing these patients. We are dealing with this patient together. So once we have these patients, we have to have a multidisciplinary team discussion where basically you end up helping this patient and trying to prevent disease flare and organ damage and the treatment side effects. So the conclusion of my talk, there is, thanks God, there is happy days nowadays. We have these targeted therapies, safe, very effective. Keep in mind, mepolizumab, there is patient that has been taking mepolizumab for more than 20 years now. More than 20 years since the early stage of mepolizumab treatment, and been showing very safe data where basically they can take in these medication without having cytotoxic effect. And usually it's responsive, but we have to keep in mind this is not a curative, this is only suppressive treatment. And the only problem now, issues that may not resolve, it's basically we need to understand more of the pathophysiology. We're trying to have more and more disease or pathomechanistic effect where basically we can cure these diseases. And with that, I conclude. Thank you so much.
I would like to invite all the three speakers to come to the stage for questions.
Okay, thank you all for this excellent session. And actually, my question and my issue will go to Dr. Adib. Actually, I think we are in the era of sub classification. And if you see some sub classification where it was based only in case report on case series, and this is what's happening with familial HS. I was teaching and I was searching for this category since 2007, actually, when it's been added in the workshop and in the classification of hyper-eosinophilic syndrome. And I think now the turn is on the lymphoproliferative hyper-eosinophilic syndrome, because there is no clear diagnostic criteria. And to be honest with you, the majority of the cases that we label them as lymphoproliferative hyper-eosinophilic syndrome tend to be preceding a lymphoma or sometimes acute B-cell leukemia. So do you agree with that? That there is no clear diagnostic criteria, and sometimes when we become happy to diagnose this patient with lymphoproliferative hyper-eosinophilic syndrome, at the end of the day, we will discover that we are catching the lymphoma or leukemia sometimes in early stages. So what do you think about that?
I completely agree with you. I think it's always start with a trigger, that something caused the disease process start to happen. Now, maybe we share this, I will take it from a different angle. We share a lot of lymphoma cases or leukemia case in immunodeficiency patients. Once you have immune dysregulation, okay, the chronic inflammation, it's activate different pathways that it tends to become lymphoma and leukemias. So I think it start as a dysregulation, what you call immune dysregulation. But our late discovery, late treatment lead to lymphoma. You know, the problem is our intervention was not targeted. We are not targeting the disease. Either we late diagnosis these patients, maybe they end up coming to you in the late stage, you treat them for a short period of time for lymphoproliferative disease, but it turned out to be lymphoma, maybe because of under treatment at that early stage, or they already have, as I said, in the realm of hematology, they call it myeloid lymphoid neoplasm with eosinophilia. We are dealing with it, hyper-eosinophilic syndrome. We call it myeloid variants. You see the difference? It's all dependent on the classification. I see classification is different. This is WHO classification that I just told you. In hyper-eosinophilic, we talk about differently. Now, I think advances that we have with the genetic testing, with more precision early on discovery of these mutations, I think we are moving towards more, as I said, sub-subs classification, where basically we can target them early on. The problem that we face as a specialist is not us. It's actually our primary care physicians and our internists, they refer to us early on. So I agree with you. I think it's all start with immune dysregulation. And I always say the teacher of immune system, it's thymus and bone marrow. If you have some dysregulation in there, the student is going to become bad students, because a lot of dysregulation.
Question from the floor. Yes, I have actually a comment on this issue. We are not different. We are not against each other from different specialty. It's the way our brains have been processed. How do we look? Like if you have the Kohinoor, you are looking from a facet, I'm looking from another facet. That's why we are speaking different languages. For us as hematologists, and because most of the attendees are hematologists, we do have two blanks or مجرى. We are in the middle of that. وفي paper رائعة open access في الامريكان جورنال of hematology منشورة في آخر 2024. Speaking about everything concerning eosinophilia from our point of view as hematologists. And we have to classify them. We have to ask ourselves just a couple of questions. If we are able to reply these two questions, we will go directly in a very precise way. Number one, is this primary or secondary? Because we know a huge array could be a secondary eosinophilia. To exclude the secondary, then we will ask the next question. Is this clonal or not? If it is clonal, so it is our territory. This is a hematological condition. It differs in the pathogenesis from the myeloid-related eosinophilia because we have very well-established genetic background. Platelet-derived growth factor alpha and beta on chromosome 4 and 5, and that's why we use imatinib. We have JAK2, we have BCR-ABL, and we have fibroblast growth factor. That's why some people are treated with not imatinib, but ruxolitinib, And we have a rationale for that because they are having Abelson or JAK fusion gene. What the problem is still there for the fibroblast cross factor. Okay? The lymphoblastic related eosinophilia, the mechanism is different because it is proliferative and reactive. That's why mepolizumab anti-IL-5 is highly indicated with the lymphocyte-related eosinophilia. So the way our brains are processed, hematologists, is a bit different from you. Once it is clonal, it's not allergic. It's not hyper-eosinophilic. It is something else, our territory with specific nomenclature and target therapy tailored according to the molecular abnormality. That's my comment.
Little comment, thank you. This shows the value of multidisciplinary care. Yeah. We should work together, immunology and hematology, to get the patient to the safe side. And thank you. We don't see a lot of hyper-eosinophilic syndrome in pediatrics. I remember we have seen 2 patients who had the hyper-eosinophilia and leukemia, and they did present with thrombosis. One had a cardiac thrombosis. Okay, so it's important to publish these cases, to collect the data, to make a registry not for the number, but for the prognosis and the outcome in all rare diseases. This is very important. حضرتك قلت حاجة extremely good. In whenever you have a primary disease or whatever a rare disease, يهمك individualization, prediction before the complications do occur. عشان كده احنا دايما نقول العيان اللي عنده rare disease should be managed in an expert center. علشان احنا هدفنا yes, and we don't develop the complication, we prevent the complication. شكرا لحضراتكم جدا. شكرا.
Just I have comment actually to your comment, doctor. I think this is really very important point that if you get the mutation like the BDGFR there, that means it is malignant, it is clone, and we should deal with it. And I just want to say it earlier. I have a question actually about that metabolic disorder because a few weeks ago I just got a patient. He's, I think, in his late 20 with pancytopenia and turned it to be Gaucher type 1. Most of the patients which you show us, they are pediatric. And if you are going to replace their therapy, let us say for 60 or 70 years, the cost is big burden in the health system. Do you think that stem cell transplantation is still valid alternative to replacement therapy in such patient, especially cost-wise?
This is the question I'm always asked. Speaking of type 1 disease, we have a group of adult patients with type 1, and usually those who come to our center because we are becoming a center for treatment of Gaucher disease, in spite that we are pediatric hematologists. Those who come are those who are having something like aseptic necrosis of the head of the femur, impending aseptic necrosis of the head of the femur, the type 1. Some of the ladies, they did have a pregnancy and they have one child and they did develop, and she developed severe bleeding during following delivery, and she passed undiagnosed with the second delivery. They did diagnose her. There are criteria who are the patients to be given enzyme replacement therapy or the substrate reduction therapy, because in type 1 disease in adult, there is another form of therapy, which is the eliglustate. It is substrate reduction therapy. It is not intravenous. There are criteria who should receive treatment and of the seriousness of the disease. Among these, one of the important factors is the severe osteoporosis, the bone disease, the splenomegaly, the cytopenia. It doesn't affect fertility, but if it did affect the fertility, so the treatment is indicated. There is a big list. Interference with quality of life also. In adults, it's not like in, I should say 2 points. I said 2 points. In type 1, in adults beyond the age of 18 years, they take the enzyme replacement therapy in a dose which is modified. Means that if in children we give 6 units per kg every 2 weeks, In adults, they receive the 30 units per kg every 2 weeks. And there are many studies which have they experienced if we can reduce the dose more, but these patients should be monitored during the dose reduction, because if we find something which is not going fine, we return them back. This is one point. The second point, عشان حضرتك you have a patient 22 years. There are a lot of reports now speaking of late onset type 3 Gaucher disease starting in adults. Genotype is important, but another important is one of the monitoring criteria of type 1 is to follow this patient neurologically, because some of them, there is a UK study published, there is late when they revised the adult patients with Gaucher, they reclassified some of them. And this can be done. You may not see the ophthalmoplegia and the squint, but if you refer the patient to a ophthalmologist or neuro-ophthalmologist, they can detect the weakness of the muscles, and he is reclassified. أنا هقول ثانية واحدة بس. My last comment. أنا هرد على حضرتك يا بيه على الكوست. Cost is cost effectiveness. تمام. We have seen patients dying of Gaucher disease. احنا حضرتك اشتغلنا بقى لنا 25 سنة. اتقال لنا ايه الولاد المتخلفين اللي انتوا بتعالجوهم. اتقال لنا بالظبط كده. الولاد المتخلفين اللي احنا بنعالجهم اللي هم they started by the age of 4 years. النهارده عمرهم فيهم ناس تايب 3 عمرهم 32 سنه متجوزين وفاتحين بيوت وعندهم اولاد. فانا I believe ان الهيومن being life لا تساوي اي ثمن. Thank you. شكرا لحضرتك.
يعطيكم العافية. Thank you. I'm sorry for interruption for the speakers, but time is running. Thank you very much. يعطيكم العافية. Excellent session.
Hello everyone. I'd like to introduce myself. I'm Dr. Abdullah Al-Muhammadi, Assistant Professor and Hematologist at King Abdulaziz University in Jeddah. Welcome to our session today on thrombosis. Before we dive into our session today, I'd like to introduce our esteemed co-moderator, Prof. Jalila Zahir. She is a professor and hematologist at King Abdulaziz University in Jeddah, and Prof. Jalila brings a wealth of expertise in hematology, particularly in the thrombotic and bleeding disorder. So let's start by introducing our first speaker. It's my great pleasure to introduce our first speaker for today's session, Dr. Ashraf Warsi, who will be presenting the important topic of up-to-date updates in cancer-associated thrombosis. Warsi is a consultant in adult hematology at the Princess Noura Oncology Center, King Abdulaziz Medical City, Ministry of National Guard Health Affairs, Western Region. He is certified in internal medicine and hematology by the Royal College of Physicians and Surgeons of Canada. And also he has the American Board of Internal Medicine. Dr. Warsi, we are honored to have you here today. The floor is yours.
Thank you very much, and thank you to the organizing committee for the kind invitation. I can promise you we'll be finishing before 20 minutes, so we can catch up on time. So I was asked about let's see the slides on the screen. Okay. So I was tasked with talking about updates on cancer-associated thrombosis. So basically, I'm just going to cover a bit of introduction about that. The recent developments have been a lot of development in the pathophysiology and understanding why do these patients have increased incidence of thrombosis. More recently, there have been a lot of developments in prophylaxis, in treatment, and also on extended treatment. So we'll go through that in the following slides. So probably it's been around 200 years since the first description of thrombosis and cancer patients, which was originally described in France. But more or less, it's not only DVTs or PEs. Now people are considering arterial thrombosis, which we used to not think about in cancer-associated thrombosis previously. Cerebral sinus thrombosis with brain tumors or metastatic brain disease have also been there, and also splanchnic venous thrombosis. Although some of the trials are still lagging behind in including these patients in their samples. So incidence ranges between 0.5% to 20%, depends on which area of the world, which type of cancer, which stage of cancer you're looking at. Probably the highest incidence, as most of you agree with, is in primary brain tumors and pancreatic cancer. The Saudi description to the incidence comes from King Saud University in Riyadh, who looked at 5 years of retrospective data of 5 years of patients referred to their center, and they found an incidence of around 6.7% of thrombosis in the first 6 months after diagnosis. So does the cancer stage and type do matter? So on your left-hand side, you can see that pancreatic cancer followed by lung, ovary, and prostate probably are the highest incidence. And if you superimpose the right-hand side image on it, if you have a metastatic disease, then yes, that's even in higher incidence of cancer. So that's very well established, and even the recent data also suggests the same thing. Does it cause of mortality? Yes. So excluding renal cell carcinoma, most of the other tumors, if the patient develops VTEs, they usually have increased mortality compared to their counterpart patients who do not have thrombosis. So probably that reflects more or less an active disease rather than being a direct cause of mortality, although some cases do develop fatal pulmonary emboli. What's the issues in cancer patients? So cancer patients, if they develop thrombosis, they have higher incidence of recurrence compared to non-cancer patients. And they also have higher incidence of bleeding compared to non-cancer patients. So it's a really challenging to treat these patients from both sides. They have higher incidence of recurrence, and they have a higher incidence of bleeding while on anticoagulants. So the pathophysiology of cancer-associated thrombosis goes back to Virchow's triad, which is basically stasis, vessel wall injury, and hypercoagulability, and it still stands till this day. Stasis in cancer patients happens because of prolonged bed rest, impaired mobility, edema and vascular compression, structural defects of the angiogenic macrovasculature. Hypercoagulability is multifaceted, to be honest. So there's upregulation of tissue factor and tumor on endothelial cells, proagulant conversion of cancer cells and stroma, comorbidities, which a lot of hematologists in Saudi Arabia believe that our population probably has more thrombophilia compared to other populations in the world because of consanguinity. Emission of circulating cancer cells, emission of tumor procoagulants, inflammation, endothelial cell activation, procoagulant effect of dying cancer cells, and necrosis. Vessel wall injury. Most of our cancer patients do undergo surgery. If not undergoing surgery, they do have indwelling catheters, which is again a vascular injury. Vascular remodeling and increased permeability leading to entry of plasma into the interstitium and thrombin generation is another risk factor. Vascular damage due to chemotherapy and radiation is also very common in cancer patients. So in fact, we have a lot of understanding in that. So cancer cells do release or express tissue factor, which can directly activate factor 7 and activate the coagulation cascade. They also release cancer coagulant particles, which goes and activates factor 10 independent of factor 7. They also have polyphosphates, which activates factor 12 and goes through the cascade of generation of thrombin. So that's how the procoagulant effect happens, but also they release tissue plasminogen activator, urokinase plasminogen activators, which affect the fibrinolytic activity. Also, there is a lot of interleukins, tumor necrosis factors, VEGF with cytokine release. All these parameters do help in the metastasis, whether local invasion or distant metastasis of tumors, but they do play a major role in the reason for thrombosis and bleeding in these cancer patients. They also recruit neutrophils and causing the nets formation, which is a major player in thrombosis in cancer patients. Why this understanding is important? There are certain parts of this diagram, for example, the microparticles that assays are being developed for it and have been included in research in risk assessment models to try to identify patients who are at increased risk of thrombosis in the cancer patient population. So, management of cancer patients. So, we'll go through step by step. So, once you see the patients, most of the patient will not have an immediate thrombosis. Only 5 to 10% will have an underlying asymptomatic VTE. But the first step probably before we treat is actually preventing. So there are different situations. So if your cancer patient is undergoing major cancer surgery or during hospitalization, probably that's the easier answer. So if they're hospitalized for non-surgical reason, they're treated as a medically ill patient and prophylaxis is agreed upon all the guidelines. If they're going a non-major surgery, probably also low molecular weight heparin is advised. If they're going a major surgery, especially pelvic abdominal surgeries, then extended prophylaxis for up to 4 weeks, so 28 days post-discharge is usually recommended by most of the guidelines as well. So that's probably was the easier part. In multiple myeloma, there has been a lot of development. So the International Myeloma Working Group long before have recommended if your patients have myeloma patients have these predictors of VT risk factor, they recommend prophylaxis. But more or less, there are specified risk scoring systems for myeloma. So the SAVED score, which looks at the different parameters, have been validated prospectively, and it's one of the recommended risk assessment models for myeloma patients. The other one is also the IMPEDE VTE score, and again, it has been validated prospectively. Under development is the PRISM score, which takes into account the IMiDs, or immune modulatory drugs, and it's lacking the prospective validation, but it's undergoing that part. So at the moment, the recommendations are either using the SAVED or IMPEDE VTE scoring system for multiple myeloma to assess for primary prophylaxis against VTE in this population. Pancreatic cancer, since most of the people do agree that's the highest risk, and there have been trials looking at either different low molecular weight heparins for prophylaxis, whether dalteparin or enoxaparin. The recommendation is actually those pancreatic cancer patients receiving systemic active chemotherapy should be offered pharmacologic thromboprophylaxis with an anticoagulant in line with the dosage and used in clinical trials. So probably this is one group of patients that should be provided, and I think those who are in practice have seen many of these patients developing thrombosis. So what about the ambulatory setting? So what about the other cancer types? What about lymphoma patients? So 80% of cancer-associated thrombosis happens in the outpatient, so not in your admitted patients. Different cancers differ in their risk groups, so that's one of the biggest challenges. And trials comparing primary prophylaxis in low-risk cancers have shown non-significant benefit. So that it has been in 2009 and 2012, different low molecular weight heparins were used. They did show benefit in prevention of thrombosis, but at the expense of some bleeding, which was not really significant, but the number needed to treat was quite significantly high. And the reason was they were prophylaxing everyone. So they included low risk, intermediate risk, and high risk groups. So number needed was treated with 50, and that's why it never changed practice. So people started developing different risk assessment models. And you can see coronary risk score developed in 2008. Probably the CAT score, the PROTECT, CONCO, COMPASS-CAT are built on that scoring system with adding different parameters. The red ones are actually specifically developed for different diseases. So the THROLI is developed for lymphoma, SAVED and IMPEDE VTE are developed for multiple myeloma. So you can see the whole idea of these risk assessment models is actually identifying those patients who are regarded as high risk who may benefit the most from primary prophylaxis. So the coronary risk score, this is the original publication. Originally, it was low risk, the score of 0, high risk 1 to 2, and or intermediate risk 1 to 2, or high risk. And it's really relatively simple parameters. So you just need to start with hemoglobin upon presentation, pre-chemotherapy platelet count, pre-chemotherapy white blood cells, type of cancer, whether it's according to the scoring system, and the BMI. If you notice, most of these parameters are actually present from the first visit of the patient. And that's why a lot of centers have included this in their IT system or the medical record system. So it actually calculates it automatically and pops up for the physicians to decide whether they want to choose a prophylaxis for their patients or not. So major development was the AVERT and Cassini trial. So very similar design trials. Both looked at ambulatory cancer patients, and they used DOACs. So they used apixaban or rivaroxaban at prophylactic dose. Inclusion criteria was a coronary score of 2 or higher. Probably they used the 2 instead of just 3 to include more patients. Exclusion criteria, they excluded acute leukemias, myeloproliferative neoplasm, stem cell transplant patients, or routinely they exclude the skin tumors, basically. Very similar demographics, screening. The AVERT didn't do screening, but the Cassini did screening, and they found that 5% of their patients actually had an underlying DVT prior to initiation of prophylaxis. The primary efficacy outcome was actually the incidence of thrombosis, and the secondary safety was basically the incidence of bleeding. So venous thrombosis rate, the AVERT trial was significantly lower in the prophylactic arm compared to placebo, where it was similar, non-significantly lower in Cassini trial. That was the intention to treat, but if you looked at the per protocol, it was lower. Major bleeding, they did, both of the studies had more bleeding in the prophylaxis arm compared to the placebo arm, but it was just slightly but significantly higher with the prophylaxis. So collecting both of data and doing meta-analysis, they showed that the relative risk for overall and symptomatic VTE by 6 months were 0.56 and 0.58 respectively. The absolute difference in symptomatic VTE between DOAC and placebo was 2.5, corresponding to a number needed to treat of 40, whereas the number needed to harm, bleeding was 100, so that was a lower number. So what happened after that, that most of the international guidelines on cancer, they do recommend that the patient should undergo a risk assessment prior to starting chemotherapy. And if they are felt to have a coronary score of 2 or higher, they should be considered for prophylaxis. Now, one of my fellows, who was a brilliant fellow, just graduated 2 days before, just asked me a question, since these are the recommendations from ASCO, ASH, NCCN, ITAC, and ESMO, why people are not using it? So I told her the reason behind that. So there's no clear evidence that primary prophylaxis improves survival. That was a secondary outcome in the Cassini trial, but again, it wasn't the primary outcome, so there's no clear evidence for that. That's number one. Second of all, the coronary scoring system doesn't include the type of chemotherapy. We do know that certain chemotherapies had different risks of thrombosis. For example, IMiDs have higher risk of thrombosis, so we're lagging that in that form. Asparaginase in leukemia, ALL patients, we very well know that increased risk of thrombosis. Risk assessment models must be reliable enough to account for the emerging risk while remaining clinically practical. So the risk may differ with the stage of the cancer, with the stage of therapy. It's not the same risk from the start to the end. High bleeding risk in cancer patients makes it difficult to offer every patient primary prophylaxis. Risk assessment models are needed in hematological malignancies. So as you have seen, most of these risk assessment, or the Cassini and the AVERT trial excluded leukemia patients. So we do need trials designed for these patients. So we're lagging behind. With all of these challenges, still implementing primary prophylaxis is a challenge for every oncology center. So that was the prophylaxis part. Treatment of CAD. So they've divided the treatment into 3 phases: the initial 7 to 10 days, long-term, which is 10 days to 6 months, and extended is beyond 6 months. So they, before probably 2002, we used to treat them with vitamin K antagonist. The pros were it's an oral medication, not affected by renal function, relatively easy reversibility with the availability of PCC. But the cons were has multiple interactions with chemotherapy, requires frequent monitoring. So the poor patients are coming for their chemotherapy, and you add extra visits for INR monitoring for them. And also depends on GI absorption, where most of our patients on chemotherapy, they have reduced GI absorption just because decreased oral intake or having GI malignancies. So the CLOT trial, it's been probably now 21 years since it was established, and it just a reminder, it did show decreased recurrence with low molecular weight with dalteparin, but the survival was similar. Have to say that the decreased incidence of thrombosis was not repeatedly seen in other medications, but nonetheless, the CATCH trial was done with dalteparin, and a meta-analysis did confirm, including different low molecular weight heparins, that incidence of recurrence was less and the bleeding risk was similar. So with warfarin, basically. So the standard became from 2003 and onwards, low molecular weight heparin for cancer patients with thrombosis. So why were we prescribing it? Probably it wasn't the decreased recurrence. The reason probably was convenience, so less visits, not needing monitoring, minimal interactions with chemotherapy, similar rates of lower VTE recurrence and bleeding, but it did have the inconvenience of injections. And those of you who may have tried it, my wife tried it for prophylaxis. After 2 days, she said, "You can inject yourself. I'm not going to use it anymore." So I knew it was very painful for them. So I always try my best not to prescribe nowadays low molecular weight heparin for these patients. So the DOAC trials in VTE did include very small number of cancer patients, and that led to the hypothesis that probably this was an option in cancer patients as well. So the first trial looked at edoxaban, which is probably the main DOAC in Japan, but it's also available in the kingdom. Some of the private sector, they have it. So the first trial in cancer VTE was the edoxaban trial, and it was a non-inferiority trial, which was proven, but they did show more major bleeding with the DOAC or with edoxaban. And this was driven from GI, mainly the upper GI and urogenital malignancies. So probably those two malignancies we should avoid DOACs in them. After that came the SELECT-D trial, which was basically what we can say it's a pilot study for rivaroxaban in these patients. And you can see the number in each arm was 203 on dalteparin versus 203 in rivaroxaban. And again, it did show a lower number of thrombosis in the dalteparin arm, in the rivaroxaban arm, but more clinically relevant non-major bleeding in the rivaroxaban arm. After that came the ADAM-VT trial, which again, it was a very small trial, around 140 patients in each arm. And they were looking at the safety and recurrence of thrombosis. So major bleeding was 0%, probably 0% because the number were just too small to show that. Also, the recurrence rate was lower. So after that came the biggest trial, the Caravaggio trial, looking at same design at the ADAM-VTE, looking at apixaban versus dalteparin. And from that point of view, it showed lower recurrences with same incidence of bleeding. So there was no increased bleeding with apixaban in this trial. Nonetheless, from that point on, DOACs became probably the standard of care nowadays for cancer-associated thrombosis. Okay, I'm almost done, by the way. So this is just a roadmap to how would you choose your best treatment, whether low molecular weight heparin or DOAC for your cancer patients with thrombosis. But nonetheless, if you look at the different guidelines, again, most of them are recommending DOAC as your treatment of choice for VTE in cancer patients. Now, the question, this was up to 6 months. All these trials that I have showed you are up to 6 months. Beyond 6 months, what to do? 2 minutes. Beyond 6 months, what should you do? So nobody knows that. Some people used to stop, which is very small percentage of people. Most would just continue, and some people would put them on prophylaxis. So in my center, we took the decision after discussing among ourselves from 2014 to put them after 6 months on prophylaxis. We didn't have any evidence, but there was lack of evidence to what to do after 6 months, regardlessly. The EVE trial tried to answer that. So very small number of patients, 184, 186 in the second arm, and it looked at apixaban 2.5 and 5 milligram after finishing 6 to 12 months of anticoagulation, therapeutic anticoagulation. And there collectively, they were looking at their hypothesis was that with the lower dose, they will have less bleeding. But unfortunately, they had similar numbers of bleeding in both arms. And what was reassuring also, they had similar numbers of thrombosis in both arms. So they didn't meet their non-inferiority criteria, and basically they said what the conclusion was that 2.5 didn't show lesser bleeding. My take on that was basically, okay, so we can use 2.5. Some people said, no, I'm going to continue with the same dose of 5. Nonetheless, 2 weeks ago, we got the APICAT, APICAT trial. So this is same design as the EVE trial, but it's a much larger study. So they randomized 1,766 patients after completing 6 months of therapeutic anticoagulation, whether it was low molecular weight heparin or DOAC, whatever, to 2.5 milligram apixaban versus 5 milligram apixaban. And they were looking at the rate of recurrence, and it was a non-inferiority trial. So the rate of recurrence in the fatal or recurrent venous thrombosis or non-fatal, in the 2.5 arm, it was 2.1% versus 2.8% in the full dose. Clinically relevant bleeding was significantly lower in the prophylactic dose, 2.5. Mortality basically did not differ in both arms. And from that, and just the Kaplan-Meier curves for those who are interested. So extended anticoagulation with reduced dose apixaban was non-inferior to full dose apixaban for the prevention of recurrent venous thromboembolism in patients with active cancer. The reduced dose led to a lower incidence of clinically relevant bleeding. And clinically relevant bleeding means major bleeding plus clinically relevant non-major bleeding, which is really significant for practicing physicians. So to conclude, significant development has been achieved in understanding the pathophysiology of cancer-associated thrombosis, incorporating biochemical parameters, type of chemo or immunotherapies, therapeutic agents in risk assessment models and their evaluation. Oral anti-10A agents have become the drugs of choice for managing cancer-associated thrombosis. Contraindication to their use should be evaluated carefully. Low-dose oral anti-10A agents will likely be the standard of care for extended beyond the 6 months of initial anticoagulation. And I thank you for listening.
Thank you, Dr. Warsi, for this excellent presentation. Now it's my privilege to introduce our second speaker for today's session, Dr. Mansour Radwi, who will delivering talk on the crucial topic of reversal in anticoagulant, direct oral anticoagulant. Dr. Radwi is a hematologist, epidemiologist, and economist with certification in internal medicine and hematology by the Royal College of Physicians and Surgeons of Canada. He also has the American Board of Internal Medicine. In addition, he holds a Master in Health Research Methodology from McMaster University and Master Health Economics and Pharmacoeconomics from UPF Barcelona School of Management. Dr. Radwi, we are honored to have you with us today. The floor is yours.
Thank you, Dr. Mohammadi, for the introduction, and thank you for the organizer for inviting me. So I think it's a nice transition. Dr. Ashraf Warsi has talked about DOACs in cancer patients, so I'm going to be talking about the reversal of DOACs and strategies and practical approaches. So I know the time we are starting late, so I'm going to be very quick, or try to be very quick. So objectives, over a quick overview of the DOACs and the bleeding risk. We're also going to discuss about what scenarios that require reversal, and then review agents that can be used for the reversal of the DOACs and the strategies that can be used when using these agents. So this is a figure that is showing the mechanism of the DOACs. We know that the apixaban, rivaroxaban, and redoxaban, they inhibit factor 10A, while the dabigatran is the direct thrombin inhibitor. So we know that we have a direct thrombin inhibitor. We have also parenteral, but because we're talking about the DOACs, I'm not going to be discussing them. The half-life of the dabigatran is very important to know. It's 12 to 17 hours because it's knowing the half-life is very important when dealing with reversing, when we are reversing this agent in patients who have normal kidney functions. Now, the indications, we know that the DOACs, the dabigatran is widely used in VTE prophylaxis, VTE treatment, and atrial fibrillation. Similarly, factor 10A inhibitor, rivaroxaban, edoxaban, and apixaban, they have similar half-life. Maybe the rivaroxaban has a shorter half-life, 5 to 9 hours. But overall, they have, I mean, the half-life is considered in teens. in general. Indications, they are used, and factor 10A inhibitors, they have off-label use more than the dabigatran. So similarly, they are used as a VTA prophylaxis, VTA treatment, and atrial fibrillation. In addition, rivaroxaban and pixaban can be used in HIT and in acute coronary syndrome as well, and for the treatment of superficial vein thrombosis. Now, the risk of the DOACs associated bleeding is usually around 1 to 3%. There was a meta-analysis that compared DOACs associated bleeding with aspirin, and they found out that there was similar rate of bleeding between aspirin, patients who are taking aspirin, and patients who are taking DOACs. This was also same for the intracranial hemorrhage. So the risk difference is quite similar when you compare them, but it is present there. But we have to know that the patients who take DOACs, they are heterogeneous population. So it's usually what we coined them at around 1 to 3%. It can be higher, and we know that when we looked at Hasbla score. Patients who were taking warfarin, this was validated score in patients who were taking warfarin, and we know that the more that you have factors that are in the Hasbla criteria, the more likely that you're going to bleed. So we just need to know that patients who are going to be taking DOACs, they might have higher risk of bleeding if they have certain risk factors. Now, moving to when to reverse DOACs, usually there are two indications to reverse DOACs. Either there's a very significant bleeding in a very critical site, or patients who are going to undergo surgery or invasive procedures. These are the patients who are likely to require reverse of the DOACs. Now, when we are using when we are planning to reverse a DOACs, we need to always think about the inherent risk of thrombosis compared to the benefit that we're going to get from reversing the DOACs, which is prevention of further bleeding and mortality. Overview of the reversal strategy. So we have two agents, specific agents, non-specific agents. I'm going to start with the first, with the specific agents. So either rituximab, this is a anti-dabigatran monoclonal antibody. It's usually it's a antibody fragment that binds to dabigatran, so inhibits its mechanism of action. So the dabigatran is not able to directly inhibit the thrombin. We know that the either rituximab is effective from the reversed AD trial. It's a non-RCT, it's a prospective cohort study, but this is a large study. And when either rituximab was used in these patients, there were two types of population. Type 1 population was the life-threatening bleeding. And when the either rituximab was used, the median time to the cessation of the bleeding was around 2.5 days. So it was effective. Also, patients who require surgery, the hemostasis was achieved in 93% of the patients. The use of the either rituximab was also associated with the small events of thrombotic events. Mostly were seen in 30 days, so about 4.8%, and 6.8% at 90 days. So the dosing, usually the usual dose is 5 grams. So each vial, so you use 2 vials. Each vial contains around 2.5 grams. This vial can be used, the 2 vials can be administered as a bolus or as a 2 consecutive infusion over 5 to 10 minutes. So this is very important to know that how to give the either rituximab. There were hypersensitivity reactions to the either rituximab, so hypertension, anaphylaxis was also seen in the trial, so we need to be aware about that. Rash that was treated with ondansetron and tramadol, and also there was another anaphylactic reaction which was manifested by respiratory distress and vomiting and loss of consciousness. Immunogenicity, so because this is an antibody, the R or is a protein, so you can find that patients can develop antibodies to it. And surprisingly, majority of the patients that were in the trial had already had antibodies to the drug itself. However, the drug itself did not interfere with the effect. It does the idarucizumab does contain sorbitol, so we need to be aware that patients who have fructose intolerance, we should be aware that we cannot use them in them because it's going to cause side effects to it. Although it's a very rare disease. Andexanet alpha, it's a dummy, so it binds to rivaroxaban and edoxaban and prevents the rivaroxaban from binding to the 10A factor. We have two trials, an EXA-1 trial, which was an RCT. Again, this is the only RCT trial that was done in patients who had reversal to the I think it was the reverse AD trial was a prospective study. This was the only RCT trial that was done in reversal agents. So patients were randomized with intracranial hemorrhage within 15 hours. Most of the patients was elderly who had atrial fibrillation. The outcome was that patients, around 13% of the patient had less expansion compared to patients who had received placebo. Although there was more thrombotic events, so 10% patients who had received andexanet alpha had more thrombotic events compared to the placebo. Overall survival was similar. And EXA-4 was the extension, so it's a single-arm study that used that looked at 352 patients who had major bleeding. Again, they were elderly patients. Again, the thrombotic events were 10%, and that's why I think maybe the andexanet alpha has a black box that whenever you use it, there's a thrombotic event warning when you're using it. And this warning is not present when you're using idarucizumab. Now the dosing here is a different. So idarucizumab was 5 grams here. According to when was the dose was given, the rivaroxaban and the apixaban, and what time was it given, and what dose was it. So we have low dose and high dose. So if you are, for example, it's not working. Okay, so for example, if your dose was, the rivaroxaban was 10 milligram, and the dose was given less than 8 hours, you're going to use low dose. But if you're using higher dose, the rivaroxaban of 10 milligrams or 15 or 20, so you're going to use a higher dose. Usually with a higher dose, you're going to start with a bolus, and then you're going to continue it up to 120 minutes, the andexanet alpha. Some of the protocols that I've seen, they recommend to finish it at 60 minutes, but most of the protocols that I'm seeing is up to 120 minutes. Again, with the andexin, as we had seen previously with the reversal to the dabigatran, there is a hypersensitivity reaction can occur, so we need to be aware about that. Okay, so now the non-specific agents. So if you don't have these specific agents, you can use non-specific agents. So we have PCC, we have a activated PCC. The differences between them is not really significant. It's APCC, you have activated factor 7. Obviously, when you have 3-factor PCC, you're lacking factor 7. Again, the dose for the PCC, you can use a fixed dose of 2,000 units, or you can use a weight-based dose. Some of the protocols, they're using 25 units. Some of the protocols, they're using 50 units. So I'm not sure. Maybe it's going to vary from hospital to hospital. There's no randomized clinical trial saying that the fixed dose is superior to weight-based or not. Efficacy, again, meta-analysis showed that PCC is effective. It's a single arm, again, it's a single arms perspective. There was one RCT that was used in intracranial hemorrhage, PCC versus non-placebo, and did not show any but there was only one randomized clinical trial. So maybe they didn't put a weight on it. As we progress, we're going to see that the PCC is still recommended if you don't have a specific agent. Now, activated PCC, which is a FIBA, is a small case series, not widely used, but still is part of the recommendation to use APCC if you don't have other agents. Okay, management of the dabigatran. So first of, if you have a major bleeding, non-major bleeding, you try to use supportive measurement, and you try to avoid using the reversal agents. But if you do have a major bleeding, you first start with either idarucizumab, and if you don't have that, then you can start using PCC or activated PCC. Similarly, in management of factor 10A inhibitor related bleeding, you're going to use indexinate alpha. If you don't have it, then you can use PCC or APCC. So we need to develop a protocol to each hospital has to have a protocol. So I just wanted to and show of hands if any of the institutes have a protocol dealing with DOAC reversal. No? Oh man. Okay, good for you. So okay, I'm going to present a protocol, a suggestion by the authors, and you can tell me if there's a difference between the protocol. Nothing في الحرس جامعة عندكم protocol? That's it.
The problem, it's not only prescribed by hematologists, it is prescribed by other people as well, you know, neurologists, cardiologists. So even if you set a protocol in the hematology, they won't be used by the other departments. And
But
this is
if
the
you have a
problem.
bleeding, does your institute have a protocol?
Exactly.
Okay.
We know about it when it is too late.
Okay. طيب. I'm not surprised, but I mean, we need to develop a protocol for this. So this is a suggestion. So if you have patients who have bleeding and you have a life-threatening bleeding, if it's not, then you see if the patient has taken the medication within the last 2 hours. If they do, activated charcoal can be used, and this can be used for either the factor 10A inhibitors or the dabigatran. Obviously, if you do have a life-threatening bleeding and it's a traumatic and within the less than 3 hours, you use the tranexamic acid. Again, if it's a major bleeding, then you start using the reversal agents, either suzumab or the indexinate alpha. APCC can be used if you don't have the agents, or you have, for example, history of VTE in the last 2 weeks. Then you try to avoid using dexinate alpha. So this is just a similar protocol. I don't want to go through them quickly because but it's one of the protocols that can use in your institution. Similarly, we can use it in CNS bleeding. It's the same idea. If you don't have the reversal agents, then you can use APCC or PCC or PCC. That's it. Thank you very much.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank the organizing committee, my chairperson, and for those speakers who hang on so far. It is my pleasure and honor to introduce Dr. Abdurrahman Al-Raiza. Dr. Abdurrahman is consultant hematology, adult hematologist from National Guard Hospital, Riyadh. He is the director of Thrombosis program and the hematology fellowship program. Please, Dr. Abdurrahman, the floor is yours.
So I will start with a case that it's not uncommon that we see in our real practice. So there is a young boy had no comorbidities, had been diagnosed with pulmonary embolism and started on rivaroxaban. 3 months later, he started to notice a black stool and his hemoglobin dropped from 15 to 10. So there are some questions that we will try to explore during the presentation. So first thing, what do we do now? Do we need to stop the anticoagulation or not? Would you reverse it? Would you consider restarting the anticoagulation? And when? And how would you prevent this event from happening again? So it's not uncommon that this patient might bleed. In fact, up to 10% they will have clinically relevant non-major bleeding, and 2 to 4% they will have major bleeding, and they differ between different type of anticoagulant with a better safety profile using DOAC compared to warfarin in all major bleeding and especially in CNS bleeding. And it's one of the most common adverse events that lead to emergency department visit, hospital admission, and death. The issue with the bleeding is that not only the complication, but it leads to a high mortality rate in these patients, especially if the bleeding is ICH. Up to 40% they will die within the first month after the bleeding. And it does not matter if you give them a hemostatic agent or not, it will have a mortality rate. So how would we manage these patients? The first thing is to prevent this event from happening. This is the first thing. And there are some principles. One of them is that not every thrombus carries a high risk for recurrence. So some thrombi, like distal deep vein thrombosis, may not have a high risk of recurrence. So may not need an anticoagulation. That's the first thing. Also, with subsegmental BE as another example, that not all of them carries a high risk for bleeding. So surveillance may be enough for them, and they do not need an anticoagulation. The second thing is that it's very important to know the natural history of different type thrombi to see what's the risk of recurrence if not treated. So we know that for major pulmonary embolism or proximal deep vein thrombosis, they have a very high rate of death. Almost 1/3 of them will die with first month if not treated. So this is the first principle. The second principle is to choose the limited duration. If you started the patient on anticoagulation, is to choose the limited duration when possible if the risk of bleeding is high. And there are many ways to predict the risk of recurrence in this patient. The most important thing is the provoking factor, which we know that unprovoked pulmonary embolism have a high risk of recurrence compared to major transient pulmonary or thrombosis. So, and there are many ways to predict the risk of recurrence of this patient. One of them is to use risk prediction models like Herdito score, DASH, Vienna risk score. Another way to use the serial D dimer that may help in predicting the risk of recurrence in this patient. So if you decided to start this patient on anticoagulation and you decided that this patient have a high risk of recurrence, what to choose? And as mentioned, DOAC probably have a better safety profile and they differ between each other. For example, rivaroxaban and dabigatran have high tendency for GI bleeding compared to warfarin. Apixaban and dabigatran have a lower risk of menstrual bleeding compared to warfarin, and tailor your choice of anticoagulant based on the patient profile. So if you decided to choose, for example, apixaban, what would be the optimal dose? Previously, we did not have a good evidence. Do we give the full dose 5 mg BID after 6 months or 2.5 mg BID until the RENOVE study was published a few months back that showed that better safety profile if you are using the lower dose of or prophylactic dose after 6 months with the same effectiveness. There are other ways or other important things that needs to be taken into account when to decrease the risk of bleeding in this patient. For example, drug-drug interaction, using non-steroidal anti-inflammatory medication, antiplatelet. It's very important to prevent this. So what to do about oral anticoagulant after bleeding? Unfortunately, it's a continuous challenge, and up to 50% with this patient will stop permanently this medication. And the evidence is coming from observational data, mostly from warfarin treated patients, and the optimal timing is not established. And there are some methodological challenges in this studies, it's observational studies with difference in prognosis at baseline. It's retrospective studies. Ascertainment of drug exposure differs between studies, and also determining the start of the follow-up. And there is one important thing, which is the immortal time bias. So if the patient will not die and will survive long, most likely he will be restarted anticoagulation. It does not mean that anticoagulation improved his survival, and there is a competing risk of death and other outcome. So what's their outcome if you start this patient on anticoagulation? Overall, there is an increased risk of bleeding, decreased risk of thrombosis, and probably decreased risk of mortality with immortal time bias. It's not really certain. And one size does not fit all. If, for example, you have ICH, traumatic ICH have less tendency to rebleed compared to, for example, spontaneous ICH. If you have lobar, they have a high tendency compared to deep thalamic bleed. And also it's the same scenario with the GI bleeding. It depends on the site, the cause of the GI bleed, and if it's controlled or not. Overall, in GI bleeding, in CNS bleeding, and all bleeding, it seems that the risk of rethrombosis decreased with the risk of bleeding higher, and improved mortality. So when to start this patient? Majority of the studies coming from warfarin, and it seems that if you start the patient with GI bleeding within the first week, they have a higher, almost double risk of bleeding. So it's general recommendation that to start them after the first week, and one size does not fit all patients. And this is a physician survey, and there is a clear wide variation in the clinical practice between them, and there is wide variation in the current practice exists among management of oral anticoagulation bleeding, also for the ICH patient. So if you started this patient on anticoagulation, if you have ICH, there is twofold increase in the risk of bleeding. There is a decrease of 30 basis to almost thrombosis, and probably decreased risk of mortality. And it seems that in patient with ICH, if you started the greatest benefit if you started within the 7 to 8 weeks after the ICH. And if you look to the guideline, for example, the American Heart Association, they made this recommendation based on very low level of evidence. They suggest that in patients with non-valvular AFib and spontaneous ICH, the resumption of anticoagulation may be considered based on weighing the risk and benefit. And in patients with spontaneous ICH, and home decision is made to start anticoagulation, initiation 7 to 8 weeks after ICH may be considered. And they made also a suggestion for left atrial appendage closure as an option. So if you decided to start this patient on anticoagulation, what type of anticoagulant you will choose? It seems that low molecular weight heparin have lower rate of bleeding compared to unfractionated heparin in general. And there are ongoing RCTs that hopefully will tell us when to start this patient on anticoagulant in these challenging cases. So in summary, if the patient has bleeding, has the bleeding stopped or not? If it's not stopped, is to give the supportive treatment and not to resume anticoagulation. If the patient his bleeding is stopped, is there any ongoing indication for oral anticoagulation? If there is no ongoing indication, is to discontinue anticoagulation. If there is an ongoing indication, to assess the risk of thrombosis based on the type of thrombosis, the site, the time, and also the bleeding risk. And at the end, it will be shared decision making with different specialty and with the patient. So, and it's not it's very important to evaluate and address modifiable bleeding risk factors in the long run. So reassess oral anticoagulation is an important part of bleeding management. Overall benefit appear to restarting for many patients. Optimal timing is uncertain. Decision should involve multidisciplinary and patient input. robust bleeding specific data is needed. And thank you for listening.
I'd like to ask the speakers to join us on the podium for quick 2 questions. Anything from the floor?
You know, with the aging of our society, atrial fibrillation has become more and more, especially in elderly patient who's prone to has bleeding, especially the intracranial bleeding. So suppose the next door you have one patient, elderly, let us say 60 or 70, and he gets CNS bleed, and you interrupt the NOAC. So when you restart, and if he has GI bleed, where is the site of bleeding? Usually the common site with the NOAC. And when are you going to start the anticoagulant again?
Yeah, that's great question. Thank you for asking. So for the ICH, it's very important to know why did he bleed. So, and is there any modifiable risk factor? Is it trauma related? Is it if there is any structural lesion? If it's hypertension related? Many things that needs to be explored before making a decision. Overall, in general, minimum 4 weeks, not to start full dose. This is my approach, and depend also on the thrombosis risk. If somebody who had, for example, a distal deep vein thrombosis, I may not even start it at all, compared to somebody who had massive PE 1 week back. But it's a very big decision. Needs to be to take into account the thrombosis risk, the bleeding risk, the recurrence of this, and shared decision with the neurosurgeon, for example. And the patient value is very important for this. And also, it's also the same with the GI. So they are not the same. Peptic ulcer different than esophageal cancer, than esophageal varices. But it's really sometimes challenging.
The time they just say, hey, it is safe only after 6 to 8 weeks. And we have to decide ourselves or the cardiologist.
Yeah, so for the atrial fibrillation, the overall, if he's having, for example, CHA2DS2-VASc score maximum, the risk is probably 15% in the whole year, risk of thrombosis. But again, you may start this patient in full dose anticoagulation and they will have free bleeding and die. So it's very important to take into consideration all of these factors.
So just to clarify that question, so in my fellowship, I had a patient who had a mitral valve, metallic mitral valve. He was 75-year-old. And suddenly he had GI bleeding, diagnosed with GAVE, and he underwent this surgical radiation procedure multiple times until the gastroenterologist told me, I cannot radiate any more area. So each time I started him on IV heparin with therapeutic PTTs, not super therapeutic, he bled. And he bled requiring 2 or 3 units of blood. And this was repeated 3-4 times across 2 months of admission. So I ended up discussing with the patient, discussed first of all with this consultant, I was a fellow. So discussing with the patient that if we anticoagulate, you're going to bleed. There's no way we're going to stop that. So what do you want? And the decision was not to anticoagulate him. So sometimes you have to go through that decision and according to the patient's wishes at the end of the day. If he says, yes, I'm still going to want the anticoagulation, I'm concerned about
stroke or that, you anticoagulate him and you live with every bleeding when he's going to come back to you. I think what we lack really in this very controversial topics, the main decision maker is the patient and his family. There's nobody who is so not educated that he will not understand. The deficiency is in us. We have to explain to the patients and relative very well the whole risks and let them fully take the decision. I totally agree if he doesn't the risk, but that's the job of the physician. Explaining to the patient, usually my patient in such controversial cases, they know as much I know about their disease. There's no exactly with the numbers, with everything. And they have to take the decision. It's that because the consequences are detrimental at the end of the day. You cannot take the risk alone. It's a very shared with the patient making the decision. It's his autonomy that we're talking about with a major role for all managing these patients.
Any other questions? Okay. Thank you.
And I have a question for Dr.
I have a question.
So, Abdurrahman, those patients who are on anticoagulation for the unprovoked pulmonary embolism, let's say he was 6-year-old, he had an unprovoked PE, he was started on anticoagulation, and the decision was made, and there was no thrombophilia, no cancer, and the decision was made that was a submassive PE, we're going to keep him on anticoagulation long term. Now he's 75 or 78, and previous data from Mark Crowther or Mark Carrier have shown that above 75, the incidence of bleeding is much higher than the incidence of thrombosis. What do we do? I'm seeing these patients and I wish to stop it, but I don't know really what's the right answer to do that.
That's a really difficult question, Dr. Ashraf. And I totally agree. We know that unprovoked thrombosis, especially in male, they have a high risk of recurrence, almost 10% in the first year and 30 to 40% in 5 years. And we know not only thrombosis will increase with the age, but also the bleeding itself. I tend to not to stop in this patient, reassess the bleeding and the thrombosis risk, discuss it with this patient and the patient value. Many patients will say, I can accept 10% risk, but I will not be happy to take a pill every day. And I totally respect his decision.
Thank you.
Well, Anizi from King Fahd Specialist Hospital at the MAM. I would like to thank you all for comprehensive talks. I have two questions, one for Dr. Ashraf and one for Dr. Abdurrahman. Dr. Ashraf, for cancer-related thrombosis, for those patients who have other thrombotic or thrombophilic disorders like antiphospholipid or inherited thrombophilic disorders, and with cancer, so is this going to change the treatment strategy of these patients or not?
So, out of all of the thrombophilias, except if you have the congenital homozygous thrombophilias, or if you have a antiphospholipid syndrome. So this is a patient that had antiphospholipid thrombotic syndrome and got cancer eventually. Not the other way around, because if somebody malignancy develops thrombosis, you shouldn't be testing for thrombophilia. So the antiphospholipid is easy, it's warfarin. That should be lifelong just to start with. Now, if he had recurrence or that, it's a question whether you increase the INR range to 3 to 4 or you add aspirin to the 2.5 to 3.5 range. I usually add aspirin. The double heterozygotes are quite rare, although once you start practicing long enough, you see I have a couple of double or homozygous and double heterozygote thrombophilias. The trend nowadays, I used to give them warfarin in these patients, but more or less the trend nowadays is doing DOACs on them. I started doing DOACs by do not drop to prophylactic dose after 6 months. As I showed you the APICAT trial, so it was an internal decision. We did it in 2014, and we were still practicing that. There are a couple of patients that we do not drop the dose to prophylactic pancreatic cancer or with thrombophilia that I don't drop. Again, this is just my experience, so take it with a grain of salt. Other than that, thrombophilia shouldn't be tested in malignant patients, but that's the practice I do.
My question, if I may interrupt, for all the speakers regarding the use of DOACs in patients with cancer, all patients actually, would you be happy to have just only protocol for the reversal or even a protocol before starting the DOAC? Because we don't have laboratory monitoring approved. We don't have available antidotes if there is a bleeding. So we have a lot of problems with the DOAC. So would you recommend having protocol or double gatekeeper before starting prescribing? Because as a hematologist, you're not the only one who is prescribing. We get consultation whenever there's bleeding complications from other department, neurology, cardiology, so on and so forth. So please.
It's a good question, Dr. Janina, and I think we should have a protocol. Every hospital has to have a protocol, and the DOAC itself should have a privilege, like a privilege for prescribing the DOACs. Not everyone can prescribe the DOAC. So this is my opinion in regards to stopping. And obviously, for cancer-associated thrombosis and the prophylaxis is usually started, and I think it should be and usually started by hematologists and stopped by hematologists. But if there are some, and I know there are in some private hospitals, we do have non-hematology who are prescribing it. My always opinion is that medical legally, if you are going to start the medication, you should be able to handle it. And this is my, I always say to my colleagues that if you are going to start a medication, then you should know how to prescribe it and how to deal with the side effects. So you can, but there's obviously, if you see that there's the prescription is not ideal, then at that moment, the administrator has to come in and provide a safety net. If you're seeing patients who are given a doxaban or a pixaban, just even for, let's say, test score of 0, for example, then it's not the prescribing, it's not the, and then he bled, for example. It's not the medication that led only to the bleeding, it's the wrong prescription itself. So there should be a protocol, there should be, but not everyone is following this protocol. This is my opinion.
So ASH 2018 and 2019, there were presentations from clinical pharmacists where in the States, they had not only have warfarin clinics, they have DOAC clinics. These patients, unfortunately, our colleagues in cardiology, they give them DOAC and prescription for a whole year, and they're going to see them after 6 months or 1 year. Now, most of the patients are elderly, and they don't have a stable creatinine or a stable diet even. So that's very risky. Clinical pharmacists are a main target for these patients to follow. Like warfarin, most of the warfarin clinics are run by clinical pharmacists. That's the way to go. We are thinking of establishing the DOAC clinics basically for clinical maximum, I think, in my opinion, 12 weeks, and they should be seen, assessed with the CBC and creatinine at least in the clinics.
So the other question for Dr. Abdurrahman. Dr. Abdurrahman, you know that patients with portal vein thrombosis or hepatic vein thrombosis, they are prone to have bleeding. Especially when they have some certain sort of or certain degree of cirrhotic liver. And you know, the approach is totally different. If there is cirrhotic, if there is non-cirrhotic, then not to mention also that these patients, they have chronic venous thrombosis that you can see the collaterals and or the ultrasound or the CT imaging. So how this will going to change your way of practice and in case of bleeding?
Yeah, that's a really challenging situation. Again, it's very important to know what's the provoking factor of this thrombosis and where is it exactly. If somebody who is having a bad Chiari, I will be hesitant to stop anticoagulation compared to somebody who had an incidental portal vein thrombosis in cirrhotic patient. They are completely different. And also the bleeding, where is the site of bleeding, and if it's reversible or not. But again, sometimes you are facing a very challenging situation, and sometimes we are keeping them only on prophylactic dose.
Are you asking about the DOACs or any anticoagulation? I mean, usually DOACs are not prescribed for unusual sites. So I would be hesitant to start that.
So Prof. Jalil is correct. There's a lack of evidence, but retrospective data, small prospective studies, single-arm studies are looking at DOACs and have been published. And the trend nowadays is using DOACs in them. And probably if you use the prophylactic dose that Dr. Abdurrahman mentioned, you'll be safer than an INR 2 to 3 in my point of view, especially that DOACs have showed less bleeding in compared to warfarin. So it's a very challenging case. Now, the gentleman from أعتقد الشرقية صح? Mentioned that you see cavernous transformation at the porta hepatis, meaning the portal vein is blocked. There are tributaries that had opened. This portal vein will never recannulate. So you don't need an anticoagulation. That was my practice previously, but then suddenly it came to my mind, you need to something to prevent the next thrombus, which could be DVT or PE. So I do what Dr. Abdurrahman does, is prophylactic DOAC in them, not full dose.
Okay, I'd like to thank our speakers, Dr. Mansour Radwi, Dr. Abdurrahman Raiza, and Dr. Ashraf Warsi for their excellent presentation, and would like to conclude this session. Have a wonderful day.
You will see you inshallah tomorrow at 8:30. We'll start our second day. Thank you.